Hello, everybody. Good evening and welcome to YCon 2021. And so we are meeting for the first time, the whole application online. And thank you for all the friends from all over the world to help us in organizing this program. I will now like to hand over the mic to start the conference.
5 minutes we have scheduled.
And then I'm going to go through the house rules, and then we're going to start our annual. Hello, everybody. Good evening and welcome to YCon 2021. And
hello, everyone.
So we are meeting for the first
dear
time,
friends,
the whole application,
colleagues,
online,
faculty,
and
delegates.
Thank you for all the friends from all over
I
the world
extend a
to
very
help us
warm
in organizing
welcome
this program.
all of you
I will
on this,
now
the
like
14th
to hand over the mic
YCon 2021.
to start the conference.
Now, these are indeed
And then I'm
exalted
going to
times,
go through the house rules.
and
And
to borrow a
then I'm
phrase,
going to start
these are the best
our
of times and the worst of
virtual
times.
YCon
The worst of
2021 meeting.
times because obviously the pandemic
Very-
and the million problems hello everyone thrown at us, dear friends. But the best of times because we have responded with 1,000,001 and delegate resolutions. I extend a very warm welcome to all of you who have been on this. Now these are indeed physiology, especially for us phlebologists. To borrow a phrase, importance of thrombosis. These are the best of times and how to treat. Treatment keeps changing. The worst of times because obviously the pandemic. So that's really and the million something to be problems that it has thrown at us, especially the scientists. But the best of times because we have responded with 1,000,001, which includes this present resolution, the Venous Association, have risen to the challenge, and we have not. Who have been some of them have been very active. And problem of not meeting each other to come in the way of interacting with each other, and especially for us phlebologists. And I'm so happy that we have learned so much. We and how to treat treatment keeps changing every day. The families and how to prevent with ourselves. And then of course something to be using for all doctors, especially get to each other and to overcome the problem. Now all our associations, the organizing committee, doctors, my colleague, Dr. Association, the Venous Association, and have risen to the challenge, and we have wonderful program, and we have had so much support from our friends. Problem of not meeting each other to come in the way across the continent with each other. Of course, so this is a brave new world. And I'm so happy that we have learned so much. We program is how I do it. Not only do we have these the meeting with ourselves and then pioneers who will tell us the correct way of doing things. But we have also included people who are pushing the envelope. So we're looking at the committee, doctor, my colleague, Dr. Rao, and our aim is to, for the youngsters, aim is to have produced together a wonderful program. And we have had so much support from our friends and to encourage basic research from all across the continents. In this conference, we should be, and I'm very confident that we will be this successful. Is at least to some extent. Not only do we have achieve our goal. The leading, once again, the pioneers will tell us all of you and let us. But we have also included people over to you, pushing the envelope. Thank you. So we're looking at the future.
Thank you, Dr. Bedi.
And our aim is to
welcome my friends from all across
scientists, surgeons.
I'll just go through some rules
and to
so
encourage basic research, and hopefully
the whole meeting is
in this
English.
Conference we should be, and
there
I'm very
be
confident that we will be
people
successful
on the panel,
at least to some extent,
the speakers and the chairpersons
and so I once again warmly welcome all of you, and let us get on with the program.
So there is no
over to you, Rahul.
Speakers.
Thank you.
Also, thank you, Dr. Bedi. All the presentations, as you can see from the program, welcome my friends. They are around 7 minutes. The continents. So all are run as an MP4 some file because so that we don't waste time in changing the whole meeting is in English. So from starting, we will introduce all the chairpersons. There will be approximately 25 people. Mr. Tarun is there. He's the media in charge. The speakers he's and going to run one presentation at a time. Past presidents of the Venous Association. The chairpersons can ask. So please 1 to 2 questions to the speaker. So there is no disturbance to the speakers. So if we are exceeding more than 2 minutes, all the presentations that you can see from the programs, they are around 7 minutes. We'll be interrupting you. So all are run as an MP4 time file. So that we can run the program so that we don't waste time in changing the content. Second is, once we finish this, we'll hand over all the, we will introduce all the things to the chairpersons. And then once your session finishes, Mr. Tarun is there. He's the media all the chairpersons. He's going to run downgraded one presentation at a time, visual. So you will be able to, chairpersons can ask visualize everything, 1 to 2 questions, but you will not be able to after each pass the comments here. So you can also join from our website in the each talk, as a as a delegate. Sorry, we will be, and it's seen as that you are sitting in a hall, and you'll be able to see the whole, so that we can run the program on. There are approximately 500 delegates. Second is, once we finish this, we'll hand over all the from all the across the chairpersons. So once your session 600 people will be online. Please, all the chairpersons, you will be downgraded as, so we will not be able to take. So you will be able to all the questions visualize chat. I'm really sorry, but you will not be able to. We will try to pass in all these questions. You can also join from our website in all that as a question answer, as a website, so that you can view seen as that you're sitting in a hall, and you'll be able to see the whole. Second is, we have changed the platform because approximately 500 delegates for 5 hours is very boring. So what we have done is all across the world, as the Venous Association of India, we have changed 600 people will be online. All the meeting is how I do it at a given point of time. All will be procedural. So we will not be able to how different all the questions in the chat. I'm really sorry how we do it. What we will watching the videos, all these procedures is much from the chat to the speakers, and we'll try to put in slides that as a question answer on our website, so that you can view presentations will be in the video format of how to do the procedure. Second is, we have changed the platform because sitting online on the computer for 5 hours is very boring in the world. What we have done is, as the Venous Association of India, we have changed the platform. I will introduce all the meeting is how I do it. Our chairperson, all will be procedural videos. How different people from China, the techniques, how we do it. By which, watching the videos of the procedures is much easier and Dr. Nick Morrison rather than the data slides. So 95% of all presentations will be in a video format of how to do the procedure. Dr. H.S. Baby will make from the live slightly more interesting, and you will be able to see Gupta, the best operators in the world, how do they operate. Vascular Society of wasting any more time. So I will introduce previous senior chairperson, college, Dr. Jinston Wang, Dr. P.C. Gupta. She is from China. Dr. Sarvanan, past president of India, Venous Association of India. Dr. Malay Patel, she has joined. Also past president of Nick Morrison of India from USA. Dr. Roy Varghese, past president of Dr. Venous Association of India, and from Tajikistan. He's from CNC Baby from India. In Oman. So we'll start with the first lecture. He's the president of, I will invite Dr. Dhanesh Kamarkar, Vascular Society of from India. So he's going to present us a case of previous senior from my college with the latest biolytic machine. Welcome with 1940 nanometer laser. Dr. Sarvanan, past president of India, Venous Association of India. Dr. Malay Patel, everybody. He's also past president of Venous Association of India. Dr. Roy Varghese, Association of India. Thank you so much. President of Venous Association of India. And Dr. Edwin opportunity to share experience on 1940, but presently is working in Oman. I might have to give a live commentary because when I realized the audio quality of the video clip he's a vascular surgeon wasn't great. From Pune, India. So he's going to present us a case of varicose veins with the latest biolytic machine with 1940 nanometer laser. Tarun. Good afternoon, everybody. Rahul and Harinder and Venous Association of India, thank you so much for inviting you an opportunity to share experience on 1940. I might have to give a live commentary because when I realized the audio quality of the video clip wasn't great. So please excuse me for that. Is it being played?
No.
Good evening, everybody. At the outset, would like to thank Venous Association of India for giving me an opportunity to share my experience of using 1940 biolytic laser for ablating varicose veins. So I'm going to show a short video of using the 1940 biolytic laser. So, good evening, everybody. Audio from the video clip is not audible, so I just give a live commentary. Here's a lady. We did a laser ablation of a long saphenous vein, and she had presented to us. For am I audible?
Yes, yes, you are.
So, doing varicosity a month ago. Varicosities were in the distribution of long saphenous vein in using 1940, and I treated her with anticoagulation for 4 weeks. So and we took her for laser. I'm sure the audio from the video clip is not audible. Here we're using 1940.
Курточки снимите, я сразу их отдам.
We did a laser ablation of a long saphenous vein.
Yeah.
And so generally, I do all my laser ablations under local anesthesia. She presented with thrombosis varicosity a month ago. Always have an standbyization of long saphenous vein in the lower thigh, anxiety, and I treated her with anticoagulation for 4 weeks this year. So we took her for laser ablation of long saphenous vein. Here we're using 1940.
Курточки снимите, я сразу их отдам.
In the next clip,
Молодец, пойдем, покажи, да? Ира, покажи, потом наденешь.
Generally, I do all my local anesthesia, where we use, of course, ultrasound machine and the Venous pump. I always have an anesthetic standby just in case some of the patients, because of anxiety, give some sedation. And this year, I was just showing saphenofemoral junction incompetence here, as well as here is thrombus varicosity here.
Молодец, пойдем, покажи, да? Ира, покажи, потом наденешь. Сколько у нас?
Here you can see.
Это возьму. Да, подожду.
And anyway, we did a saphenous vein puncture to some guidance. Give anti-telegraph position to the vein nicely, and then we punctured the saphenous vein in the upper leg under USG guidance. Thrombus varicosity here. Put the sheath in while thrombus bring the fiber all the way up to saphenofemoral junction. Just stopping
Да, подожду.
2 centimeters away from SF junction. So anyway, so the key here is ultrasound guidance to have a accurate location guidance of the laser fiber. Give anti-telegraph position to the vein nicely, and then we puncture. We're puncturing saphenous vein under USG guidance. Put the sheath in, wire and sheath, and then get a laser fiber in and bring the fiber all the way up to saphenofemoral junction, just stopping 2 centimeters away from SF junction. So the key here is ultrasound guidance. So with under local anesthesia, we puncture the saphenous vein of the USG guidance fiber, and get the wire in and over the wire sheath. So we're puncturing saphenous vein and through 5' sheath. We put the laser fiber. So with under local anesthesia, we puncture the saphenous vein under USG guidance. See the blood flowing out, and then get the wire in and over the wire. Our protocol is to use sheath, radial 5' sheath. We put the laser fiber. So that's the wire going in, and get the sheath in, and through the sheath we get the laser fiber. So once the advantage of being under local anesthesia, the blood flowing out, and then get your set in. So our protocol is to use the room radial touring. So that's the wire going in, and get the sheath in, and through the sheath we get the laser fiber. So that's our protocol. The advantage of 1940 nm under local 8 watts energy, the fiber is going in, and then give Jameson's anesthesia all along the length of saphenous vein. Here you can see actually is going into one of the varicosities. And you need a little bit of repositioning of the laser fiber with some manual external pressure and trying to guide it into the main saphenous vein, and now it's going right up to the junction. I always like to mark these veins before the procedure. So that's a protocol. Here's 1940 I got into 8 watts energy. The fiber is going in, and you bring the fiber anesthesia all along the length of saphenous centimeter. Here you can see actually it's going into one of the varicosities, and you need a little bit of repositioning of the laser fiber with some manual external pressure to guide it into the main saphenous vein. You Jameson's anesthesia all along the length of the junction. I always like to mark these veins before the procedure. These are the settings, and you can see the Jameson's. It's a kind of habit I got in all around 360
We reconfirm the
position
of fiber,
and you bring the fiber stopping the vein short of 2 centimeters from the SF junction, and then
now we are giving Jameson's anesthesia
8 watts and 60 joules
along the length of the long saphenous vein.
Give a Jameson's anesthesia all along the length of the vein. Once the Jameson's anesthesia settings is completed, so Jameson's, then
drawing the
fiber,
we reconfirm the
position of the fiber 1 centimeter every time after the heat from the vein. So a supplement to the machine now, which can automatically withdraw the fiber 60 joules. We don't have it. And after every beep, withdraw it by a centimeter. And as you come very close, once the Jameson's anesthesia is completed, upper third of leg, then
drawing the fiber
ablation is started. Now would cross the saphenous vein of 1 centimeter every time after the beep. Laser ablation of vein could have effect and damage the saphenous nerve. That can cause unpleasant. So a supplement to the machine now, which can automatically withdraw the fiber. So we stop. We don't have it around in upper third of the leg. And after every beep, withdraw it by a centimeter. After the procedure, as you come very close to here, low molecular weight heparin, enoxaparin, 0.6 or 0.8, depending on the weight of the patient. And here we are showing the obliterated vein, long saphenous vein. All along, almost 95 to 98% of the time, patients are very comfortable. They tolerate the Jameson's anesthesia because of very fine needle, and because of the pump, we can give Jameson's fluid under pressure. Again, advantage of 1940, there is no carbonization of laser fiber here, what we have seen as compared to 1470, where we used to see carbonization of the laser fiber. The advantages of this machine, of course, pain quotient is lesser. We have seen less of ecchymosis or bruising after this procedure. The tolerance and acceptance of these 1940 laser fiber is better as compared to that. Even many of the times using 1470, people used to feel cord-like structure after the saphenous ablation, but here we haven't seen that happening with this 1940. Again, pain is less. Again, the ecchymosis is less. And generally, we wouldn't recommend any compression stockings to these patients following the procedure, except sometimes I have advised compression stockings in a very huge long saphenous vein measuring around 10-12 millimeter. Other than that, we wouldn't give any compression. Again, they can walk back.
That's a lady walking back
the
after
patient
the
going walking
ablation.
back to the
They are happy with the results. This is a protocol radial tubing, no compression after therapy.
It was
Jameson's anesthesia
continuous fiber pullback.
either LSP
Painkillers sometimes in case of pain, I generally put them on rivaroxaban 10 milligram once a day for 5 days as an anticoagulant.
On a signal mode.
And other than that,
laser ablation
SOS basis
anti-inflammatory. Sometimes painkillers in case of patients go back and mild no rest is required. And all our patients have tolerated this under local anesthesia very well. If you look at this, 40 times higher absorption, 40 times higher absorption, water is 1470 as compared to 980, and also 41 has a 40 times even more higher as well than 1470. But the occlusion rates are similar. Complication rates are similar. There's no difference in pain separately, but ecchymosis is much less. Feeling what bruising is much less. In fact, the pain quotient-wise has been seen so far. The tolerance of this ecchymosis and bruises also are much better as compared to pain quotient and 70 levels. So far, so good. Much better as people patients have been happy with this 1940 and laser fiber. So we have already discussed there's no more risk of fiber carbonization. If you look at the pain scores over 10. Thank you.
Chairpersons, if there are any questions, please to Dr. Dinesh. We can take one question, so we have run over time. So if we can have one quick question from the panelists, please. Any questions, please?
So Dhanesh, good presentation. So finally, what do we conclude? That you are saying that there are actually no difference between the two. Is that correct? Clinically?
So clinically, no. The pain-wise, they're much less pain. There's hardly any ecchymosis or bruising, and at times you all must have seen there's a cord-like feeling in the saphenous vein following 1470. So far, we haven't seen this. Seen almost about 4 or 5 months ago. But other than that, there's no cord-like feeling. So definitely seems to be better than 1470. But in a longer run, more number of patients will tell me, if you compare it, the results with 1470 and 1940, how good or how bad, or are they equally good? So, so far, I would say, the results have been better.
Thank you.
With this machine, we have done about, I think, 20 odd laser cases. 1470, I've done about maybe 300, 400 cases, maybe more also.
Yeah.
Okay.
Yeah. Thank you, Dhanesh.
Thank you so much.
It was fantastic. And Tarun, can we move to the next lecture, please? Dr. Ahmed Gavesh, all the way from Egypt. Thank you, Dr. Ahmed, for joining us. He's here on the panel, and he's going to talk about laser crossectomy.
Thank you, Rahul. It's a great pleasure to be with you. Great pleasure and honor to be with you in the 14th VICON 2021 meeting. I'd like to thank all the organizing committee, our dear friends from India, for being so active. Hello, everybody. It's a great pleasure and honor to be with you in the 14th VICON 2021 meeting. I'd like to thank all the organizing committee, our dear friends from India, for being so active and for a very nicely organized meeting. We are always happy to be among our friends from India. So, back to the classic state-of-the-art vein surgery, there is no doubt that crossectomy is the term to describe properly done high flush ligation of the saphenofemoral junction with ligation of all junction and tributaries. And there is no doubt too that radical, well-done crossectomy results in the shortest stump, leaving the shortest stump behind and the lowest duplex reported recurrence. And the recurrence post-surgery most commonly occurs due to inadequate crossectomy when not done properly, or due to neovascularization arising from surgical trauma itself. On the opposite side, endovenous thermal ablation, when we were taught in the early days that we should leave the 2 centimeter distance from the junction untouched to avoid heating the deep venous system and preserve the epigastric vein patency. That resulted in leaving longer stump with endovenous thermal ablation together with patent tributaries at the junction. And looking to anatomy of the saphenofemoral junction, when this interesting study analyzing the distance of different tributaries from the femoral vein, if we look at the superficial epigastric vein, most of the superficial epigastric vein lies 1 centimeter away from the femoral vein, while for the anterior accessory saphenous vein can be 1 or 2 centimeters away from the junction. And actually obeying or going with the rule of leaving the 2 centimeter proximal stump unablated with laser would result in leaving behind many anterior accessory saphenous veins untouched. And that's not surprising to find that the most common recurrence after endovenous thermal techniques is junctional tributaries recurrence, namely the anterior accessory saphenous vein, while neovascularization is not a big deal with endovenous thermal ablation, as we know. So in 5 years follow-up of high ligation stripping compared to laser, we find that same site recurrence is much more significantly more after thermal ablation rather than surgery. So it's really long-term anterior accessory saphenous recurrence higher after thermal ablation. Thomas Propstel looked at this long-term study. He found a very interesting finding that 55% of patients with previously unrefluxing or non-refluxing anterior accessory saphenous vein during great saphenous vein ablation after laser compared to high ligation stripping, and most of the recurrences were due to anterior accessory saphenous vein developing reflux. So it seems that leaving a long stump and untouched tributaries is the main cause of recurrence after thermal techniques. But is there anything we can do about that? As optimization occurred over the years for surgery, it occurs again with thermal ablation. Nowadays, I doubt that anybody would go measure 2 centimeters from the junction as previously advised. Some people go with 1 centimeter being easier to see the superficial epigastric vein on ultrasound. So they modified their technique, and others, like our experience, we went through the infraepigastric site location of the tip before starting ablation. Of course, what helped us is the presence of radial firing lasers. So we are going to the trend. The trend is towards leaving shorter stumps. Also, we do accessory vein ablations as we do for the great saphenous vein. We cannulate the vein and ablate both veins successfully simultaneously. So that brings us to the term laser corsectomy, which is the endovenous equivalent of traditional, properly done surgical corsectomy, which aims to close the saphenofemoral junction as close as possible to the femoral vein and close all potentially descending tributaries, which may be causing recurrence later on. How I do it, I use 1470 ringed laser firing fibers, tip of the laser infraepigastric. We do separate cannulations for the accessory veins with 16 gauge cannulas, inject tumescent anesthesia in copious amount around the junction, and then ablate the great saphenous vein followed by the accessory veins and give prophylactic rivaroxaban for 5 to 10 days off-label indication to all our patients. Going with this way, we treated more than 2,000 legs with 1 week follow-up duplex. We had no significant E-hits. DVT developed in 3 cases, but none of them related to the femoral vein. They were actually related to simultaneous perforator ablation when done, and those patients were treated by therapeutic anticoagulation. So yes, corsectomy can be achieved by endothermal techniques as well, but one question remains though. If we should close anterior accessory saphenous veins, whether they are refluxing or not, This remains debatable. However, there is an interesting study by Professor Raj in which he introduced the catheter and did flush laser crossectomy, introducing his and the laser catheter at the junction. So he compared two groups of patients, one with the technique of flush laser crossectomy and the other infraepigastric positioning, and he was able to show that significantly lower anterior accessory great saphenous recurrence in 2 years follow-up, significantly lower with laser crossectomy, with flush laser crossectomy, rather than infraepigastric positioning of the laser fiber. So in conclusion, ladies and gentlemen, laser crossectomy is a strategy aiming to minimize groin recurrences after thermal ablation, and we should all revise the distance previously advised by manufacturers in the early days of the thermal ablations. Whether we should go for routine prophylactic ablation of non-refluxing anterior accessory saphenous veins remains questionable, or we should adopt the flush laser crossectomy as advised by Professor Raj, and if that would affect the number of groin recurrences, this remains to be explored in future studies. Thank you very much for listening and have a great day.
Thank you, Dr. Ahmed. I'm sorry, there was some hitch in the IT thing, and there were some slides which were not very clear. We are trying to sort that thing out from the back, because in some computers it's very clear and in some computers not. So Tarun, can you just please look into it while we are sorting the question answers? The talk is to the panelists, please, if you want to ask any questions to Dr. Ahmed Kavesh.
I doubt there will be any questions with these hazy slides. Actually, it was too hazy on my computer too.
Dr. Lowell, you want to ask any question? Can you unmute your mic, please, Dr. Lowell?
Thank you very much for the privilege. Ahmed, thank you very much for that informative lecture. But I ask you the question, does all recurrences lead to medical necessity for intervention? And how many patients do you have to treat with a high flush ligation in order to take care of one patient for medical necessity?
Thank you, Lowell, for a great question, as usual. So it's medical necessity. About medical necessity, it depends. Of course, not all patients suffering from recurrence, from clinical from duplex recurrence, actually have clinical necessity to perform an intervention. But especially that we know that, as shown in the slide, if it appeared that a quarter or to 50%, which is quite patients we do great surface of vein ablation for, actually get recurrent in the anterior accessory within 4 years. So that's quite a lot of patients if we just rely on duplex recurrence. But however, we still have some patients from this 50% that would actually need intervention because of their veins coming back or for their symptoms hitting back, but definitely not all patients with just duplex showing recurrence in the anterior accessory saphenous would need intervention. So how much of that has not been studied, how much patients we treat with clinical necessity, that needs to be looked for, actually.
Thank you. And now we will go to the next topic, please. Dr. Deepak Salvaraj, he's the consultant surgeon from CMC Vellore, and he's going to talk about MOCA, how we do it. Tarun, please.
Good evening, friends. It's always fantastic to catch up This is a quick video.
Mechanical chemical ablation using phlebograph. That's the catheter that you see. We flush the catheter first, then look at the vein with an ultrasound, inject local anesthesia. The entire procedure is done under local anesthesia. An 18 gauge needle is used to puncture the vein under ultrasound guidance after giving local.
Sorry, there's something wrong with the video. I think it's kind of stopped.
Deepak, can you share the screen? Is the video on with you? Because we got this video last minute, so we didn't have the time to check up. Deepak?
Okay, it's
Mechanical chemical ablation using phlebograph. That's a catheter that you see. We flush the catheter first, then look at the vein with an ultrasound, inject local anesthesia. The entire procedure is done under local anesthesia. An 18 gauge needle is used to puncture the vein under ultrasound guidance after giving local anesthesia. Wait for the back bleed of blood. The needle has to be into the lumen. Then you pass in an 018 wire. The wire has to go very smoothly. Once the wire has gone in, you have to pass in a sheet. It is usually a 7 French sheet that we use. Pull back the introducer. Then you check if the sheet is inside the vein. Aspirate, look at the blood, flush it back. Make sure there's no air when you flush. Then you pass the 018 long guide wire. Check with the ultrasound. Go to the saphenofemoral junction. Look at it both transverse and longitudinal direction. You should be able to see the wire come in there. Can you see the wire? The wire goes right into the junction, but pull back the wire. The wire should stay right at the junction. And then you pass in the MOCA catheter. The MOCA catheter passes over the wire. Take the catheter all the way up to the saphenofemoral junction over the wire. Always keep looking at the junction. Once you're there, pull back the wire. Make sure the catheter is around 2 to 3 centimeters from the junction. Pull back the catheter. There you can see the catheter. And I'm pulling it back. Make sure it is 2 to 3 centimeters from the junction. It's very important. Now is a very important step. Push the catheter in or pull back the sheath and fix the sheath. What happens now? The sharp tentacles are released. You can actually see the catheter end there and the tentacles getting released like an umbrella opening up, the spokes of an umbrella. Confirm with an ultrasound that the tentacles are released. catheter ends, end of the catheter and the tentacles being released. And next step is to prepare the foam. Once you prepare the foam, you take 5 cc or 6 cc of foam, connect it to the catheter, inject an initial 1.5 cc so that it fills the catheter. Once that is done, you will have to retract the catheter 5 centimeters at a time. 1, 2, 3, 4. There you see the catheter being retracted. As the catheter is being retracted, every 4 centimeters, inject 1 ml of the foam. The catheter, twist the catheter at the same time. Gentle twisting. We do a gentle twisting as well. Keep doing the same procedure. Catheter scratches against the vein wall and compresses the vein wall. There you see, that's what happens when you retract the catheter. The spokes come out.
Well,
then you home.
Thank you.
That's very simple procedure, straightforward procedure, and then you follow it up with the.
Thank you. That was a very short video of a very simple, fairly simple procedure which can be done under local anesthesia, and the prongs which get released tease the intima and cause narrow the vessels, and then you inject the foam. We found very good results which are comparable. There's an ongoing study that's going on in our department, and we are almost at the ending the analysis, and we found that pretty good results when it comes to patient satisfaction, and venous severity scores are very good, comparable to thermal and non-thermal as well. Thank you.
Any questions from the chairpersons, please?
Deepak.
Yes.
Deepak, hear me.
Yes, Dr. Sarun.
Very nice video. I can see your puncture just above the knee. What do you do below knee perforator? What do you do?
I think this is a very good question. This is one technique where you can actually puncture as low as possible. You won't injure the nerve at all. But in this specific case, we didn't find a good vein. It was in spasm, and there were multiple small tributaries below the knee, and so the saphenous vein was actually forming in the fascia just above the knee, and that's why we had to go above the knee. But you're absolutely right. This is a technique where you can go as low as possible. There are many patients where we puncture just above the medial malleolus, and we kind of form the whole vein right from the groin up to the ankle, and there's absolutely no chance that you can injure the nerve as well.
Please, can you have all the mics off, please, at the back, everybody? Please, it's a request.
Deepak, a question, Deepak.
Yes.
Do you need compression after you finish ablation?
Yes, actually, that's part of another ongoing study which we're doing, compression or not compression. But at the moment, our protocol is to give compression.
Okay, because it has been touted as one of the advantages that you do not need compression.
Yes, yes. But at the moment, we're just doing a study as well at the same time to look into whether we actually need to give compression. But what we're doing at the moment is we are giving compression bandage to patients who are not enrolled in the study. So that is our standard protocol, to give compression as well, because this is a fairly new modality, and we're not really convinced whether compression may not be necessary. And we found that the recanalization rates are slightly higher, and their patchy recanalization is always present. And but the patient is very satisfied. He doesn't have symptoms, so there is somewhere that we need to strike the balance between thermal and non-thermal ablation.
Yeah.
I agree with you. We might not need to give compression, but at the moment we are actually giving compression.
No tumescent also?
No tumescent at all. No tumescent, just a local anesthesia, just a single puncture, and the patient actually can go home. But patient selection is an important part of it. If you have multiple varicosities which you need to foam or stab, then we tend to, if the patient is very sensitive to pain, then this might not be a great procedure. But patients who have very little varices, a lot of symptoms, and younger patients or elderly patients who can't have anesthesia, fantastic to have this. We're actually looking at whether we can have more prongs than just 4, and you can have complete endothelial injury, which can bring the vein into spasm. Maybe that can reduce the recurrence rates, recanalization rates.
We need to move on, Dr. Bedi, please.
Yeah.
And we can.
Thank you, Rahul.
Thank you, Deepak. And now we got a very interesting lecture by Dr. Paula from Uruguay on microphlebectomy.
Hello, everybody.
Yes, Tarun, we can play it, please.
Is of ambulatory phlebectomy, how we do it. I have no financial disclosure or conflict of interest to declare. And this is our vein center in Uruguay. It is a branch of Naples Cardiac and Endovascular Vein Center, Naples, Florida. We follow the same protocols. Dr. Julian Javier is the director. And we have performed as well a lot of phlebectomies, hundreds of phlebectomies since 2006 at his hands-on academic and humanitarian activity. So ambulatory phlebectomy is an effective, safe, and non-expensive technique with excellent cosmetics results. We can perform this in an office setting. We use local anesthesia, Sumesen formula, plain formula, and the incision are small. The procedure is simple and well tolerated by the patients, and they can ambulate after the procedure immediately. The veins disappear after 1 hour procedure in an office setting, so the patients loves it. Indications, we can treat varicose venous tributaries, but also reticular veins. And I love to perform the microphlebectomy to reticular as well. Contraindications, there is no contraindications, but it's important to avoid lipodermatosclerosis areas and to avoid knee and ankle areas as well, because there are more small nerve branches that can be damaged by the hook. There is some tough cases with patients with prior phlebitis or previous treatments. So I try to avoid those patients as well. And of course, be careful with saphenous and sural nerves. So the technique, first of all, must have a duplex ultrasound of superficial and deep system of lower limb and pelvic. The exam should ideally be done in a standing position. And with the ultrasound findings, we create a vein map, diagnosis, and treatment plan. So Bolshin varicose veins can originate from different sources. Identification of the source is important, and also to treat the source first is important, with laser radiofrequency from depending of the vein. So we treat the great saphenous vein, the small saphenous vein, or the neovascularization, so the source. At the same time, we are performing the ambulatory, so we do this the same day. So the technique, what we need, or our tool, what we need the tumescent anesthesia, 16 or 18 gauge needle. This is for the incision or the blade, the hook, and the hemostat. These are my tools. So here is a little video of our table, the tumescent anesthesia, and then the blade or the needles, and the crochet hook, and the vascular solution device, which I think is a very interesting device, and I love it as well, and the two hemostats. So this is all what we need. This is all what we need. The step of the technique. Preoperative marking, we mark the patient in a standing position, and then ultrasound line to connect the dots. The local anesthesia preparation, the tumescent, we follow so this is our formula, is the claim formula. The maximum recommended doses of lidocaine is 35 to 45 milligrams per kilograms. And the procedure, it's important to treat the entire vein. So every patient is different and may need ablation or form of neovascularization to treat the source. And during the procedures, the phlebectomy, it is important to be persistent because the retaining segment may lead to phlebitis, recurrences, or staining. So here are some pictures of the steps. So first, mark the patient in a standing position. Second, lidocaine and tumescent to the skin area. And these are in the third picture, these are our tools, the hemostat and the hook. And here is a little video as well of the procedure itself. Here the patient had a great saphenous vein insufficiency. We treat this with thermal ablation, with radio frequency. And this was our access. Then next step is to do the phlebectomy. We inject the dots with the lidocaine, a little amount of lidocaine, 1%, and then we inject the tumescent until have orange peel appearance skin. And the incision is with the needle, in this case, only 2 millimeters, so no scars. And then with the hook, here we use the crochet, It's important to expose the vein, and then with the hemostat, we pull it out with small, gentle movements. Sometimes there is a small segment that we can pull out, sometimes big segments, but it's important to be persistent with the technique and also to have a Trendelenburg position of the table for less bleeding. So after the procedure, we wrap the patient with 3-layer compression bandage in place. We put pad at the pressure points, and we follow up the patient 2 days after the procedure for dressing removal and ultrasound. And the patient may need sclerotherapy or more phlebectomy in another visit for small veins. So complications are rare, less than 0.05%. Hyperpigmentation, matting, seroma, these are things that we can see. Seroma is really rare. Transient paresthesia, superficial phlebitis, blistering. So it's important to avoid tapes. Indurated areas at the incision sites or film subcutaneous inflammatory nodules are self-limiting and are common. I see this very frequently, but all are self-limiting and disappear after several weeks or months. And infection is rare. These are some of my cases in Montevideo. So thank you very much.
Thank you.
Hello, so thank you very much.
Any questions from the chairpersons, please?
Just one question. Do the patients have a lot of pain while you give in the tumescence?
Hello, thank you. First of all, thank you for the opportunity and the invitation to be here. It's an honor and congratulations. It's really nice Congress and to see all of you. There is no pain. This is one of the most interesting things of this technique and also one of the 6 basic features that it has. It's no pain, only it's a 20 gauge needle first. I inject lidocaine and then the tumescent. The patient never complained, maybe some, but not pain. No pain during anesthesia.
Thank you.
Thank you for the question.
We got a question in the chat box, Paula, from Dr. Kushal. Please, which hooks you are using?
Yeah. I love one that I saw it at there is the vascular solution is a hook with the crochet and the hook is, but if I don't, so the crochet could be the Varady. I like the Varady as well. I like the crochet, but this one, the vascular solution that has the crochet hook in one side and the needle in the other is one of my preferred, and the one that I use the most.
Sure, thank you. Now we thank you, Paula, for joining us from all the way from South America.
Yes, thank you very much for the invitation. Congrats.
Thank you. And now we go all the way to Russia. Professor Evgeny Shodak is going to speak on glue closure live in a case. Tarun, if you can the video, please. Yes, please.
Hello.
Good evening, dear friends. Nice to meet you again, and of course, great honor for me to be a part of the team today. Glue closure, life in box case. Within the last 2 decades, the treatment of incompetent truncal veins was revolutionized by the introduction of minimally invasive and the venous thermal ablation techniques, which led to excellent long-term anatomical success rates. That is why we found it most interesting and relevant from a practical point of view to study the Russian developments of glue composition and try to identify the most effective of them in order to implement the everyday phlebological practice. Having analyzed the detail all the Russian developments presented to date, we have come to the conclusion that sulfacrylate adhesive compound can be used as a potential occlusant of non-thermal obliteration of varicose veins. The Russian adhesive sulfacrylate was synthesized at the beginning of the 21st century, in contrast to foreign analogies of based on ethyl ester of alpha sulfacrylate acid, not butyl. 2 additional plasticides were added while reducing the inflammatory reaction due to an additional substance. In 2010, it was registered and approved for use in Russia. The main purpose of our presentation is to show how we use Russian glue in daily practice. Ultrasound diagnostic to allow us to measure the diameter of the great or small saphenous vein. In this case, the diameter of the vein is approximately 1 centimeter. It's incompetent great saphenous vein. The patient, 42 years old, with the varicose veins, C3 CAP classification. Saphenofemoral junction, 1.2 centimeters, as you can see. The delivery system of Russian glue is very, very simple. As you can see, it's a standard function of the great saphenous vein. Introduce a 6 French, and additional, it's a Russian glue, 1 milliliter in the gun. We don't need, it's a fluid form, so we don't need the additional gun to use Russian glue. As it's the delivery part of delivery system, it's an additional dilatator with a specific chemical structure. Why specific? Because one of the problem of the glue procedure, it's a glue setting. As you can see, the drops of the glue, and then after pause of 10 minutes, we change the glue gun and repeat the procedure. And you can see no problems with the glue setting. We use the additional dilatator with the glue inside. And the place of the glue injection, in this case 2 centimeters, saphenofemoral junction before the femoral vein. You can see the method of the using Russian glue is continuous remove. You see some lines, 5 centimeters between them, 0.1 milliliter for every 5 centimeters of the vein. And when we see the marker of 3 lines, as you see, 1 centimeter before the introducer, we remove it and pick up from the vein. No problems with the fat. And then assistant press the saphenofemoral junction, and we press all the great saphenous vein for approximately couple minutes. The situation inside the vein, it's a glue with some blood, it's some stuff. As you can see, the distance from the femoral vein from saphenofemoral junction is about 2.5 centimeters in front of the femoral vein. And the occlusion of the all great saphenous vein. What is inside? It's occlusion of the great saphenous vein. No any blood flow inside, as you can see. And the next video will be the next day. It's the first day after our procedure. Their advancement, it's one of the big problem of the glue injection. So in our case, the advancement was 1 centimeter. So the distance from the saphenofemoral junction, 1.5 centimeter. And the first day was 2.5 centimeter. So the advancement, no problem to advancement into the avoiding problems with the deep veins. Developed in Russia, sulfacrylate glue was even lower viscosity and higher fluidity, approaching the water fluidity, or more precisely, thin syrup quality. Fundamentally new formula of sulfacrylate alpha cyanacrylic acid diethyl ester increase adhesiveness of the glue composition, enable to avoid the potential complications. While following the glue injection technique, we did not observe the problem of glue setting in the delivery system. Extremely high adhesive properties of the glue, together with its low viscosity and elasticity, allow avoiding problems with the possible advancement of the glue into the deep vein system. Conclusion. Cyanacrylate adhesive embolization of incompetent truncal veins using the Russian glue sulfacrylate is a safe and effective procedure. The high adhesive ability of the glue continues of the absence of extension into the deep vein system. The glue is biodegradable. The Russian glue is a low-cost treatment which can easily be performed as an office-based procedure. Thank you very much.
Thank you, Professor. Any questions, please? We got one question from the chat box. Is do you know what is the polymerization time for the glue?
The polymerization time of the glue is approximately 1 minute or shorter.
Okay, thank you, Professor. Any other questions from the panel, please?
Hello, everybody. Nice to see all friends
Hi.
on this beautiful conference, and congratulations to Indian colleagues. Thank you very much, Professor Shaidakov, for this excellent presentation. My question is, can we use the delivery system for 2 veins or for 2 legs, for example?
No. It's, of course, our dreams to use one delivery system for many patients. It's impossible because we can't to sterile this system for the next patient. Only one procedure for one delivery system.
I mean, can we use this one delivery system for 2 veins in 1 session?
Yes, of course. If we would like to use this system for great and small saphenous vein, it's possible. And if we need to use the glue to close the incompetent perforant vein, it's possible, of course, in 1 procedure, in 1 operation.
Thank you.
Thank you, Professor. So if we'll move all the way from Russia to London, UK. We got another question coming in, Professor, before we move on. What is the highest diameter did you apply the glue in the great saphenous vein? This question comes from Hugo Navas from Venezuela.
When we start to use our Russian glue, we limited the diameter of the vein 1 centimeter. But last 10 patients, we use the glue with the diameter of the great saphenous vein 1.2 centimeters. And with the good nearest results. So we think that in the future, after we have many procedures of our and experience of our glue application, we think that we will use our glue composition more large diameter of the veins. Today, 1.2.
Okay. And we have got another one question. When it is biodegradable, so, you know, on your ultrasound follow-ups, how much time it takes, you know, it to disappear?
Bad quality. Repeat, please, question.
When we apply the glue on a follow-up ultrasound, how much time it takes for it to go away? Is it biodegradable or does it remain in the body?
Our morphology results for our experience of morphology results and our study of morphology results allow us to say that our Russian glue is biodegradable, but it's very it's a no simple process. So in experience in vivo, we pick up the veins after our procedure, after half year after procedure, and we see little pieces of the glue, but only little pieces, half year later. But 1 year later, ultrasound diagnostic show us that we don't see the pieces of the glue. So our conclusion that is our Russian glue is biodegradable, but we need another study, of course.
Sure. Thank you, Professor. So now we move to the next lecture. Is from Professor Mark Whiteley, all the way from United Kingdom. He's going to talk about the newest, latest procedure called HIFU. Tarun, if you can play the video, please.
I'd like to thank Ravel and the other organisers for inviting me to be part of this virtual Venous Association of India conference. Today I'm going to talk about HIFU, or high intensity focused ultrasound treatment of veins using Sonovane or the new Sonovane S machine. High intensity focused ultrasound is based on two ultrasound machines working simultaneously. The first is a grayscale two-dimensional ultrasound to see the vein. The second is a conical therapeutic beam of ultrasound that focuses at one point from a dome-shaped transducer. This is the appearance of a vein that has been treated immediately after treatment with little gas bubbles appearing, showing that the vein has had thermal ablation. The new Sonovane S machine has now come out from Theracleon and is quicker than the original Sonovane machine. We are able to treat longer sections of veins, rarely use local anesthetic, and there's no local anatomical disturbance because of the lack of local anesthetic. The first commercial case was done in our clinic in October 2020. This is the setup that we use for the Sonovane S machine. The patient lies to the left-hand side of the machine, and I like to use a small second ultrasound just for imaging. Using the small ultrasound, we mark the position of the target great venous vein on the skin. The patient is laying with easy access to the vein to be treated.
And we can see here the great venous vein there, straight away. Going into the junction there. And because we've marked it on the surface, you can go exactly down here.
Yeah. Some patients don't need their veins, so don't worry, some do.
So we can see the vein here in the middle. Okay, so now we have the great venous vein here. We're going to go to the positioning. We're going to lock this. We have to put the laser into range here. So the laser onto the machine there, the laser set, bring the skin down, and now we're more or less where we're going to start here. But what we're going to do first, we're just going to come up to here. Here's the junction I want at that point there. Bring the vein right into there. So there's the great venous vein. We can go to the longitudinal view. And there we are. And in longitudinal view, we can see the vein here. It's coming out. Just a little bit of rearrangement of that.
No, sometimes patients can think that the veins
I'd like to see the longitudinal section of the great venous vein. So here we can see the great venous vein here. Do now? Okay, so we've got the great venous vein here. We're right on it. We know where we are longitudinally. We're going to look here. The skin is in the right place there. We can just go up a little bit to check the great venous vein higher up. And we can see how it's starting to drop down there through the sphenoid-femoral junction. And we can come all the way down the great venous vein here. Comes up there. And it's on the muscle at point, so almost definitely we'll need a little bit of local anesthetic for this one. But you can see it's all in one place. So as long as the patient stays still, we'll be in the right place. Okay, that's lovely. So just go to that's in the junction there.
Local anesthetic isn't often needed for Sonovane S. In fact, we rarely use it. In those patients we do need it, it's usually only used in one or two areas, and certainly not the whole vein. This lady needed a little bit of local anesthetic in the groin, firstly because she found it uncomfortable with the vein lying right on the muscle, as you saw on the ultrasound. But also we needed local anesthetic to push the skin up off the vein to give a good distance for treatment. However, we only need to use an orange needle or a blue needle, and have never even used a green needle.
Leave the skin crease up here a bit more. There we are. So now do 300. Just here. And we're just going to go under the vein a little bit there. There we are. And so we can see there's a vein just there. And you can see, I'm just going to put a little bit of pressure on. We're just going to try and see if we can squash the vein a little bit. Just to try and keep the...
She was the star. Yeah, so I decided.
So if you just from there, you can see how it's the vein before and after, before and after. So once you've actually completed those centimeters, we now mark where the jump is on the leg. We then go back to here, do end treatment, new segment for the current position, yes. And then holding this exactly, so watching the vein you've got marked already, push the little button on the head. The computer the robot arm resets itself. And you're set to go straight from the same place again. But now you've got a whole thing. You lock the laser in place, you make sure the skin is in the right place there. And there we are, we're on the vein now, and we're ready to go again.
The last 20 years has seen a massive change in the way we treat veins, from endovenous thermal ablation through the attempt at non-thermal, non-tumescent treatments, and now to the completely non-invasive method of treating veins with high-intensity focused ultrasound, now often without local anesthetic at all.
Hello. Yeah, thank you, Professor Mark. I think is Professor Mark is here on the panel. Really need to look into it. I think he's not able to join us.
No, sir. He's not here.
I think he's not able to join us today. So we will post the questions to him by Professor Victor and Kotakusha. Can we treat the C1 varicose veins with HIFU? And we will get the answers from him directly. So we can go to the next topic now. Professor René Milra from France. He's going to speak about steam ablation and how he performs the steam ablation in varicose vein patients. Tarun, if you can please play the video.
Good morning. It's a pleasure for me to present the application of steam and to tell you how I perform this technique. Why do we use endovenous steam? Because the heat transfer from steam to water is very quick, which allows the heat to stay in the vein and to treat superficial veins for large malformations, as we have no risk of burning the tissue around the malformations. This is a generator used for the steam generation, connected to a handpiece, which converts the sterile water in a syringe to a puff of steam of 300 joules. For the grid saphenous vein, the technique is very similar to laser or radiofrequency with a Seldinger approach. inserting the catheter, tumescent anesthesia, and we retract the catheter 2 or 3 centimeters at a time, sending 300 joules, which means 100 or 150 joules per centimeter, depending on the diameter of the vein to be treated. For perforators, large tributaries, and malformation, steam is much better than radiofrequency or laser, as we shall see. For popliteal perforator, the surgery is often difficult because this patient can have previous dissection of the popliteal fossa, and there is a lot of fibrosis around the vessels and nerves, which gives a risk of vein and nerve injury in these patients. Steam can close these large perforators with only 2 or 3 small catheters inserted transcutaneously. This is a large perforator, popliteal perforator, dilated and tortuous, which you can see here. When you imagine surgically, you must do a very wide dissection of the popliteal fossa and the big scar. One of my patients here with only 2 catheters in the large perforator. You see this one in the perforator, this one is a feeding vein under the skin, this is a generator, and this is the tumescent pump. This is the single-use heating chamber, which generates the steam from this syringe with sterile water into this small catheter. And you see that immediately after the treatment, the vein becomes incompressible, echogenic, and it is closed. If we want to do steam phlebectomy, we use several of these small catheters, and we send several pulses, 2 or 3 pulses, meaning 600 to 900 joules per catheter, and then we can treat all the big veins at the calf level. For instance, in this patient, it was a recurrent from the anterior accessory saphena, and you see all these very large superficial veins, which are long and difficult to treat surgically. Here, we insert all our different catheters in the different areas to be closed. So all these catheters here are in place. So we perform the tumescent anesthesia with the pump. And before heating, we apply a pad with a cold saline at the entry point of the catheters, because the catheter themselves will become hot during the treatment, and we want to avoid the burning at the entry point of this catheter. There is no risk of burning on the veins themselves. Here, a patient with a superficial saphena and tributaries. And again, we see all the catheter in place. And with the guide wire, it's a long catheter used to treat the venous vein. So small catheters must be put in place before hitting the real venous vein, because a spasm will occur and it will not be possible to insert them after hitting. Some result at 1 month. Here, this patient with very superficial veins, and you see very few pigmentation as compared with what could be expected with a foam injection, and no inflammatory reaction. And this patient here with these veins fed by perineal vein insufficiency, pelvic vein, which were embolized before the treatment with steam of these recurrent varicose veins, at a very good result at 1 month. And another patient here with very wide and diffuse recurrences, treated only with steam, again 1 month. And lastly, the malformations here, complex malformations with bone malformation, lymphatic malformation, and these big legs, big venous legs, which were closed with steam and gave a good improvement in the quality of life of the patient and the level of pain and work ability. Another young patient here. All the catheters here are in venous legs intramuscular, which are diagnosed with MRI and ultrasound. And in the first session, we do the intramuscular legs. In the second session, later, we will perform the treatment of more superficial veins. And in the last patient here, it was a complex malformation with high pressure and a lot of bleeding in all these small areas highlighted in black. All was treated with steam, and the bleeding was considerably reduced, so the quality of life of the patient was much better. So in conclusion, steam is a technique, and it can be added usefully to any practice with a lot of difficult patients. Thank you very much for your attention.
Thank you, Professor Rene. And I think Professor Rene could not join us today on the panelists. If there are any questions on the steam, we can take it. If anybody wants to ask questions. Otherwise, there are no questions from the chat. Otherwise, we can go to the next topic.
Oh.
Sorry, yeah.
How to prevent the steam getting into the deep venous system when they are treating the long saphenous vein? That is my first question.
Sure.
Second question: would they put them on any kind of anticoagulant post-procedure, or anticoagulants with anti-inflammatory, because you're using steam?
Yeah, sure. You see, as you know, we have been using steam from 4 years now. The good thing is the steam really does not produce any clot formation. Actually, steam produces less inflammation outside the vein. So if you see the follow-up patients of the steam, you don't see as the laser puts in a clot. Actually, when you do the 1940 laser, it produces a similar picture as the steam when you see in the follow-up. So there is no problem with that. You can use very mild anti-inflammatory as you use with any thermal technique. Second is the distance what the steam travels is around 3 to 4 centimeters only. So when you do at the junction, we press it and we keep it around 4 centimeters away from the junction rather than 2 centimeters, and we give it at least 2 to 3 puffs if the junction is big. And it does not travel. By the time it reaches the deep system, the saphenofemoral junction, the steam bubbles becomes very diluted, and it does not harm the deep veins.
Thank you.
We can move to the next question, next topic here by Dr. Lovell Kapnick from USA. It's a very, very important talk on EHIT and how to prevent it and how do we treat it. Thank you, Dr. Lovell, for joining us.
And Dr. Jindal for the honor and privilege of presenting recommendations from the American Venous Forum and the Society for Vascular Surgery that has recently been published in JVS VNL and the Journal of Phlebology in January of 2021. Early adopters noticed that there was a unique complication with thermal ablation, thrombus extension into the deep system. The company Venous Medical was keeping a registry of which we mined and reported in 2002 286 limbs with a 1% incidence of thrombus extension. In 2004, Anil Hingorani and Enrico Asher at the American Venous Forum cautioned all of us by reporting their early experience. 73 limbs with a 16% DVT rate. In 2006, I presented at the American Venous Forum the classification and definition of EHIT. After analyzing many cases from 3 different institutions, it was certain that there were different patterns of extension. EHIT 1, venous thrombosis to the superficial deep junction, saphenofemoral junction, or the saphenopopliteal junction, not extending into the deep system. EHIT 2, into the deep venous system, non-occlusive thrombus with a cross-sectional diameter of less than 50%. EHIT 3, into the deep venous system, non-occlusive thrombus, cross-sectional diameter of greater than 50%. And finally, EHIT 4, total occlusion of the involved vein. With regard to EHIT treatment, all of us have our own thoughts. Thus, it was clear to the AVF that there was a need to develop practice EHIT guidelines. The American Venous Forum Guidelines Committee organized an EHIT writing group to analyze available literature regarding EHIT to gauge the quality of clinical evidence to provide guidance on EHIT's diagnosis and treatment. These guidelines were approved by both the AVS and SVS and accepted for publication in JVS, VNL, and the Journal of Phlebology. Regarding methodology, there were 4 subgroups tasked to accomplish the following. 1, establish the EHIT definition. 2, discuss the available EHIT classification systems. 3, evaluate prevention strategies and risk factors. And 4, appraise treatment options. We utilized 4 scientific repositories to identify potential publications related to EHIT: PubMed, Embase, Cochrane, and Web of Sciences. In addition, the following search terms were utilized: EHIT in patients undergoing radiofrequency ablation or laser venous ablation, DVT, SVT prior to 2006, truncal veins, great saphenous vein, small saphenous vein, accessory saphenous vein. Perforator veins were excluded. No restriction regarding language or research design, and the grade system was utilized. We looked at both the Kabnick and Lawrence classification and were able to translate the data, as the descriptors were quite similar. Thus, the AVF updated the EHIT classification by adding to EHIT 1, thrombus without propagation into the deep vein. We added the following: 1A, peripheral to the superficial epigastric vein, and 1B, central to the superficial epigastric vein, up to and including the deep vein junction. Now let's talk about EHIT guidelines. There are 15 guidelines with regards to EHIT. With the time limitations for this talk, I have selected some but not all. So let's start off with Guideline 2.1, risk factors for EHIT. Some possible but inconsistent predictors of risk factors for EHIT include large great saphenous vein diameter, previous history of venous thromboembolic disease, and male sex. These may be considered in the pre-procedural phase, but the evidence is inconsistent. Grade 2C. Guideline 2.2, prevention of EHIT with chemical prophylaxis. The use of chemical prophylaxis for prevention of EHIT should be tailored to the patient after assessment of the risks, benefits, and alternatives. Grade 2C. Guideline 2.4 of EHIT by increasing ablation distance. There is a trend toward decreased EHIT when ablation is initiated greater than 2.5 centimeters from the saphofemoral or saphenopopliteal junction. Grade 2C. Guideline 3.2, treatment for EHIT 1. Just as you would think, we suggest no treatment or surveillance. Grade 2C. Guideline 3.3, treatment for EHIT 2. We suggest no further treatment of EHIT 2, but with weekly surveillance until resolution, thrombus retraction. Grade 2C. As an alternative for EHIT 2, consideration may be given for antiplatelet therapy or anticoagulation for EHIT 2 weekly surveillance with cessation of treatment following thrombus retraction to the saphofemoral junction. Grade 2C. Guideline 3.4, treatment for EHIT 3. We suggest treatment with anticoagulation for EHIT 3, weekly surveillance, and cessation of treatment following thrombus retraction to the saphofemoral junction. Grade 1B. And finally, Guideline 3.5, treatment for EHIT 4. We suggest that treatment should be individualized, considering the patient risk factors, bleeding risk, and reference may be made to the CHEST guidelines for the treatment of a provoked VTE, grade 1A. Thank you for your attention.
Thank you, Professor, for a wonderful talk, and I think it's a very, very important. And we got the first question for you from Dr. Vasila. Being in the COVID times, do you suggest that we should add any extra anticoagulation routinely in patients whom we are doing a thermal ablation? I'll just unmute you, please.
Yeah, the quick answer is no,
yeah.
Because these are ambulatory. However, after discussing with Professor Caprini, we were looking at this because those patients that have had COVID may be at an increased risk for thrombosis. So again, how long would you treat this patient, or in terms of prophylaxis? So I would submit that would, if a patient has had COVID, that would increase the risk in terms of the Caprini score, and it depends upon the rest of the risk factors in the Caprini score. So yes, those high-risk patients, yes, and I would treat at least 7 to 10 days prophylactically.
Professor, another question from Dr. Ahmed from Egypt. Do you think EHIT diagnosis could be much affected by the timing when we do the duplex scan follow-up?
Absolutely. We know that if you do the scan at 1 month, the majority of EHITs have disappeared. And the question is EHIT even important? And I will leave that to the panel, because I suspect that EHIT is not important with the fact of the history that we've looked at for many, many years now. And in the United Kingdom, they don't even do post-operative scans. The patient's sent back, as far as I know, to the primaries, unless there's a problem.
Another question from Dr. Kursat is, any docs which we can use for prophylaxis? Do we use it or not?
Yes, there's a study that came out of Russia by Dennis who looked at using DOACs and found it to be helpful.
Sure. And we've got another question from Dr. Padaria. Prophylaxis for obese patients with anticoagulation.
So for obese patients, I tend, if we're talking about really obese patients, I consider that a contraindication unless they are really have advanced venous disease and they've not done anything. I think those patients really need to go for more morbid obesity treatment, because that's an end stage problem with veins for them and increased failure. But if you're going to treat them, that is a risk factor, but you have to look at the total risk factors, just not obesity. Just not obesity.
Sure. Professor Victor Canada, please. The last question, please, because
yes,
we are.
This is a question also for Lowell and for everybody. Excellent presentation as always, Lowell. My question is, I've been treating and doing and seeing so many patients right now with the COVID positive treat, saying that I have COVID 2 weeks ago, 1 month ago, 6 months ago. This will be a trouble for us in the future just to keep them in prophylaxis after the treatment, or what were we supposed to do with those new kind of patients that we are having right now in the office?
So looking at Caprini scores, Joe and I looked at it and we asked maybe to consider adding 2 points for COVID and then to risk assess after that. But I think that's really important, but we don't know enough yet.
Sure. Thank you, Professor Lovely. I think a lot of interesting questions, but because of lack of time, I'm really sorry. We have to move on. We are going to go all the way to Panama. Dr. Victoria, unfortunately, he cannot be here with us as a panelist, but he's sent us a beautiful lecture. Tarun, if you can play it, please.
Good morning. Thanks to Dr. Rahul Jindal and all the executive committee for the invitation to this great event. Our conference is Combined Thermochemical Ablation for Saphenous Vein Insufficiency, How I Do It, Panama Experience. no disclosures. Since 2010, we have not performed any more saphenectomies. We perform different techniques, but we prefer the use of laser, last generation, and combined with the use of sclerosant. In this conference, we will explain how we do it in 2020. We do the thermal part with the 1470 diode laser, 360 radial fiber, and automatic retractor. We do not use tumescent anesthesia. The chemical part, we use polydocanol in different concentration depending the size of the vein, making a microspuma with 1 cc of PDC and 4 cc of air with the Tessari technique and 40 shakes. We do echo Doppler pre and post-operative for all patients. Here we see some details of the conventional technique for the echo Doppler with the patient standing. We use this procedure for all sizes of saphena. It is shown one of almost 17 millimeters, and we treat the same way the saphena aneurysms as we shown. This is our echo Doppler and mapping findings record protocol. The previous day, the patient sent us the preoperative exam results, including the COVID-19 serology. Is necessary 6 hours fasting, strict personal clean, with not use antibiotics or thromboprophylaxis. At arrival of the patient at the center of ambulatory surgery, it's very important the interview with the anesthesiologist. Choice between two options: awake only with local anesthesia or sedation with propofol and local anesthesia. The details of transoperatory mapping. The ablation of the great saphenous vein is very important. The location of the laser and ultrasound equipment in the operating room, front to the surgeon, and the correct visualization of the vein. The identification of the vein at the ankle level, and the echo guide, needle puncture, and placement of the introducer with the Seldinger technique. We follow the wire inside the vein with the ultrasound, and when we are sure of the access, we introduce the 360 fiber. It's important to view in the guideline of the fiber and with the ultrasound all the way. You can see the correct course of the fiber. It's very important the position of the guide 2 centimeters from the saphenofemoral union. The preparation and administration of the sclerosant through the annex of the introducer is very important to see with the Doppler the intense spasm of the vein around the fiber. This part of the technique allows that we can do large veins and aneurysm. The correct setting of these laser parameters. The laser is started using the automatic retractor. reducing the energy as we approach to the knee, checking the distance from the vein to the skin, and confirming the closure of the vein through the Sisburg sign, that is the retrograde migration of the bubbles. Finish the procedure and putting on the compression stockings. Post-operative intrusion, sleep with the stockings on the day of the operation, walk, visit the office for the control echo Doppler at the third day. Our result series included more than 300 patients with no major complications. Our complications are mild pain or paresthesias and recanalization of some short segments treated on the office with echo foam. The advantage of the procedure are no tumescence, less hematomas, simultaneous treatment of the tributary veins, faster procedure, thermochemical synergy with less volume of sclerosant and less energy in terms of leads. Thank you very much.
Thank you. Thank you, Professor. As Dr. Victoria is not here, so we will move to the next lecture, please, from Dr. Shoaib Padaria. He's a past president of Venous Association of India, very active member. And Dr. Shoaib Padaria is going to speak on perforator closures. Tarun, if you can play the slide, please.
Today is when and how to close incompetent perforator veins of the legs. I have no conflict of interest. Perforator veins are those which connect the superficial veins with deep veins by piercing the deep fascia obliquely. There are approximately 150 perforator veins in each lower extremity, and of these, about 30 become incompetent and are relevant in clinical practice. There are two types of perforator veins: direct perforator veins and indirect perforator veins. The direct perforator veins are those which directly connect the superficial veins with the deep veins. And examples of these are the saphenofemoral junction, the Hunterian perforators, dot perforators, Voigt's perforators, and the Cocket perforators. On the other hand, the indirect perforator veins consist of small superficial veins which penetrate the deep fascia to connect with a vessel in the muscle, and in turn then end into the deep vein. The perforator veins are the gateway to the skin and should allow only inward flow from superficial to deep veins. And the competence of valves in the perforators are critical to protecting superficial tissues from transiently elevated deep venous pressures. Now, what happens when a perforator vein becomes incompetent? When it does so, there is a high systolic intravenous pressure in the calf vein, which can be as high as 200 millimeters of mercury, is transmitted to the superficial skin circulation. And this can cause white cell trapping and capillary cuffing, along with impairment of nutritional skin flow, and this can lead to skin pigmentation, lipodermatosclerosis, and finally ulcer formation. The larger the diameter of the perforator vein, the greater the chance of its reflux. For example, if a perforator diameter is only 2 millimeters, the incidence of reflux is 10%. However, if the diameter of the perforator is 4 millimeters, then the incidence of reflux goes up to as high as 88%. The correlation between the severity of the SEEP classification and the incidence of incompetent perforators. Patients with SEEP classification 3, the incidence of perforator reflux is about 52%, while 5 and 6 is more than 90%. What is defined as a clinically significant incompetent perforator vein? As per the AVF-SVF guidelines, the size should be greater than 3.5 millimeters in diameter, the reflux duration greater than 500 milliseconds, and there should be reflux from deep into the superficial veins during diastole. When is the right time to treat perforator reflux? It has been shown that those patients who have persistent venous ulcers, even after recommended compression therapy of more than 3 months, are unlikely to heal their ulcers. In superficial ablation, does not result in venous ulcer healing, which can be in as many as 45% of patients, then is the right time to treat the perforators. The current consensus is that there is an improved clinical outcome in patients with C5 and C6 disease, and these are the patients with medial ulcers, recurrent ulcers, and large ulcers, which account for 90% of the cases of venous ulcers. What are the methods of closures of perforators? Various techniques to treat peripheral vein reflux in the past included surgical ligation and subfacial surgical approaches. However, due to the fragility of the skin around the ulcer and the risk of creating new non-healing wounds with surgical procedures, the current approach is to use minimally invasive techniques. Various endovenous ablation procedures have demonstrated good technical success and low complication rates. Amongst the non-thermal methods, foam sclerotherapy is effective in the short term. However, there is a high rate of recurrence of the incompetent perforator veins and thereby the ulcers. Cyanoacrylated injection into the perforators, a few series have shown effective closures. However, some patients have had prolonged thrombophlebitis. And both these techniques, of course, there's a risk of DVT. How do we treat an incompetent perforator vein by sclerotherapy? You see a patient here who has severe skin changes due to chronic venous insufficiency. And here on the Doppler, you will see a very large incompetent perforator above the ankle draining into the great saphenous vein. Percutaneously, you can directly inject the sclerosant into the perforator, and care is taken to avoid injection into the adjacent arteries. 2 weeks later, a control ultrasound shows a complete occlusion of the perforator vein. And if the patient is followed up, we see at the end of 6 months, a complete healing of the skin has occurred with regression of the skin changes. As far as the thermal methods are concerned, we commonly use radiofrequency ablation and also laser. Radiofrequency ablation and laser are both intraluminal procedures. The initial success rates of RFA was about 96%. At 1 year, about 60 to 80% with the first generation. With the second generation RFA equipment, it's almost 90%. The drawback is it's a large bore stylus and it's difficult to cannulate the perforator. Now you can close the perforator directly by entering into the perforator if it is straight, like a direct perforator. So here is an example of how we close that using a laser technique. You can see a perforator here in this area. We use an angiocath, which is an 18 gauge angiocath. We remove the stillet and we insert the laser fiber so that a little bit of the laser fiber protrudes out from the tip of the angiocath. Once that adjustment is done, we, under ultrasound guidance, we cannulate the perforator with the angiocath. And as you can see here, we are inside the perforator. Now we will place that laser fiber into that perforator, give a little bit of local anesthetic around the laser wire, and start giving laser energy, usually between 5 to 10 watts of energy. And as soon as you start giving laser energy, you see the bubbles coming up and the entire perforator gets closed. And when you remove the equipment, there is no mark left behind. And you will see here how the perforator reflux, which was present before the procedure, has totally disappeared. On the other hand, we can also, when there's an indirect perforator, with a large number of tortuosities in the perforator direction, you can close the draining vein in a horizontal manner. And this can be also done either with radiofrequency ablation or by laser method. Here's an example of a patient with C6, C5 disease. And this is the draining superficial vein, and you can see the large perforator here draining into the distal GSV. In this particular case, under ultrasound guidance and after giving local anesthesia, we use an 18 gauge needle to enter the vein retrogradely, and a guide wire is then inserted into the vein, which crosses the perforator and is placed distally into the great cephalous vein around the ankle. During use of RFA, I normally use a sheath, and through the sheath, I put the RFA element, and that's the tip of the sheath, and you can see the RFA element, which is 7 centimeter long, placed distal to the tip of the sheath. The RFA element is placed across the perforator. Local anesthesia is given by using a Klein pump, and then usually one cycle of 20 seconds of RFA energy is delivered, and this causes effective closure of the vein within a matter of a few seconds itself. Usually one cycle is more than enough to close the perforator. So in conclusion, friends, treatment of incompetent perforator veins is still a controversial topic. It has shown to be effective not only in accelerating the healing of venous ulcers, but also in decreasing the rate of recurrence. Endovenous techniques such as laser, RFA, and foam sclerotherapy, and also glue are effective methods of permanent ablation. However, more studies are needed to accurately identify those incompetent perforators which still need closure. Thank you very much for your attention.
Thank you, Dr. Padaria. We got questions already shooting for you. The first question is for you is from Dr. Kursut. What is the foam concentration and average volume for perforating vein ablation?
So I normally use polydocanol foam, and for injecting into a perforator vein, I will use 1.5% concentration of polydocanol, and I will not exceed more than 0.5 cc's of foam into the perforator directly.
Sure. The next question is from Dr. Vasila. Why do you go to the perforator? Why don't you just do the foam of the superficial varicosities? And if you close them when there is no varicosities in the top, so it will be treated. So why we do go into the perforators?
So when there is a large perforator and the reflux is quite significant, and you only inject into the superficial draining varicosities, because of the persistent reflux, if you do an ultrasound 2 weeks and 4 weeks later, you will see significant reopening of the superficial varicosities and recanalization. And the perforator reflux does come back again. And therefore, if the perforator is more than 3.5 millimeters in diameter, I almost always, and it's a direct perforator, I will close the perforator directly.
So next question from Dr. Kursut. Do you see any thermal nerve damage with RF when you treat the perforators?
Correct. So I use RF only for treating the superficial draining great saphenous vein or short saphenous vein. I do not use RF because it's a large bore catheter, and therefore it does cause damage not only to the vein but also to the surrounding artery and the nerve. So I do not use that anymore.
Okay. Last question from Dr. Rashad. How many incompetent perforators do you close in average in every case?
If it's a C5, C6 disease, I usually find 2 to 3 perforators, but I must caution you at this point that I will always close the superficial reflux first, the GSV or the SSV first, reassess the perforator, and then only close the large perforators at that time. But 2 to 3 on an average, yes.
Okay. Thank you, Dr. Padaria, for a wonderful talk and the discussion. We move to the next, Dr. Victor Kanata, all the way from Paraguay. Dr. Victor Kanata is going to speak on foam sclerotherapy, different techniques, how he do it.
To give this lecture for the VICON meeting. And I'm more than happy just to remember that my friends Raghu Hindal, Roy Verghese, and Malay Patel are part of this humongous meeting. Just we are able just to go through the real life situation, but we will be together through this new kind of way of meeting by Zoom. I'm Professor Dr. Victor Kanata. I'm Vice President of the International Union of Phlebology, and I'm more than happy to be here with all of you. I will talk about my technique regarding about ultrasound guided foam sclerotherapy. It's 12 millimeter safe and feasible, and the final idea is how we've been doing it and how we're working in Paraguay. I don't have conflict of interest. Those are part of the society that I'm being part. What is ultrasound-guided foam sclerotherapy? It's a highly specialized procedure for treating advanced varicose veins and involves injecting a sclerosing solution into the abnormal veins using ultrasound guidance, causing the vein disappear. As you might see here right now, this is the external saphenous vein. We are in a longitudinal view. You can see beautiful how the needle enters the vein, and inside of the vein, we just drop the sclerosing agent just to close the vein and fix the patient. Why is the reason that GFS is useful? It's useful because it allows a complete view of the superficial intravenous space, observing the foam and providing great safety, avoiding the deep venous system. What is the goal of the treatment? The goal of the treatment is the elimination of the reflux with the final occlusion and future elimination of the vein without residual thrombus. How are we working here in Paraguay and how have been doing? I pre-op and mapping the US the patient. I demarcate the zone, I position the patient, I prepare the foam, I set up the injection site, I prep the area, I inject the patient, I give some rest time, and then apply the compression. You might see here, there is a patient I will do in a few minutes, and the way that you prepare the foam is crucial. You have to just do the amount of movement that is required to get a very good foam. The technique that I use is 1 to 4, and it's called the Tesaric technique. As you might see here, we use 20 passages from one to the other side to get the best foam for our preparation of the patient. And you might see also here, I demarcate and I put a line each 10 centimeters from the saphenofemoral junction, 10, 20, and 30 centimeters, just to demarcate and see that everything will go fine and without trouble. Now, you can see me using and checking the patient pre-op. After you pre-op the patient, you prep, you put some cleaning agent, and then you will be able to do it. All those patients I have here are with a little bit higher the amount of size, and the size of the vein is more than 12 millimeters. That is the reason that I've been trying to show that the 12 millimeter size is always feasible when you are trying to do atherosclerosis treatment. This is the treatment. We have the red line over there. We inject the foam in the longitudinal view, as you might see here. Then you will see that the needle is going slowly and approaching the vein. Then we twist the vein a little bit and we release the foam. After this, we move a little bit and we keep the patient resting. We elevate a little bit the leg and then we apply the pressure. Those are some kind of papers that I usually have with guidelines talking about UGS. Ultrasound guidelines are very good. They are usually very nice, but the relaxing time are just shortened than the other treatments. But you are always able just to repeat it if you require something else in the future. As you might see, there are a lot of patients, a lot of people, and a lot of physicians that will start training. I will be trained in this kind of new methodology that will be UGS treatment for the large veins in the body. Just to finish my talk, I would like to show before and after. This is a 47-year-old female with a saphenous vein larger than 12 millimeters. He has congestive heart failure as well as he has obesity, and she's unable to have a large procedure. I decided with her that we were doing it ultrasound guided foam sclerotherapy, and you might see before and after the result. The vein was completely closed without reflux and without trouble. The second one is a 57-year-old male with an ulcer in the leg. The guy suffered for the ulcer for more than 1 year, and he would like to have something that, because he cannot go and back and forth for the future treatment, we just want to have something in one shot. And we decide to use the ultrasound guided foam sclerotherapy. The vein is near to 12 millimeters. Before and after you see the result, we use 3 shots of 5 cc of polydocanol, and after this we have the result that you are seeing right now. In the longitudinal view, you will see the same. You will see how the epigastric vein is still open. We don't have reflux, and the vein is fixed, and we don't have a fit. The reason of that kind of treatment is trying to give another kind of difference to our patient, making sure that the results are very good and we don't have big trouble. My final slide, giving us our final acknowledged from the Paraguayan Society of Phlebology as well as Centro Paraguayo de Varices. We are working right now in the COVID season, and we are doing really very well. And this is a picture with nurses and with my patients that are really very happy to show what's going on already in Paraguay. Just my final conclusion is I consider that the ultrasound-guided foam sclerotherapy is an efficient method of treatment of vein of more than 12 millimeters by itself, but it's not 100% positive. We will work in the near future to have guidelines, also people who will train to have better results and to improve the way that we are doing our treatment in all over the world. Thank you very much. Thank you, Rahul, for the invitation. Thank you, Dr. Roy Verghese. Thank you, Dr. Malay Patel, and God keep you safe and alive for these really rough times that we will still have to go through the whole 2021. Thank you very much again, and have a good one.
Thank you, Dr. Victor. So we got one question already in the chat box for you. Do you see any difficulty for puncturing saphenous vein in the second and third, cannulation? So because you the pre-cannulation of 3 segments.
Yeah, there is no big difference, but sometimes the foam spells just a little bit behind the area that you are just treated. You have to do it faster. If you do faster, the spans will not be. It will be not a trouble for you to just fix the vein without the spans that you will lose if you have that trouble.
Thank you, Dr. Victor. We move to the next topic because the talk was slightly longer. So we'll have only one question, please. We'll go to Dr. Kürşat Buzkar from all the way from Turkey. He's going to talk about European College of Phlebology guidelines.
Thanks from India. Last year I was with you, but unfortunately this year, because of the corona, we have to be online. My subject is European College of Phlebology guideline for truncal ablation. This paper was published last year in Phlebology, and it is a work together with myself, Martin, Danielson, Dr. Pavlovic, Sorunalario, and Lars Rasmussen. First of all, we started from the surgical treatment. For the non-complicated C2 and C3 varicose veins, surgical treatment is recommended instead of conservative management. Whatever you do, surgery or endovenous ablation, if necessary, intervention procedures are doing better. To consider to do surgery, definitely you have to do high ligation and stripping instead of high ligation alone. The results of the high ligation alone is very poor. That's why we have to do stripping and high ligation. And the recommendation is 1A. Then for the guideline, what we did is we just collected the data up to 5 years for each endovenous ablation techniques. And as you can see, radiofrequency ablation, laser are doing very good job up to 95% closure rates in 5 years. Foam is 25% less than thermal techniques. At the time of writing of this guideline, we used to have 3 years of data for MOCA, but now we have 5 years of data for MOCA, and after 3 years, the closure rates of MOCA is reducing down. And in 5 years, it's 83%. If we are talking about glue, when we are writing this paper, we used to have 3 years data, and the closure rate was 94.4. Then we had 5 years data of American study, and the closure rate is same. What did data show us is, at 5 years time, sternoclad glue have over 90% closure rates. And because of this reason, in this guideline, our suggestions were For great subvenous vein, thermal techniques have 1A recommendation, and if possible, if available, thermal techniques, endothermal techniques should be preferred to surgery or foam. So that means we do suggest endothermal ablation techniques to other treatments with a recommendation of 1A. For short subvenous vein, this recommendation is 2A. Regarding the type of laser catheter, and if available, in order to reduce postoperative pain, we should use a new type of radial catheters. The recommendation is 2AB. Steam is not very popular in the world. There are some data, but it's scarce in the literature. So we suggest 2AB. Some are using very efficiently. I have no experience at all, but in the guideline also we were unable to find enough data to support the use of steam for truncal ablation. And for the treatment of anterior or posterior accessory subvenous veins, laser radiofrequency or foam can be used, and the recommendation is 2C. This is very important point. You gonna show a beautiful, she's the most beautiful woman in the world. Always new things are sexy. It's a routine thing. That's why there's a big interest regarding the new techniques. If we are talking about MOCA, the recommendation is 2BE. And if we are talking about glue ablation, recommendation is 2AA. Although 5 years closure ratio is almost perfect, almost wonderful for sionacrylated glue ablation, there are some ongoing rumors regarding the granuloma formation, long-term effects, and etc. That's why still I believe the recommendation should be 2AA. And for the treatment of subvenous reflux, surgery is recommended as an alternative to endovenous ablation in some patients. Regarding tributaries, side branches, as we have enough data, we did say a recommendation 1A, and we suggest we should do everything in one session. Although I know there are some questions about that. Thrombophilaxis should be considered for high-risk patients. It shouldn't be routine, and the recommendation is 2BC. We do not suggest routine post-ablation ultrasonography, 2BC, and we do suggest compression stockings for a week after the procedure, and the suggestion is 2AB. I thank you too much for listening to me, and unfortunately we had to postpone UIP to 2022. The reason is Corona. We are going to announce the new date very soon. We are working on with UIP on that. And as you know, 2023, European Society of Vascular Surgery were planned to in Istanbul, and we had to postpone is 2025. Thanks a lot.
Thank you. Thank you, Kushal. Fantastic review. And if there are any questions, please, regarding this, you are most welcome to put it into the chat box. Look, I can't see any question here. I think everybody is very clear about the guidelines, Kushal, and I think people have already gone through it.
Thank you.
And you have been very, very clear. So no questions to you.
Thank you. Thank you.
And so we can save some time because we are running 10 minutes late. So we'll move to the next lecture by Dr. Rashid Bushara from Egypt. He's the president of the Egyptian, all the IVLA you have been hearing on the internet a lot, the new society. And he's going to talk about the foam sclerotherapy for venous ulcers.
Dr. Badi, Dr. Abul, thank you for your kind invitation for me to participate in your esteemed Venous Association of India conference year 2021. Let me share my screen. I'm going to talk about foam sclerotherapy for venous ulcers, how I do it. Venous ulcers affect 1% of the population. So in India, you'd expect to have 1,200,000 patients affected with venous ulcers. For the assessment of venous ulcers, Docplexus play an absolutely key role. The superficial venous system must be assessed for axial reflux as well as extra-axial reflux. The deep venous system must be assessed for reflux and obstruction. And importantly, the iliac veins must be assessed for occlusion. Docplexus should suspect the diagnosis, and this should be confirmed by CTV or MRV. For the assessment of venous ulcers, the area around the ulcer should be assessed with a Docplexus scan for the pathological incompetent perforators and for this network of refluxing veins that may be surrounding the ulcer or in the vicinity of the ulcer. Regarding the treatment of venous ulcers, a key element in the treatment of venous ulcers is compression. It received the recommendation grade A with level of evidence A from the Society of Vascular Surgery and the American Venous Forum. Ablation of refluxing superficial venous system has been shown in the EVRA trial, a randomized trial of early endovenous ablation in venous ulcer, has been shown to reduce time of healing and to improve the number of patients who have actually healed. Iliac vein stenting for occlusion have been shown by Ravu and his colleagues as early as 2002 to be beneficial in venous ulcer healing. And I would like to share with you this image of a patient who had iliac vein stent for occlusion 16 years ago, and this Docplexus was recently performed, so it attests to the durability of this procedure. What's the role of foam sclerotherapy? We observed, as well as many other authors who work in the field of phlebology, that there is a network of refluxing veins in the vicinity of the ulcer. This is how it looks on the Docplexus scan, and we called it ulcer veins. Sometimes you can observe the ulcer veins with your naked eyes. And we found that 69% of our patients presenting with open venous ulcers have this Docplexus detected refluxing network of veins surrounding the ulcers. We figured that this is an important contributing factor to skin ulceration, and we aimed at abolishing ulcer veins using ultrasound-guided foam sclerotherapy. Ultrasound-guided foam sclerotherapy is an office-based procedure. We used polydocanol in a concentration of 0.25 to 0.5%. We used the Tesari method to prepare the foam in a ratio 1:4 for carbon dioxide. We used enough volume to fill the network of veins as seen by ultrasound. We injected in the vicinity of the ulcer, as I will show you a little later, and sometimes through the ulcer bed itself using ultrasound-guided technique, and we ended up the procedure using short stretch bandage. And I would like to share with you a couple of cases. This is case number 1. A male patient presenting with venous ulcer. He had an ultrasound scan, and these are the marks for the proposed sites for venous axis. The probe was placed over the mark, and this is what you expect to see, the network of refluxing veins around the ulcer. And here's obtaining access into the venous network using fine needle, and this is how it looks like inside the vein. And then this is the back bleeding, and then here we obtained access in the second site in the same network of vein, and then the foam is prepared, and the foam is slowly injected to fill this network of refluxing veins surrounding the ulcer. And this is what you expect to see on the Docplexus. That's the foam filling up the network of refluxing veins. Again, here is the foam filling up the network of refluxing veins. And we end the procedure with a compression bandage. This is the second case that I would like to share with you. Here is what we expect to see, the network of refluxing vein nearby the ulcer. And here we are obtaining ultrasound-guided access into the vein with the back bleeding. And here we are injecting carbon dioxide into the network of refluxing vein to make sure that we are intravenous, and this is what we get to see, the carbon dioxide. And then the foam is injected slowly to fill this network of refluxing veins. And here we can see the foam filling up the network of refluxing veins. And I would like to share with you our results. We studied 159 consecutive patients presenting with active venous ulcers. They were a rather young group of patients. Their mean age was 47.4 years. And we had complete follow-up on 89% of them. The mean follow-up was 30 months, and it extended in some patients to 4 years. In the group with primary reflux of the superficial venous system, 93% healed, and in the group with secondary reflux, post-thrombotic reflux, 83% of the ulcers healed. And I would like to share with you a few examples. This is before and after. Again, this is before and after. And again, this is before and after. My take-home message, Mr. Chairman, that foam sclerotherapy is an important tool in the treatment of venous leg ulcers. This data was presented by my distinguished colleague, Dr. Wasila Taha, at the UIP chapter meeting in Krakow 2019 and received the award for the best submitted abstract. I will be very glad to welcome you in person in our beautiful country, hopefully sometime soon.
Thank you, Professor.
Thank you very much for allowing us to share our data with you.
Thank you. And we got one question, and very important question, which people have got all the fears from Dr. Kushar, that he had a patient who had a DVT after doing this. So what is the mistake? So what are the precautions we should take so that we don't get deep venous thrombosis?
I think an important factor is the amount of foam you inject. So you inject the minimum amount of foam that would fill up the network of veins. But if you keep injecting, of course, it will go into the deep system and might cause problems. That's one thing. The other thing, I'm not sure if you can hear me. I hope you can hear me. And the other thing is for people who are at risk of developing venous thrombosis, we should use prophylaxis like it has been well said and well demonstrated by Professor Kapnik.
Sure. Professor Victor, you want to ask some question, please?
Yes, I saw that you are treating. The work is really amazing, and it will release a lot of patients in a crowded hospitals like Paraguay. You have the same trouble that you have. How you, after you do your foam treatment, those ulcers are very painful. How you treat them?
Yes, it is true that those ulcers, some of those ulcers are very painful, particularly the large ones, the chronic ones, the deep ones. They are very painful. Well, it's a problem that's not very easy to handle. There are a few measures. We use a dressing that contains anti-inflammatory. That's biatil ibuprofen. I'm sorry to say the trade name, but it does work. The other thing is we don't use 40 millimeters compression to start with, like we should. We use lighter compression, which might reduce the pain. And the third thing, we combat infection because infection is very painful. So we take culture and sensitivity, and we give antibiotics, and we don't keep the bandage for very long as we normally do in non-painful ulcers. So we might change the compression bandage after 2 or 3 days.
Thank you. And I think there is another question we have. I think Dr. Koshar, you want to ask this question, please?
There is a question from Dr. Boskut.
Yeah, do foot movements after injecting may help, or is it not useful?
We keep the patient in bed for 30 minutes, and during these 30 minutes, we instruct him to move the toes and to move the foot. But I personally don't think this is an important factor. I think what's very important, very crucial, is not to inject too much volume of foam. Can you hear me? Dr. Rahul?
We can hear you, Dr. Rashad. We can hear you well.
Thank you. I think Dr. Rahul is not with us.
Rahul, sir?
Dr. Rashad, Dr. Bedi here. Sorry, what did you want to say? Rahul is probably busy.
Yes. Well, I'm done. If there are no other questions,
thank you very much. That was a great talk. And Tarun, do we have another speaker?
No, sir. The session is over, sir.
Okay. Is Rahul around?
No, sir.
Anyway, thank you very much, all the speakers, the faculty, and the attendees. This was a really excellent and good talk we had from people who are leaders in their fields. Thank you very much, all of you. Really great. Wish you all the best. Now we'll move on to the next, and I request people to stay on, whoever is interested in the talk. Yes, Tarun, we can move forward.
Right, so just give me
Thank
a
you,
minute.
sir. Yeah, sure. Tarun, we would like to introduce the next session, session B. We got multiple lectures in that. And I'm going to start with the introduction for the panelists. Dr. Sandeep Pandey from Nepal, Dr. Wang Shengming from China, Dr. Malay Patel from India, Dr. Gurjeet Singh from India, Dr. Vishal Attari from India, Dr. Sho Padaria from Mumbai, India, Dr. Davinder Singh from Hyderabad, and Dr. Kapil Gupta from Delhi, India. So we can start, Tarun, whenever you are okay with the first lecture from our friend from Egypt, Professor Imad Hussain, is going to talk about failing hemodialysis access, values and limitations of endovascular interventions.
It's a privilege and honor to be part of the VICON 2021 with Professor Jindal and very distinguished members of the Venous Association of India. In fact, in 2017, I had the honor of hosting distinguished members of Venous Association of India when we held at that time in Aswan our AfroChat meeting. In this quick presentation, I will try to cover a few aspects of predictors of outcome of the failing the endovascular solution for failing arteriovenous fistulas and grafts. I have no disclosures. Now, what is the problem we're talking about? Arteriovenous fistulas and grafts are frequently being done for patients of end-stage renal disease but they are prone to failure. It's an emergent situation that needs salvage as soon as possible. Often multiple salvage procedures, endovascular interventions nowadays are being utilized more liberal for both AV fistulas and AV grafts when they are failing. When you look at the literature, we'll find variable results. Go quickly into that, not only for salvage of the AV fistulas, but also of percutaneous creation of AV fistulas for end-stage renal disease. The endovascular options are quite known to all of you, and they include simple balloon angioplasty, sometimes cutting balloons, stenting, sometimes, especially in the central venous system, or stent grafts, or drug-coated balloons recently. The diagnosis is straightforward, will not dwell into that. Clinically, or by duplex or fistulogram, that is reserved to the timing of the intervention, actually. This is our study conducted over 4 years. Actually, it is a retrospective study for both university hospitals, Demirbaş and Enshams University Specialized Hospitals, included 31 hemodialysis patients with failing angioaxis, arteriovenous fistulas and grafts. These are the demographics, and these are quickly some of the results pre and post angioplasty. And we start usually by the fistulogram in order to visualize everything. So directly injecting the dye into the perianastomotic area, the outflow, and the proximal venous system, especially the proximal venous system. And then we undergo the vascular procedures, and then finally the completion fistulogram. Follow-up of our cases mean 14 months, clinically duplex predominantly. And these are results, the technical results, fairly good, 93%. We had our share of re-interventions actually, and we had 2 failures, predominantly AV graft and central proximal venous system stenosis. And these are our results. And the distribution of the site of the stenosis, predominantly the distal anastenosis, or multiple levels. In the meantime, from the first access to the failure, takes longer to interfere for AV fistulas. They take longer because they just they live longer than AV grafts in our series, and also from the endovascular salvage to the re-intervention. Well, the conclusion is that endovascular intervention in the form of a balloon angioplasty is safe and efficient in the treatment of failing AV grafts and fistulas. Results are usually better in AV fistulas. The re-stenosis rate is not uncommon. In our series, it was in the order of 24%. Secondary intravascular interventions globally offer longer patency and durability. Results and close follow-up of these results is mandatory. And failing AV fistulas, as we mentioned, fare better than the AV grafts. I thank you very much for your attention, and we're ready to receive any questions.
Thank you, Professor Imad. And we got one question coming up from Dr. Vasila. Sorry. Sorry. I think,
no, it was an answer, Rahul. It was an answer.
Yeah. I got the question. Yeah. Any questions from the panelists, please, for Professor Imad? Professor Imad, did you, in your practice, for how long do you think after angioplasty, the fistulas remain open? And next question is there any contraindication? So is there any fistulas, when you see them on an ultrasound, when they come into your practice, you will not recommend endovascular interventions?
This is an interesting question, Rahul. Actually, we are talking about with the endovascular intervention in the vast majority of the cases, especially with AV fistulas. I'm not talking about the grafts, because the grafts, they fare worse. So we are talking at least 8 months. But the good thing about the whole technique is, as you know, and everybody knows, it is reproducible. Especially when we do not have the hard front of a central venous system added pathology. As far as the second question, You were asking about.
So, is there any contraindications where you will not do, like you see on ultrasound or clinical examination and you say, no, the angioplasty will not work and it's better to go for another fistula or an AV
actually there is, yes, actually there is one only contraindication in our series, which is recurrence for the third time, because we know that we have exhausted so many trials before, or presence of overlying infection or an associated stenosing or failing fistula with a part of an aneurysmal dilatation in the perianastomotic area. So we just do a new one.
Okay, thank you, Professor. Sorry,
maybe I'd like to ask one question from Dr. Sen. Professor, one question.
Yes.
Well, probably, do you have any data about what is the role of drug-coated balloons in a case of AV fistula, failing AV fistulas, and how are they behaving in clinical practice? How the potential is improved following a DCB implantation?
We have just started lately, only like 6 or 7 cases. We cannot talk about a large series on that. Drug-coated balloons are having an more increasing role in such situations. We cannot also find in the literature medium-term outcomes, actually. So probably it's a bit premature, waiting for further high evidence results from other series.
Correct.
Thank you.
Thank you, Professor Imad. Now we will move on all the way to Italy. A dear friend, Dr. Sergio, is here on the panel, and he is from University of Ferrara, and he's going to speak on randomized comparative trials on aquatic versus dryland exercises for phlebology and the lymphology patients.
Thank you so much, Raul, and thank you so much to all the friends from all around the world who are joining the always prestigious BICON meeting. Indeed, we are moving away now from the hospital to go into the aquatic environment, so the pool, but in reality remaining into the health topic, and in particular into the evidence-based topic. I was asked indeed about reporting our latest publications on the topic. These are my conflicts of interest, while I declare that it is interesting indeed, as brain specialists, to look at the data on the topic of the aquatic environment used for our venous and lymphatic patients, because according to the literature, you can see that our colleagues from the rheumatological and the orthopedic world have done very well in terms of scientific production, while we are really low as numbers in terms of the scientific publications. So that our patients are for sure enjoying the aquatic environment, and they have been doing this since the ancient Roman times. We all know that the spa environment has been used a lot, but with not scientific data really in support of that, if not for some, that were extremely interesting back already in 1992, showing, for example, the potential volume reduction of the lower limb and also the hemodynamic improvement. But the problem in science is always standardization and reproducibility. So if we don't collect the data properly, it's really difficult to have solid evidence-based data in support. So these protocols were quite variable. Carpentier did an outstanding job on this topic, with also crossover trials showing what was going on when the same group was going outside the pool rather than inside the pool. But the problem remains in terms of reproducibility, because as you can see from the same paper, the protocol that was used inside the pool was changing on every single patient based on the indication of the physician. The potentials are huge if you think of that every single centimeter of water is exerting 0.74 millimeter of mercury, which means that when we are standing up inside the aquatic environment, we have a graduated compression that is starting even at 80 millimeter mercury when we are with the water up to our navel, so 120 centimeters. For this reason, we standardize a protocol of exercise, and we published that in 2017 in Phlebology Journal. The protocol is available, it's for free, so you can see all the details and eventually use this protocol with your patients. What it will do will be reducing significantly the lower limb volume. At the same time, the subcutaneous thickness and the circumferences of the lower limb, as well as improving the ankle range of motion. You see Michael Jackson with this moonwalk, because walking backward, there will be an increase in the ankle range of motion, even more than if walking forward. We also demonstrated at the VAS scale an improvement in terms of symptomatology, while no improvement in terms of objective measures in the functional ambulation classification, an objective measure of how these patients are walking. But with this publication of ours, in reality, we were not answering to the question about the protocol per se or the aquatic environment, meaning these benefits are coming because of the exercises or are coming because of the aquatic environment compression, or maybe a synergy between the two. For this reason, we set a very serious and long-lasting study, a randomized comparative trial called the DATA, so dryland and thermal aquatic, indeed looking at the data on this topic. We looked at the same outcome measures I reported before. You can find the paper published in JVS. And basically, we consider just the C3 patients to be as homogeneous as possible, doing exercises in dryland versus a thermal aquatic environment. It was performed at the University of Ferrara and in a thermal center nearby Venice, where I hope we will meet soon together in person again. The protocol was the same of the previous publication, was performed twice per week, 5 times in total, and it is basically moving all the joints, as you can see, of the lower limb. In terms of lower limb volume, there was a significant reduction in the group inside the thermal aquatic environment, not in the group doing the same exercises on dryland. In terms of subcutaneous thickness, a significant decrease in the aquatic group, not in the one in the dryland environment. In terms of GSV caliber measured, as you can see, at the A point, so 10 centimeters below the inguinal skin crease, a significant reduction in the thermal aquatic group, not in the dryland group. We looked again at the ankle range of motions. In both cases, there was a significant improvement of this ankle range of motion, but more in the aquatic group. And there was, of course, a correlation just in the aquatic group between leg volume variation and improvement of ankle range of motion that is in agreement with the previously published data. We know that quality of life is fundamental. It's fundamental to report that in an objective way. So we looked at the civic score that was improving in both groups. But we also know that there can be, as reported by the literature, a variation in the different quality of life scores. So we included also VVMCQ. And there was, in this case, an improvement just in the aquatic group. In another publication of our group, we focused on the bioimpedance analysis of what is going on inside the leg during the aquatic compression. And what we reported is that indeed the extracellular water, as reported by the bioimpedance analysis, is significantly reduced. Interestingly, with a correlation with the lower limb volume, as there was a correlation with the lower limb volume with the ankle range of motion in the other publication in the AVIA journal. So one on diagnostics and one on JVS. So I would conclude that we can now say in an evidence-based way that performing a standardized reproducible exercise inside the aquatic environment is more beneficial than on dryland in terms of lower limb volume reduction, subcutaneous thickness reduction, improvement in ankle range of motion, reduction in extracellular fluids, and improvement in quality of life. Of course, further studies are needed in terms of the different kind of waters we want to take into consideration. But we hope this is another step forward in improving the evidence-based data that are needed in a field of venous and lymphatic medicine that is still too empirical. I'd like to deeply thank Erika Menegatti, our PhD, who has been the first author of the last 2 papers I was quoting. And I look forward for Gather Together in this initiative that is following this other paper that is showing us that 40% of the medical websites are including fake news, also in the aquatic use, for which I invite all of you to report eventually encountered venous lymphatic news. I deeply thank Vicon to be already part of this group effort that will lead us to the publication of a Delphi consensus on proper communication that we will present hopefully all together in Dubai during the Universal Expo, a once-in-a-lifetime opportunity also to stop in India, as we were planning to do in person last year when we were planning in conjunction the two meetings. And it is a nice anniversary today, actually, because exactly 2 years ago, we were together in Cortina, and 1 year ago, we were together in India. So I look forward for the next year to be together in person once again. So a big hug to all the friends, in particular from India, and a deep thank to all the organizing committee, in particular Raul and Betty.
Thank you, Sergio. Fantastic talk. I've been very interesting, in this topic. And, I've got two questions before, the panelists ask you questions. One is, have we tested a normal water or a water, maybe a seawater with a high saline content? Does it make a difference in terms of, decreasing the swelling?
This is a very physics expert question, because you are referring to the Stevin law, that is the law of hydrostatics, that is telling us that the graduated pressure is related to the density and to the height of the hydrostatic column. For in terms of physics, I can surely answer, yes, it will make a difference if the density is higher. The first study we did in 2017 was in normal water, let's say a pool. Now we are talking about hot springs, so thermal water, because I can already disclose some data. We are going to publish also the results of the different densities and the different temperatures. And the interesting thing is that, for example, it could be a fake news that hot water is an issue. Because if we really dive into physiology, and on the Journal of Applied Physiology back in 1985, it was already demonstrated that you could have an improvement of the flow of the femoral vein, and at the same time of also the great saphenous vein, with temperatures that are ranging from 34 to 39 degrees Celsius, because it is a matter of cross-sectional area also in terms of final flow. So there is a lot of physics to be studied in this application that is, of course, cost-effective for our patients. So if you can go to the sea, great. Sea for sure is better than the pool. If you can't, already going to the pool with the water up to your navel is 120 centimeters, so 80 millimeter mercury of graduated pressure.
Well, I think it's a very, very interesting, because if it's really works very well in the patients, then we can get into some pools for the patients who can do it at home, and it's very cheap, and patients will love it. They don't like doing exercises because of some joint problems and all. They are not able to do exercise. If they can jump into the pool and stand there for for some time at home, and without doing much exercise, it will be fantastic. And any other questions, please?
I see our friend, the Professor Hussain, has a question in the chat about tiptoes exercises or swimming better. So dear Emad, the answer is absolutely tiptoe, I would say, because you are combining with the tiptoe the gravity force. So what we were saying before, the graduated compression. Of course, we never tested swimmers versus tiptoes, so that could be something to look at, but you are losing the graduated pressure of the hydrostatic column. Another interesting thing, to go back to what you were saying, Raul, is the chemical properties for which these specific waters who are hot springs are having components of sulfides, for example. And it has been published 2 years ago that sulfides can act on endogenous thrombolysis. So there is also the chemical properties of the water that could come into play in the anti-inflammatory action for these patients.
Thank you, Sergio. Thank you for the nice talk. And now we will move on to Egypt. Dr. Wasila Tarun, yeah. And, she has been coming to our center from so many years to India to teach all the people in ultrasound. And she's going to talk about a duplex ultrasound in patients with venous ulcers.
Hello, everyone, and thank you very much for the kind invitation, my dear Indian friends, and congratulations for such successful meeting for the 14th annual conference of VICON, the Venous Association of India. My topic today about the duplex ultrasound in patients with venous ulcers and how I do it. This is some of my best memories in India, in Chandigarh, with the Maharaja Bedi, and during the course with my candidates, also with my dear friend Rahul, and receiving the best hospitality at his home, and with Professor Diki and Professor Pinjala. I have no disclosure. And in fact, patients with active ulceration, they are the most unfortunate patients during their productive life, and they do have a socioeconomic impact in our societies. Here, the SVS and the American Venous Forum guidelines for the venous leg ulcer, they do recommend a comprehensive venous duplex for those patients. And in fact, the key word here is comprehensive. We have to extrapolate the most important information about the underlying pathology, either reflux or obstruction, or even both reflux and obstruction. Here in the IVRA trial, they do pointed the early ablation of the superficial venous reflux results in the faster healing of venous leg ulcers. So we should really look for extrapolate the information from the duplex about the superficial reflux, and the vast majority of those are relevant or corresponding to the medial trunks at the GSV, as we are know the saphenous eye on the cross section or transverse section. We have the GSV inside the facial compartment and between the superficial and the deep fascia. Another important drug, the anterior accessory saphenous vein, is very confusing, but as its name, it's anteriorly lying, anterior but inside the facial compartment, but aligned with the femoral vessels. And another important issue also, it has a short journey compared to the GSV. Another important trunk is the superficial accessory saphenous vein. So here we have the superficial accessory saphenous vein. The facial compartment itself, it's voided from any trunks, while the reflux pattern comes from the superficial, as its name, it lies superficial and outside the facial compartment. So this is how I do it. The patient on standing position, bearing his weight on the contralateral side, and with a linear probe, and we do compression side to assess the patency and distal manual compression for reflux, and we measure the transverse diameter if the patient is candidate for any ablation procedures. And this is the compressibility, how we compress the GSV. And also this is on longitudinal skin, very important to assess the reflux on longitudinal skin. And this is a quite competent GSV, another quite competent GSV, while this is a very incompetent with prolonged reflux with augmentation. And as all we know, the threshold of duration is 0.5 seconds for the axial or truncal reflux, GSV, the anterior accessory, and superficial, as mentioned before, as well as for the small saphenous vein. And if you do have patients with lateral venous ulceration, we should really think the small saphenous vein examination. So the duplex has a crucial role to extrapolate the different reflux pattern, not only the axial refluxes, but also the incompetent perforators and the distal reflux at the vicinity of the ulcer. They are network of refluxing venous collaterals, which transmit the high venous pressure by the pathological incompetent perforator to the skin, which is really an important contributing factor for the ulceration. This is how it looks at the superficial varicose at the vicinity of the ulcer, which is beautifully stated by Dr. Rashad Bishara, and how in our study we can abolish this superficial varicose aiming to ulcer healing. And this is the duplex criteria for the pathological incompetent perforator, as all we know, the facial diameter and the reflux duration. How we measure, this is VR, this is the line, this is echogenic line, the facial defect, or the facial line, and this is how we can measure the facial defect, and this is by the color flow, the bidirectional flow, and this is how we measure the time or the duration of the pathological incompetent perforator. In a distinguished Indian Journal of Plastic Surgery, pointed to the role of the duplex scan with the most useful investigation, and we have also thorough examination for proximal obstruction. In fact, when we have such ulceration, we have to think post-thrombotic syndrome or think proximal obstruction. Here we are with the Professor Raju in a distinguished contribution, really more of the iliofemoral DVT, more pathological venous ulcers lines in 15% of those patients, and the recanalization process appears to be worse in the presence of an external compression, which has been reported in 80% of the limbs with acute iliofemoral DVT. Here we have a typical example of proximal obstruction. This is the right common iliac vein spared, and this is the right common iliac artery. The left common iliac vein chronically occluded with thread-like flow and a small bunch of collaterals nearby. Another important example, this is a double channel recanalization of the external iliac vein with the nearby collaterals and with a very confirmative venogram of such a patient, the double line of the external iliac vein with the bunch of collaterals nearby. Another important crucial role for duplex to assess the inflow and the outflow prior any iliac venous reconstruction. This is a good inflow with the common femoral vein, profound femoral vein, as well as the great saphenous vein. So we have a good confluence at the level of the common femoral vein, which points to a good inflow prior reconstruction. While this is an inadequate inflow, we have only the sole inflow, the profunda, while here the femoral vein is contracted and chronically occluded. Also, it has a crucial role to assess the outflow. This is a patent with good color flow IVC. Another important role of duplex prior applying compression, which is the highest level evidence for the healing of ulceration, venous active ulcerations, in the compression. So we have to know if the limb is ischemic or no or not before applying the compression, and also the degree of ischemia. To conclude, Mr. Chairman, ladies and gentlemen, role of duplex in venous ulcer has a crucial role to assess the ischemia of the limb prior applying the compression. Also to know the different pattern of reflux before applying the ablation procedures. Also to assess the iliac veins, either it is obstructed or not, and the degree of recanalization. To assess the inflow and the outflow prior reconstruction, as well as if we need to eliminate or to abolish the distal reflux. It has a crucial role here to assess the superficial varicosity at the vicinity of the ulcer, as well as the underlying pathological incompetent perforator. Thank you very much for your attention. This is my photo in Chandigarh in Mohali in my sari. Thank you very much for your attention, and thank you one more time for the invitation.
Thank you, Vasila, for the wonderful talk. And you look beautiful in sari. Any questions from the panelists, please? Looks like we know everything about ultrasound, and so there are no questions here, Vasila, but thank you for joining us.
Thank you, Rafur, for the kind invitation. Congratulations for the success of VACN. Thank you very much.
Thank you. And we go to the next topic from Egypt. Dr. Ayman Fakre. It's a very different topic and a lot of debate from so many years. Is internal jugular venoplasty a new hope for MS patients? 7-8 years back, we started doing that in our center, and then we stopped. And so it will be interesting to see. Professor Ayman.
I'm Mohammed Ayman Fakre, Professor of Vascular Surgery and Chairman of Egyptian Venous Forum. First, I would like to thank Professor Betty and Professor Raul Jindal for inviting me to VACN 14th virtual conference and give me the chance to join you today discussing is internal jugular venoplasty any hope for MS patients. I don't have nothing to disclose regarding this topic. My agenda today, Mr. Chairman, back to history, epidemiology, introduction, case presentation, and conclusion. Regarding the history, multiple stings and hyperbaric oxygen session were believed to cure multiple sclerosis in the past, and both theories were flawed. The epidemiology of the disease is estimated to affect more than 400,000 people in the United States and more than 2 million people worldwide.
It's typically a disease of young adults. Its pathology, known as inflammatory neurological disease, characterized by heterogeneous autoimmune in nature, and the exact origin remain unclear. The disease is characterized by demyelination, axonal loss, and inflammation. The caution is chronic cerebrospinal venous insufficiency, an entity and upset for multiple sclerosis. We know iron stores in the white and deep gray matter in cause of multiple sclerosis have never been explained and could be related to abnormalities on the venous drainage. This may be resulted from impaired venous drainage from stenosed internal jugular vein. Chronic cerebrospinal venous insufficiency is a syndrome characterized by stenosis of internal jugular and or azygos veins with opening of the collaterals and insufficient drainage provoked by reduced cerebral blood flow and increased mean transient time in cerebral MRI perfusion. Prevalence of chronic cerebrospinal venous insufficiency in multiple sclerosis patients ranges from 50% to 100%. Dr. Zambouzi, with Symposium 38th with Symposium in New York, stated internal jugular venous stenosis reported 70% for chronic cerebrospinal venous insufficiency in patients with multiple sclerosis versus 10% in control patients. It is characterized by multiple stenosis of the principal pathways of extracranial venous drainage and the internal jugular vein and azygos vein with opening of the collaterals. This hypothesis was we could improve chronic cerebrospinal venous insufficiency by dilating the stenosed internal jugular vein and abolishing these venous collaterals. These international procedure guidelines stated multiple sclerosis can be a distressing and disabling condition with a lack of effective treatment. Based on the existing evidence, we believe that clinicians should only consider offering percutaneous venoplasty as a treatment option for people with multiple sclerosis who fit the diagnostic criteria for chronic cerebrospinal venous insufficiency as part of structured clinical trials. Our guest presentation today, Mr. Chairman, is a 53-year-old lady presented with repeated attacks of unilateral gradual onset mononuclear visual loss, pain on moving the eye, and altered color vision. Visual loss rarely progresses beyond 2 weeks from the onset, and visual recovery usually takes longer than 2 weeks and may not recover to baseline and known as optic neuritis. SF examination revealed oligocondylar bands in the SF and used as a surrogate marker for estimated time to confirm diagnosis of multiple sclerosis. While there was a delayed evoked potential with a well-preserved waveform and known as abnormal visual evoked potential, while the MRI, there was free axial fluid attenuation in version recovery, known as FLAIR image, and the MRI in T2 showed hypertense lesions that are characteristic of multiple sclerosis in 2 or more of 4 areas of the CNS, periventricular, cortical, or juxtacortical, and infratentorial. Simultaneous presence of gadolinium enhancing and non-enhancing lesions at any time, or a new T2 lesions or gadolinium enhancing lesion on follow-up MRI. To summary the case, it is 53 years old female patient, primary progressive multiple sclerosis for 7 years duration with positive CSS finding, abnormal evoked potential, and FLAIR image on MRI. The Docplexus showed criteria suggestive of right internal jugular vein stenosis in positions of supine and sitting and also during inspiration and expiration. This table showed this flow, significant flow changes in sitting and supine position, in the internal jugular, and in collateral vein. The procedure, we passed our wire and we passed the stenosis segment and we dilated, and this is the catheter to show what was happened. And this is the picture post-operatively or post-dilatation, and this is the procedure. Complete dilatation. To conclude, Mr. Chairman, there is currently no high level of evidence to support or refuse use of angioplasty for treatment of multiple sclerosis. Chronic cerebrospinal venous insufficiency in people with multiple sclerosis is estimated to affect 50 to 100% of the patients. The effect of this intervention, and which can provide a reliable evidence to help clinician and management decision making. And we recommend this case presentation highlights the need for randomized controlled trials to evaluate the effectiveness of internal jugular vein angioplasty in the treatment of multiple sclerosis patients. And I'm happy to join you today. I hope we meet again next year. Thank you.
Thank you, Professor Ayman. And it's a very interesting topic, and it's been in debate from the last. If you can just unmute yourself, Professor.
So you need to unmute yourself.
Sir, if you can unmute. Tarun, can you help, please?
Dr. Ayman, you need to unmute yourself, sir.
Yes.
Yeah, thank you.
Yeah, we can hear you.
No, thank you. I have done.
Yeah, thank you. Professor
Thank you,
Rahul,
and thank you, Professor Bedi, for giving me the chance to join you as usual.
Thank you.
It is a really privilege for me to be here with you.
It is a
I'm
pleasure.
ready for questions.
Very nice of you to have joined. Thank you.
Thank you. Professor Ayman, it's a very interesting topic. It's been in debate from the last nearly 13 years, and
Yes.
7, 8 years back, a lot of patients started flowing to countries like, India, other countries where we can do these procedures, where the, regulations are not very strict about doing the procedures in terms of where the data is very confusing. And there are a lot of publications, and the basic two problems with these procedures were, one was the diagnostics, because sometimes you could misinterpret the MRI and the CT venograms and the duplex of the narrowings in the IJVs. And because if you have the patient, lie down or standing, the diameters of the IJV changes. And also the success rate with the angioplasties, this was so varied, whatever the publications. So we did few cases when the patient started coming in the very early part, and then there was a lot of publications which were against it. So, 11 years down the line, we haven't reached anywhere for this group of patients, So is there any latest publications in last like 1 or 2 years where, we are thinking again of this topic?
You have a point, Raul. Yes, it is a little bit debatable topic, and the good thing that the NIST guidelines did not refuse or augment its abuse, but it said it's an option. We can give it a chance for the patient if he fulfills the criteria of diagnosis. We can give him a chance. It may improve him. And you know that there is a very nice talk from Christopher Meyer. He said, during the last 10 years, we have many patients, and at least 70 to 90% of them improved. We don't know why. If we did not give them a chance to use all tools, it will be the perfect crime.
Yeah, I can understand. There is another question from Dr. Vasila. If we think that the outflow tract from the brain is one of the causes for causing this hemosiderin deposition in the brain and causing multiple sclerosis, that was a theory behind. So why patients with chronic renal failure, with obstruction in the veins does not suffer from MF? Is there a difference, or is it because CRF patients, they don't live that long, or is there anything related to CRF?
This is a great question. Thank you, Asila. You have a great point. The point that when we have central venous stenosis, we don't have an issue for the chronic cerebrospinal venous insufficiency. It affects the central vein, but still we have good flow in the cerebrospinal venous flow. That's why it doesn't show in chronic end-stage renal patient this iron deposition in the 4 known areas of the brain. This affects only the upper arm, the chest, but it does not rely much on the cerebrospinal venous pathway.
Thank you. Any other question, please?
Yeah, Professor Ayman, so one question to ask. So what is your choice of stent, and what the diameter of stents you have to put in a stenosed IGV?
Stent, no, I don't recommend putting a stent. I recommend just angioplasty, and if it works, we can repeat it. It is an easy procedure, so it works. It's good. We can repeat it after it restenosed again. I think it is much safer than putting a stent in such a injurious region.
Correct.
I think so.
So to what diameter do you like to inflate the IJVs to have a good outflow?
Yes. There is no published criteria for that, but I made only 3 cases. Both did well. All cases did well. From I had done, I used high pressure balloon 14. It works very well.
Okay.
Dr. Tarazi, please, the last question, please. Dr. Tarazi.
Yes, I have met Dr. Zamboni when he began to do this operation.
Yes.
Yes, and so it was in the mode 15 years ago, and so I used it 5 times, 3 times for jugular vein and 2 times for azygos vein.
Great.
Yes, and the only good result, really good results that I have, it is a young gentleman, 32 years, with azygos vein narrowing. He has a very good result, nearly total derision of his multiple sclerosis. I have one amelioration with 1 jugular vein. It is not evident. The neurologist was not really cooperative with us, and the literature was negative, so we abandoned this operation. What do you think about azygos vein?
You have a point. Yes, it is written, and Dr. Zambuzi explained these 2. Yes, you have a point. It works, and it may be more curative than the internal jugular. But I myself, I don't have this experience, and I didn't met cases with azygos vein. But yes, it is reported, and I am happy that you made few cases, and I hope we can work together to make further cases. Maybe it is a hope.
Maybe. Why not trying it anytime if we have nothing else to do?
Exact. This is the point.
Okay, thank you.
Thank you. Dr. Raul, may I make an announcement, please, if you allow me?
So please go ahead, sir.
I'm very happy and I'm very pleased to announce that 2 years ago, we had a very good and very promising Indian fellow from India. He spent 10 days with us in Alexandria. And I have the honor to repeat the invitation and ask you the VI to annually give us the privilege to have one of the Indian fellows to spend 10 days training in our center in Alexandria annually. I think we have this great honor, and I will be happy to be done annually, if you allow me.
Thank you. That was very kind of you.
Thank you for your hospitality and your great heart. We will continue to be associated. Thank you so much.
Thank you. Thanks, sir.
The next talk is by Mr. Gil Shapira, and he's representing a pharma company.
Hi to everyone from Israel. My name is Gil Shapira. I'm the CEO of Neolaser, and the topic today for this lecture is the evolution of fibers for endovascular use. So first of all, from a technical perspective, when one thinks of delivering laser energy to tissue, the most important metric to think about is really the power density. Power density is defined as the power of laser light divided by the spot size, by the area. The smaller the spot size, the higher the power density, the larger the area on which you emit the light, the lower the power density. And the reason this is so important for us clinically is that when you have a high power density, the temperature of the tissue rises very fast and it's less controlled. For example, this is good when you want to cut tissue. But when you want to close down the vein, such as in endovascular, you prefer low power density, larger area of emission, which gives you controlled temperature rise. Really, the goal for endovascular use is a gradual and controlled rise in temperature inside the vein, the ability to contain the energy inside the vein structure and not impact any structures outside, and do this in a uniform way around the wall of the vein. And of course, last is to prevent any thermal damage from reaching the deep vein system and potentially having significant complications such as DVT. So with this in mind, and with the concept of power density, and one can think of power density a bit like a surgeon would think of a force of applying a scalpel. So the higher the power density, the more force is applied, and therefore the more rapid the interaction, and the lower power density, the less force and the more gradual and controlled it is. So with this in mind, let us look at the evolution of fibers along the last 20 years. The first fiber that was introduced for endovascular use was the simple bare fiber, which emits to the front. And with this structure, you have a very, very high power density because all of the energy comes at the tip of the fiber, which is small. And the fiber may contact the wall of the vein, and therefore this combination of rapid rise in temperature and contact can create a puncture going through the wall of the vein, and of course a lot of thermal damage beyond the wall. After this fiber was used, angiodynamics introduced, I believe in 2007, what they call the never touch fiber, which was later further advanced into the never touch direct. And in this approach, you have a tip, you have a jacket around the fiber to prevent contact with the wall. So if you don't have contact, you don't have very high power density. And energy is still emitted to the front, but in a bit of a wider emission, and as such, power density is reduced. You avoid contact, but still you have forward emission. The next evolution in fiber was the radial fiber by Litec, I believe somewhere around 2012. And in this design, any delivery to the front is eliminated. You fire only to the side, much lower power density because light is spread in a ring all around the fiber. And of course, a glass cap to prevent any direct contact with the internal fiber. The next evolution was the two-ring radial by Biolitech. Same approach in general, just half of the energy in one ring, half of the energy in another ring. And the latest addition in terms of fiber evolution is what Neolaser has introduced in 2020, which we call the infinite ring radial fiber. And in this design, it's a whole section that emits in a radial fashion, a bit like having tens of rings one right after the other. And as such, power density is drastically reduced even further because the light is spread over a much bigger area. And we prevent any firing to the front as well. So why does this matter? All of the fibers you've seen above can be used to close the veins with high efficacy in terms of closure rates. But the better you get with the fiber design, the more you prevent in terms of side effects, pain, bruising, and risk of DVT, risk of any impact in terms of going EHIT, going into the vein system. And as such, it matters. So the first step in terms of bare versus jacketed tip fibers, for example, like NeverTouch, you can see in this graph research that was done in the US in terms of big impact on pain. So you can, even with this small step in the first evolution of fibers, see a reduction in pain scores for patients. In a further study that was done in Japan by Hirokawa on radial fibers versus bare fibers, both were compared using a 1470 laser. And as you can see on the table, results, significant reduction in bruising, pain, EHIT, and so on. And all of this is statistically significant. So definitely the fiber makes a big impact in terms of the ability to reduce side effects. So what is special about the next step of fiber evolution, which is the infinite ring? In this fiber, we reduce the power density even further. You can see in the graph a big reduction of between 4 and 8 times versus the standard radial fiber or the two-ring radial. And as such, the rise in temperature is much more gradual and controlled. In studies that have been done ex vivo on this type of fiber, which is called, technically it's called a diffusing fiber. The brand name is the infinite ring. What you can see is that the temperature inside the vein is lower than, of course, relative to the bare fiber, but even relative to the radial fiber, by about 15%. And as such, temperature is more controlled, and the probability of preventing damage beyond the vein wall is enhanced. Okay, so with this technical results, you can see the design. This is what the fiber looks like. The emission is in a cylinder pattern along a section of about 3 to 4 millimeters. Can be used with any wavelength. Today with Neolaser, we use it primarily with 1470 or 1940 nanometers. And what the structure does, it's because it spreads light over a section, it provides optimal uniformity of the deposition of light along the vein as you pull the fiber along the vein back to the entry point. And because of this, reduces any potential complications such as pain, bruising, sensory disturbances, and so on. To see what this looks like clinically, you can see this on a model of liver. The two first lines on the right were done with the radial fiber, so you can see even though the power density is low with the radial fiber, you do get some interaction at points which it may stick and lead to additional thermal damage. You can see this in the lines on the liver versus the infinite ring fiber, which produces a very, very uniform and clean line, avoiding any specific hot points and so on. And you can imagine that such a path inside a vein would lead to potentially less complication and really optimal results. So in conclusion, what matters for vein treatment is really the design of the fiber tip and the power density. The lower the power density, the more controlled you will have the temperature inside the vein. Another important point is the avoidance of any emission to the front, which avoids anything going into the deep vein system. And as such, this infinite ring fiber gives you the lowest power density possible and optimal uniformity applying along the vein, and potentially reducing any sticking carbonization, and as a result, reduction of complications. So I hope this has been helpful in terms of seeing the different fibers along the path from bare fiber, jacketed tip fiber, radial, two-ring radial, and today the infinite ring fiber, which is the latest advance in terms of fiber design for endovascular. Thank you.
Thank you, Gil, for a very nice lecture. You know, guys, I've just introduced Gil because I was offline for that minute. He's a MIT graduate in lasers, in beam laser from 20 years, and he's the owner and CEO for the Neo Laser. So actually, he is inventing the laser fibers, what we are using. So any questions which we are not clear about? And Lowell, first question, please.
Thank you, Gil. That was a fantastic summary. But the bottom line of all of the new fibers they are diffusion fibers, and so more are diffusion than others. I don't agree with you in terms of the side firing lasers that there's no propagation of heat. So we do know that there is convection, conduction, and radiation. So my question really is having to do with power density. As you decrease the power density, do you need to increase your LEED with power and energy? So does your new fiber require higher power and energy to deliver the same damage?
Yeah, so that's first of all, thank you for the distinguished forum and of course the opportunity to present here. In terms of your question, it's an excellent one. It sort of goes to the line of you know, if you need to hit the nail, you know, the two hits, small hits equate to, you know, one big one. And from a purely clinical perspective, the most accurate answer I can give is we don't know yet. So the fiber we as physicists, we have, let's say, an estimation based on ex vivo work in terms of what this should be. So our best estimation, given temperature rise, is that you may need to increase power density on the order of about 10%, not more. So this is what we started with. We're now doing patients both in Germany and in Belgium to see how this will react. And then based on this, we'll come out with more detailed recommendation. Based on the physics outside the body, my answer at the moment would be yes, a bit, about 10%. Now to the comment in terms of side emission penetrating the wall, of course, this depends on the combination of both the fiber design and the laser itself. And what we've been doing in the last year is movement. For example, in the study in Belgium, we're doing this with this type of fiber, which increases the area of emission. But on the other hand, we're using a 1940 laser where the depth of penetration is sub-millimeter. So the energy by itself is contained within the vein. And we think this combination of both an energy which is much more absorbed than 1470 and the large area of emission would give you the most, let's say, optimal combination of things.
The question then, will it translate to a clinical improvement? And it's all theoretical at this point. But thank you very much. I really appreciate that new looking diffusion fiber. Congratulations.
And another question, Gil. So a question from Professor Ayman. Is there any difference between one ring and two ring radial fibers in terms of you know, the clinical uses and safety and complications in terms of physics?
Could you repeat the beginning of the question?
Is there any difference? Is there any difference between if we use a one ring radial fiber and a two ring radial fiber?
So unfortunately, when you look at the data and what's published to date, there is no comparison really of one ring and two ring in terms of clinical outcome. There is a body of work from Japan, which I quoted, which looked at bare fiber versus one ring, and then bare fiber versus two ring. okay? And this, taking those two combinations into analysis, since they were done by the same group using the same methodology and so on, one can try and come up with a comparison of one ring and two ring, and at least from that body of work, you don't see any significant difference. But that said, there isn't a large body of work that looked at that comparison. Theoretically, the two ring does give you slightly more area, so slightly less power density, so there could be an advantage, but the jump is not significant, I would say.
It's a very important question, because you see, if you look into the price difference between a single ring fiber and a double ring fiber, it's quite a lot. So if you put it into the clinical perspective, it really makes a difference in terms of if there is not much huge outcome different, then we can think about using a single ring only. If there is no problem with the money, then it's better to use a two ring fiber.
Yeah, so from a theoretical perspective, there should be a slight difference. Clinically, in terms of proof, there is no proof out there. That's what it is today. And we look at, for example, this design of the infinite ring in order to substantiate this. This is exactly why we're investing in clinical work, to see what the results will be. I mean, of course, it's a very
The last question from Dr. Hussain. Dr. Hussain, if you want to ask the question, please. Dr. Hussain, you raise your hand if you can ask the question. I think he's not connected. Okay, we move to the next lecture. Thank you, Dr. Gill, for a wonderful lecture. We move all the way to Mexico. Dr. Fernando's talk on distal crossectomy. So people, I heard the term first time, so we all will hear about distal crossectomy now. Dr. Fernando.
Hello, friends. I'm Dr. Fernando Vega Rasgado from Mexico, from Mexican Institute of Phlebology, Mexican College, and Mexican Association of Phlebology. It's a pleasure and it's an honor, this invitation to participate in this wonderful VICON meeting 2021. I want to say thanks to all my friends in India, especially Dr. Sohai Podaira and Dr. Heringer, who invited me. From Mexico, I want to say hello to all my good friends from India. In this time, my lecture is about the distal crossectomy, a new way to control of distal reflux. I hope that you enjoy it. I haven't conflict of interest. On the contrary, this work tried to make the treatment of chronic venous insufficiency easier and cheaper, without expensive equipment, practically with your own hands. Traditionally, saphenofemoral reflux results in large varicose veins and ulcers in advanced cases. The surgery, any kind of surgery, laser, radiofrequency, glue, crossectomy, etc., prevent the reflux by closing the vein near the saphenofemoral junction. As a consequence, the varicose vein disappears and the ulcer closes. Closing the leg point will prevent the high-pressure column impacting on the distal leg, though we have simpler surgical alternatives to achieve the reduction of venous hypertension transmitted from the saphenofemoral junction? The answer is yes. We can do a proximal crossectomy with mini surgery and tumescent anesthesia, like I presented in the past year. But what if we do this same cut and ligature on a more accessible and less complicated place, just here? Close the knee. If we fractionate the pressure column and in this midpoint, we achieve the same effect of correcting the reflux and eliminating venous hypertension in the lower leg. This is a technique. First, we do an ultrasound study and mark where is this venous vein on the leg and verify that it is cause of the high pressure, distal high pressure. With tumescence anesthesia, a very small cut in the skin, we locate this venous vein close the knee. And with a hook, for example, Varady hooks and other hooks, we expose this venous vein and we cut with a ligature in proximal and distal ends. With the ordinary suture, silk, polyglycolic acid, etc. In the distal part, we introduce a catheter to pass through some millimeters of foam or polydocanol foam, 2%, to close all the system, insufficient system in the lower leg by ultrasonography control. To end, close all the endings, proximal and distal, and close a usual suture. And then, if you can see some varicose vein, you can do sclerotherapy. At the end, you put a bandage from the foot, and I can prove what is the reflux in this leg. You can see it's disappeared totally. This method is very simple. In our first series of 20 patients operated with this technique and who had venous ulcer, 60% closed in the first month and the 90% in the second month. The hemodynamic consequences of the ankle are the same with both techniques. One, distal reflux is eliminated, the venous hypertension is eliminated too, and improve the reflux in the deep system. The reflux pattern in the venous vein in the teeth changes according to the perforated veins in this segment. We found two possible outcomes. First, without perforators. If the saphenna haven't perforators in the teeth, we can obtain a thrombus. The second case, with perforators in the teeth. The reentrance and decrease the diameter of the saphenous vein. Type 1, the saphenous do not have any reentrant perforating vein in the teeth. A thrombus occurs from the ligation to this saphenofemoral junction, where the reflux has the same pressure as the resistance offered by the thrombus. You can see in this picture how is the saphenofemoral junction here, and 2 centimeters approximately. The thrombus is very organized in this place. You can see when the force of the reflux limit, it is the limit of the thrombus. In the type 2, in the most common case, the reflux will be re-enter at the deep circulation again through perforators in the teeth, like here, like here. And return to the deep system. The diameter of the venous vein in the teeth reduces immediately, and with the time, it becomes very small. In some cases, the reflux goes away. The diameter decreased after 3 months from 1 centimeter to 0.41 millimeters. The reflux didn't. We still do not have follow-up data after 1 year, but we believe that in case of reflux persists over time, new veins could be opened, but if they are detected early, can be controlled with sclerotherapy. Our conclusion, it is an easy approach that effectively controls the reflux and hypertension in the lower leg, with a fast closure of the ulcer. This work provides information on the refluxes of the great venous vein in the thigh and its hemodynamic consequences. We require more studies in this area. Maybe this is a blasphemia. Yes, I know that maybe some of you give me, oh, this is not possible. It's a blasphemia. This is an heresy. Maybe, but this is a very simple method when you need to control the venous ulcer in places far from the cities, with the people having other opportunity. Colegas, before that you crucify me, please visit Teotihuacan in Mexico, the city of the gods. I wait you for in Mexico. Thank you very much by this time, this opportunity. Yes, this is big point in the point of view of the venous treatment, especially in venous ulcer. I hope that you promote new ways of things, change your mind. Thank you very much by this opportunity. Please receive best regards from Mexico and all my love. See you later. Bye.
Bye-bye. Thank you, Dr. Fernando, for a wonderful talk. Because the length of the talk was more than 9 minutes, so I'm really sorry we cannot take any questions for this talk. We need to move on to the next talk, please. Next talk is very different. We'll take to Dr. Edin. He's a PhD from University of Melbourne, and he is associated with 3M Healthcare. As you know, the initial company was KCI, then it was BD, and now it's a different company. And he's going to talk us about the wound management and innovations in complex wound management, because we deal with venous ulcers, and I think it's an important aspect to understand this. Dr. Edin, please.
Good evening, ladies and gentlemen. Edin's my name. I'm the Medical Science Liaison for 3M KCI, and my objective this evening is to introduce you to the topic of VeriFlow Cleanse Choice. The Cleanse Choice dressing is designed to be used in combination with VeriFlow therapy, and this particular slide describes the therapy in essence based on its mechanisms of action. And essentially what it does and what it is designed to do is combine phases of VAC therapy with phases of installation of a topical solution into the wound area. The combination of two are designed to help drive granulation tissue and help cleanse and remove pro-wound stalling factors. And obviously by diluting them out through each installation phase, you're limiting their impact on that wound bed and aiding in driving that wound through to that healing phase. What's important is that in order to support the use of VeriFlow therapy in that installation phase, the material composition of the dressing has been optimized to a polyurethane ester, and compared to traditional granule foam used for traditional VAC, it can absorb 4 times the amount of fluid within a given period, and this is demonstrated in the graph to the left of the slide. So this is important because you want to ensure that the fluid reaches the periphery of the foam and obviously cleanses and contacts that wound surface. Now, focusing on the Cleanse Choice dressing, this was designed in order to support wound management where patients that would require sharp debridement to remove the areas of slough and non-viable tissue were delayed to be taken to the operating room. So in order to facilitate this management, the dressing was designed in 3 layers. Material composition is a polyurethane ester, but its tensile strength has been improved to increase its strength and limit and improve its removal intact during each dressing change. The increased tensile strength has improved its hydrophilic properties, so it distributes fluid even more efficiently than standard VeriFlow foam. But that contact layer with the holes in it is designed to facilitate the removal of slough and non-viable tissue, and the additional layers are designed to bolster that layer down but also fill in that wound volume as a traditional foam is used. one characteristic feature is also the pore size, and that is fixed and carried over from traditional granufoam through to the cleansed choice dressing and the VeriFlow dressing as well at 400 to 600 micron pore size, which is optimal for generating granulation tissue and fibroblast proliferation more specifically. How does it fare in an actual real-world scenario? So first, the preclinical study was presented here in 2017, and essentially 3 dressings that were designed to support the installation of fluid were compared in their ability to break down slough and granulate tissue. Porcine model, full-thickness wounds, slough layer inside each wound placed into each wound, and over an 11-day period, default settings were utilised, 3.5 hours of vac, combination with a 10-minute dwell phase of standard saline, and the wounds were monitored over an 11-day period. The results show cleansed choice was most effective in breaking down slough and also granulating tissue. You can see that that wound volume has reduced most significantly, and the histopathology results confirm this outcome specifically. To complement the preclinical study, Luc Thiot and a team of plastic surgeons in France presented a retrospective case series where 21 patients presenting with predominantly pressure ulcers were managed purely with cleansed choice and VeriFlow therapy, where typically they would require sharp debridement to remove areas of slough and the non-viable tissue or devitalized tissue. And essentially what was shown is using the same conditions that they were able to manage these devitalized areas of tissue and slough layers within 3 dressing changes, so 9 days, and reduce the surface area to less than 10%, equal to or less than 10% within that therapy period. In 85% of patients that had non-viable tissue within their wound, or within 57% of patients that had yellow fibrinous slough. What's important about this is that it demonstrates that this dressing not only breaks down slough, but also can granulate. And this image analysis shows you at day 0, at day 9, you can see there's an important progression in that wound and it's responding. So you're not compromising the care of that patient by simply utilising a dressing that was designed to manage areas of non-viable tissue and slough, but it also granulates. The mechanisms of action, why it's such an effective tool in the management of pro-wound stalling factors, as I noted in the previous slides, is related to the design of that contact layer, so that whole layer. And essentially what was first described in 2018 by Kim et al. Is the mechanism of action. And essentially those open holes provide space for granulation tissue to form into. And this enables that contact layer to anchor down against the wound surface more effectively, with the additional layers helping to bolster that layer down. And naturally, through each vac therapy phase, that foam compresses and expands, and this creates a microabrasive effect against that wound surface, and essentially helping to mechanically break down areas of non-viable tissue. In combination with the installation of fluid into the wound area, this softens these non-viable tissue areas and obviously helps to facilitate more effective removal during drawdown when the vac therapy phase is switched on. Naturally, as this is a cyclic action, the contaminated fluid is removed and then refreshed during each vac therapy phase. But this is proposed why it's such an effective tool in combination with VeriFlow therapy when using cleansed choice. The final slide is just to highlight a consensus article presented in 2019 by a team of experts in the area of negative pressure wound therapy with installation, and they present 11 consensus topics to help you optimally apply the therapy in your clinical practice. As it's in its infancy, this is an excellent tool to reference. I thank you for your time and I welcome any questions.
Thank you. Thank you for the wonderful talk. Is there any questions from the chairpersons or the panelists, please? Aiden, I will start with a small question. Have you used this technology along with the 4-layer bandaging on the very exudative venous ulcers?
To say we haven't used it, I would not say that, but to have it clinically reported on at this stage, I haven't come across it personally, no.
Sure. So, Adin, we have used this on 10 patients in our setup. And so tomorrow we are going to present a small publication. And we found it's a fantastic way of very exudative venous ulcer, where it's a very big problem to apply a foliar compression for 4 or 5 days. So you put in the vac and apply a foliar bandage. The compression is there, your skin does not get macerated, and you can keep the compression on for 5 to 6 days, and the patient can actually go home with the vac and the foliar. And it has been really fantastic experience in the last 10 cases what we have used, not in the normal venous ulcers, but in exudative venous ulcers.
Excellent. That's very promising.
Okay. There are no more questions. We can end this session here. Thank you, everybody, all the chairpersons and the speakers to be here and to support VAI. And now we'll move to the session C. It's multiple miscellaneous different lectures we have. And we will start with the chairpersons. We have Dr. Loyal from US, Dr. Victoria from Panama, Dr. Luis Tarazi from Syria, Dr. Javier from Mexico, Dr. Joing from Peru, from South America, Dr. Dekivadia from India, Dr. Pranay Pawar from India, Dr. Kumud Rai from India, and Dr. Adarsh Kabra from India. Thank you, chairpersons, to join, and please do ask difficult questions to the speakers to make it more interesting. So we will start with the first talk by our close friend Dennis. He's struggling in snow between two cities and trying to get this talk delivered to me. Thank you, Dennis, for this, and we can start the session. Please, he's going to speak on the clots, how I do it.
Dear colleagues, hi, my name is Denis Borsuk, and in this short video I will show you how we do clots procedure, cryo-laser cryosclerotherapy. So our first acquaintance with the clots method was in 2017 when we first time met Kazuo Miyake and his clinic and his meeting, IMAP, International Meeting of Aesthetic Phlebology. And we were really interested of this method at that time. And then after 3 years of visiting of his clinic and his conference, we believed in this method and bought the equipment for this and started to do clots and really satisfied of this method. Moreover, this method nowadays in Russian guidelines of aesthetic phlebology, and we're really proud of this because it's a very, very interesting document, and it gives us opportunity to work with this method in Russian clinics. So one of the most important thing in clots is the settings for procedure. And in the next video, I will show you our settings in our clinic. Dear colleagues, hi, my name is Denis Borsuk, and in this video, I want to show you our settings and how we do clots procedure. So firstly, I want to show you the settings in our room for clots therapy. Here is the standard cabinet, standard room. And we have here, as always, for clots therapy, following Kazuo Miyake's protocol, which we have been using for last year. So here we have a photo camera, which is extremely important for clots. So when we do a picture, these pictures are going to this screen. And when we have follow-up procedure, so before we start second procedure, we do again pictures, and they are going directly to the second screen. So, and the patient can immediately compare before and after. It's very important. The patient is lying here and can see pictures. In any positions, on spine positions or any position, patient can see the pictures. That is why these screens standing here in this side. So also, as I told you, we have a camera for pictures, screens for pictures. Also, we have a Zimmer machine. It's a cooling device, which is very important for clots procedure. Of course, we do have a viewer, and I will show you. It's augmented reality. Very important to find feeder veins, not to meet them. And of course, we have an ND-YAG laser machine for clots therapy. So now I will show you how we do procedure. So, as I told you, one of the most important thing is a picturing of the leg before and after. And as it was investigated by my friend Fabrizio Santiago, that when you show the result of a patient with the pictures before and after, you can rise in his satisfaction of the result. It's very important. So, having said about clots, so let me show you in the pictures how we do this. So our first step is treatment of reticular veins, of feeder veins. So we do with the standard settings of laser from 2 to 3 passes for each vein with the laser, and of course every time we need to have a good cooling of the skin. So the state settings, it's very easy. That state settings is the same for reticular veins and for spider veins, for telangiectasias. It's 15 milliseconds impulse, 6 millimeters spot size. Fluence is approximately 70 joule per centimeter, and you can decrease fluence for 50 joule per centimeter in case of when it's painful for a patient. So, and after the percutaneous laser, you need to immediately inject 75% dextrose, because vein is has less diameter, and it is inflammation of the venous wall, and you need to inject very slowly dextrose 75%, which is quite a very good sclerosant, but not so strong as detergents. So here is injection of the reticular veins, and after you need to repeat the same settings, the same laser, but only 2 passes, not 3, only 2 passes. We use just 2 passes for every telangiectasia and ectasia, spider veins, and then you need to inject the same dextrose to that veins. Very easy, and after you can have very good results just after 2 to 3 sessions of clots. But when we started, we thought that after 1 session you will have every time good result, but it's not true. In majority of cases, we do 2 sessions of clots. But some of patients want to have better results, and we can do 3rd session. So nowadays I work in 2 cities, and it's 200 kilometers between them. And to be honest, I do sometimes sclerotherapy still in 1 city, but a lot of patients who heard from me the words like, your legs is so beautiful, I cannot do sclerotherapy for you. I cannot harm you, so make some hyperpigmentations or matting. I need to be sure that you will have very good results with very low risks of some complications. And you need to go 200 kilometers to another city to have this procedure. So I really believe, without any comparative studies nowadays, having just my experience, that this is quite a good method. And in the nearest future, we will show you that it really works, and you can have very, very low complication rate without matting, without strict complications, strong hyperpigmentations. So we're really satisfied and lucky with this method today. Thank you for your attention, and I hope it was interesting for you. Ravul, unmute yourself.
Professor Lowell, you want to ask a question? Thank you, Dennis. Yes, please.
Dennis, always nice to see you, even in the snow and 70 degrees in Florida. But you are a scientist as well. And for you to stand up here and tell me how good CLACS is without a randomized controlled trial, I would submit that you're doing this and you haven't, and you are in the process of doing a randomized controlled trial. Can you give us any information about it?
Thank you all, but we didn't start yet. We have an idea how to do a good, we have a program, ImageJ. Maybe you know this program. It can count the length of spider veins and reticular veins. So nowadays we are organizing the protocol because we want to do multi-center study, and it's not so easy in aesthetics to have some good endpoints. It's quite difficult. So nowadays we are thinking about organization. But Kazuo, he treat very rich people. When we came for him 3 years, year by year, and saw how he works with very rich people. And without randomized study, you can think that he cannot have complication with that people, firstly, because in case of complications, it's not good. That is why we started without any evidence. Without any evidence, we started it, and we satisfied. I like this method. I think that it's quite good.
Please do an RCT. You can see whether laser is necessary to the sclerotherapy, etc. And I know you will do a great job. Thank you.
Thank you all. Thank you.
And Dennis, absolutely, we have been using Clark's from 2 years now. We met in his clinic, and we have been using microsclerotherapy with 0.25 from 8-10 years before as a cosmetic. And yes, there is a difference, but I will give, unless we have a randomized controlled trial, but I will also give another picture to it because this requires a lot of investments. So it's not for people, who are going to do one-off case, in many weeks, because it's a lot of investments on putting on the laser machines. And second is, really it makes a difference because such procedures are being done by really posh people mainly. And if you have big laser machines and if you do that, and it also puts in a different angle, not a scientific angle, a bit different marketing angle, if you have to say. And the third is, if you look into the physics, yes, it should make sense because you are using the laser and you are producing the edema of the endothelium and burning that, and then using a lesser amount of sclerosant and lesser hyperpigmentation. So it do make sense, but yes, we do lack RCTs, and I really don't know why we are not getting there and why we are not able to do it. And we have been talking about for nearly 2 years now.
Ravul, I agree with everything that you said, except that we don't have a good device, whether it be sclerotherapy or laser alone, to be effective. So that's why it may be in the hands of the average phlebologist to do both.
Yes. Thank you, Dennis.
Colleagues,
Sorry.
I strongly agree. In Russia, we have big arguing today, between different people, that somebody said that we're so satisfied with mixture of dextrose with sclerosants, doing just sclerotherapy, and a lot of things. But I started with Clark's, and I have this opportunity, and I'm really glad to have it. So I can find patients for this method, and so we have a lot of patients. So I like it. So just my experience.
Thank you, Dennis, and we need to move on, please. We go all the way to South America, to Ecuador. Unfortunately, that meeting was cancelled last year, and we missed that opportunity to visit a beautiful country. Dr. Ernesto, he's going to speak upon compression for ulcers, how I do it.
Hello, my name is Ernesto Intriago. I'm from Ecuador. I'm resident of vascular surgery in clinic in Stuttgart in Germany, and today I'm going to talk about compressions for ulcers, how to do it. First of all, we have to find the problem. Is a venous disease, arterial disease, or we have both problems? What are the effects of compression? We can reduce the edema, we can reduce the venous volume, we can improve the venous pump, decrease the venous reflux, increase our arterial flow, increase the lymphatic drainage, reduce the inflammation, reduce the accumulation of cytokines, of the accumulation of free radicals. We have to differentiate between the long-stretching materials, short-stretching material, and inelastic materials. Short-stretching materials has little elasticity and little stretchability, high working pressure. Long-stretch materials has very elastic and high stretch capacity and less working pressure, but high resting pressure. Can stretch more than 100% of their original length. Inelastic material like zinc paste impregnate are non-stretchable or fast or almost non-stretchable. Short stretching products bandage has a high working pressure, so we can increase our venous pump, increase our muscle contraction, and decrease the venous reflux. Long stretching products has a high low working pressure. That means that we need to apply more force, we need to apply more pressure, and that is going to cause pain to the patient because we are going to increase the resting pressure. And when we increase the resting pressure, that produces pain. To compress a leg vein in the upright position, a pressure between 60 to 90 millimeters of mercury is required. To achieve this pressure range by elastic material, very high values would also be needed in the resting position, which would not be tolerated by the patient. If you see in this chart, after the applying of inelastic materials, you can see that we obtain a peak pressure of 60 millimeters of mercury in resting position. In standing position, we can obtain values above 100 millimeters of mercury. After 24 hours, in the resting position, the values decrease until 20 millimeters of mercury. And in standing position, the values remains above 48%, 48 millimeters of mercury. So that's the reason why inelastic bandage are hemodynamically still effective after several days, despite the loss in resting pressure. We have to prepare our terrain, we have to prepare our ulcer, we have to do a good debriefing with enzymatic tools or physical tools. Select our material. You can use alginate, collagen, superabsorbent dressing, pad dressing. It depends of the wound. We have to hydrate the skin. It's very important to hydrate the skin if we are going to use compressions therapy for more as 3, 4, 5 days, even a week. And we can use also pad dressing to cover our bones and reduce the production of skin lesions. What are the products that I use? A multi-component system. So I use tubular bandage, I use cotton, I'll use synthetic cloths to prevent skin lesions. Then I apply the inelastic material in A technique on crossover pads techniques, and then I apply the short stretch material. There are no new products that you can use. Those products comes in 2 different versions. One is you have the first layer, a short stretching material, and you make a circle and you are in the right position. Then comes another layer, a long stretching material. It's an oval and you have to make a circle. When the circle is done, you know that you are producing 40 millimeters of mercury and you are in the right therapy. I think this type of bandage are really good for people that has less experience with the compression therapy. The only problem is the cost, and they are not available for in all the countries. In Ecuador, for example, we use at least inelastic materials, inelastic bandage, and then it depends of the cost of the patient can afford the cost. We can use the Rostidalca or we can use the normal non-stretching bandage, but we don't apply too much force in order to not increase the high resting pressure and don't generate pain for the patients. As I told you, there are a lot of different techniques that you can apply. It's very important to go to one course, to go to compression courses, and learn by doing. You have to feel it. You have to feel it. If it's too loose, if it's too strong, somebody have to make a bandage for you. You have to have the bandage in your leg, and you have to feel it, so you can experience the pressure of the bandage, and then you can talk with your patients. You can use also the pico press. The pico press is a system that measures the force, the pressure that you are applying in your bandage, and you can control. You can train with that system. It's really good because there are a lot of studies that say that many people that have experience with bandage with compression therapy are applying suboptimal or are applying less pressure that we need. So, for example, they're applying 40 or 30 millimeters of mercury, and we need 50 to 60 millimeters of mercury pressure in order to have a good therapy. So the problem is that you cannot just read and then do it. You have to go to an expert. You have to do a practice. You have to practice. You have to practice a lot, and then you can do it with your patients. So it's learning by doing. So as you see, you have a patient here with an elastic bandage. After a week, the bandage is a little bit loose. After 2 months, the ulcer is closed. We have also treated the patient with sclerotherapy foam. And in between, we use compression stocking bandage because after 1 month of treatment, the patient didn't want to use bandage anymore. And in order to have a better compliance, we use 1 week compression stocking. The first layer 10 millimeters of mercury, the second layer 20 to 30 millimeters of mercury, and the first layer is cooler, is antibacterial, and the patient can take a shower and use the compression stockings. And the next week we can use bandage again. And if we see that doesn't work, we use bandage for 2 weeks and then return to compression stockings. There are other products like compression stockings with Velcro. They are in the future, but they cost a lot, and we don't have in all the countries. But I think that's are the future bandages, because the patient can self-use and can self-adjust them, and we don't have to worry too much about those products. So thank you very much for your time, and if you have questions, I am at your disposal. Thank you.
Thank you, Ernest, and thank you for the wonderful talk. Guys, I'm just going to stop for a second here. We are running around 35 minutes late. And some talks are slightly bigger. So if you allow all, we will have only one question per talk from now, please. And so that we can move on and finish all the program on time, please. And one question for Ernest, please. Thank you, Ernesto. It was wonderful having you on as a speaker on the session here. Now we'll move on to the next talk. Dr. Varinder Singh, he's an intervention radiologist, a friend from Delhi. He's going to talk about a very, very important topic: how to perform varicocele embolization. So it's a very important topic, and we do get patients very routinely for doing this procedure.
Good evening, everybody. I'm Dr. Varinder Singh, intervention radiologist at Medanta Hospital, Gurgaon, India. First of all, I would like to thank Dr. H.S. Bedi and Dr. Rahul Jindal for organizing a virtual VICON meeting. I would be talking on stepwise approach on varicocele embolization. As we all know, varicocele is dilatation of the pampiniform venous plexus and the internal spermatic vein. It's a well-recognized cause of discomfort, heaviness, pain in the testiculo-inguinal region, and can sometimes lead to decreased testicular function, which results in infertility. The diagnosis is made clinically and by imaging, most commonly being ultrasound, Doppler. So what are the clinical signs and symptoms? Yes, patient comes with a scrotal swelling, mass. He may say there is a bag of warm feeling. He may come with symptoms of acute pain or sometimes a dull aching chronic discomfort, heaviness, pain. He may also say there is a difference in testicular size that can be well palpated by the examining doctor. And maybe an incidental finding just on a scrotal ultrasound for some other reason. There are various grading clinically as well as on Doppler. So grade 0 is subclinical varicocele. You can't detect it clinically, but can be diagnosed by ultrasound or conventional venography or CT venography. Grade 1 is palpable with Valsalva maneuver. Grade 2 easily detected without Valsalva. Grade 3 is detected visually at a distance. So as I told you how it is diagnosed, if it can't be diagnosed clinically, it has to be confirmed on ultrasound duplex, which I think is a gold standard. And rest can be seen or as a finding for some other reason, a CT or MR venography was performed. Conventional venography, these are basically not done routinely. So I would say Doppler ultrasound. So what do you see on scrotal ultrasound or a Doppler ultrasound with color allow accurate diagnosis in nearly all cases of varicocele, even subclinical varicocele, and is the imaging technique of choice. Here on the right side, you can see the hypoechoic multiple dilated pampiniform venous plexus veins on cross-section and longitudinal. And when you tell your patient to do a Valsalva, it shows a light bulb sign. So on grayscale, there is dilatation of small vessels of the pampiniform plexus greater than 2 millimeter. Doppler demonstrates retrograde flow, which is called as reflux in these veins with standing position or with just Valsalva, asking the patient to lift their neck. On spectral analysis, venous flow is directed towards the testes, which augments on increasing the abdominal pressure. So the diagnosis is pretty straightforward on Doppler. So indications for treatment before going stepwise approach, I would say presence of varicocele does not necessitate treatment. There are many patients who may have grade 1, grade 2 without symptoms, don't require treatment. Significant testicular discomfort or pain, not responding to routine symptomatic treatment, yes, they qualify. Testicular atrophy, if there's a volume difference of more than 20%, yes, the patient qualifies for treatment. Possible contribution to unexplained male infertility. So there are American Urological Association male infertility best practice policy. You can go through varicocele present, couple has documented infertility, female has normal fertility, one or more abnormal sperm or their semen parameters are abnormal. So men who have varicocele and abnormal semen analysis findings but are not currently attempting to conceive should not be offered varicocele repair. So coming to embolization, which is the main topic today. So there are many ways to skin a cat. The aim is basically to occlude or stop the reflux or divert the venous outflow. So access, I would say it's an operator dependent. You can go through IJV, through femoral vein, some prefer basilic vein from the arm. So I think it's an operator dependent. How your cath lab is oriented doesn't make a lot. Embolic agent, again, there are many ways to treat varicocele. It's the operator's training. So you can use sclerosant with coil. You can use liquid embolic agent like glue. With coil, you can use even micro plugs. Additionally, look for any underlying cause such as nutcracker syndrome or May-Thurner syndrome. So, for example, the varicocele could be secondary to underlying pathology, like there could be a compression of the renal vein, which is most commonly on the left side, which is anterior or posterior nutcracker syndrome, or could be secondary to iliac vein compression. So, before proceeding, one should be aware of all the collateral pathways. So this is very important. If you don't embolize it properly, there could be very high chance of a reflux. So one should be aware of the pelvic venous anatomy. So coming to the technique, as I told you, access either groin or neck, which is basically most preferred access sites. Catheter, again, if you are going through neck, you may have to go with a multi-purpose or some angled catheter like Wert or Picard, or which is basically hockey stick type. And when you're going through the groin, you may have to use a Cobra or just Judkins right, or you may use a renal double curve catheter. And again, depending on that, you take as the second step would be a coaxial catheter. You can go with a 5 French catheter directly, or if you're using a guiding or a long sheet, you may take a diagnostic catheter. And then some people do like to use micro catheters as well, to go as distally as possible if the vein is really tortuous. Now, once you have reached the inguinal canal and you have demonstrated a good reflux, now it's the, again, operator's choice. What would you like to do? You can use sclerosant with coil technique. So you use 2 catheter, and which I'll be demonstrating in my images. You can use endocril. So let's see. So this is from the left side. This is from the left, for the left varicocele. You have hooked your renal vein. You have demonstrated the reflux. You have taken your diagnostic catheter directly into the left somatic vein and demonstrated the reflux into the tympaniform venous plexus. And then you start coiling it from as distally possible. Try to coil all the confluence so that there is no reflux. So here you have done a coil and a glue combination. You can use a coil, and then you can use liquid embolic agent as well. You can use sclerosant. This is on the right side. Right side is not that easy, I would say, as compared to left. Finding a right gonadal vein, it may take some time. It's easier to go through the IJV access, but if you have a good hockey stick or a angled or a reverse curve catheter, then you may go through the groin as well. So the technique lies the same for embolization as on the left side. Before concluding, I would definitely like to say, just look for nutcracker syndrome. You can look for circumaortic renal vein. So these are the underlying causes. And if the symptoms don't go, patient has hematuria or hematospermato blood in his sperm. So you may have to treat these underlying causes as well. So this is pre and post Doppler. Here you can see this was pre, like bulb sign, and once the embolization is done, the results are pretty quick, and slowly the abnormal plexus gets thrombosed and there is no reflux and patient starts feeling well. So I would say the technical success, if properly done, is pretty high. The only challenge is finding the gonadal vein, and once you have done that, it's just your endovascular skill to reach the final position. Clinical success varies. I would say for infertility, the results are not very high, maybe 50 to 70%, but for pain and discomfort, especially in teenagers, the results are pretty good. I would say more than 90%. The complication rate, I would say it's basically less than 1% or probably 0 if properly done. Haven't seen any as of now. So in properly selected and screened patient, transvenous embolization is a safe and effective treatment for this varicocele. Thank you. If there's any questions, I would be happy to answer. Thank you.
Thank you, Virendra. I think Virendra could not join. He has to rush to the emergency, I think. Is there any burning question from anybody? If not, then we will move to the next topic, please. Welcome a friend, Dr. Jaza from Georgia. Another very, very important, similar to the varicocele, we are going to see how to treat and how to do an ovarian vein embolization. So, it's a different tips and tricks we have to learn from the experts. So we are going to share. So Dr. Jaza is among us, so he's going to answer your questions. Tarun, please.
Dear colleagues, First of all, I want to thank to my friend Raul and all organizing committee for such possibility to participate in this great virtual meeting. It is my great honor. The theme of my current presentation is how to perform gonadal vein embolization. I have not any disclosures. The key question for effective and safe treatment of any disease is when to treat. Until recently, unfortunately, this was no unified protocol on how to perform this procedure. Published in 2019, the consensus document of WIP about diagnosis and treatment of pelvic congestion syndrome defined the principles and criteria by which this procedure should be carried out. Please note that we must treat the patient, not the diagnostic image. Ovarian vein embolization is generally performed under local anesthesia or light sedation using fluoroscopic guidance on a radiological tilt table. Before the procedure, it is very important to instruct the patient how to do Valsalva maneuver. According to consensus document, diagnostic criteria for pelvic congestion syndrome are as follows. An ovarian vein diameter more than 6 mm with proven reflux, contrast retention more than 20 seconds, congestion of the pelvic venous plexus and or opacification of the ipsilateral or contralateral internal iliac vein, or filling of vulvovaginal and thigh varicosities. It is very important to correctly choose the access site. Internal jugular vein is preferable because of easy accessible all ovarian veins and internal iliac veins with shortest distance. Of course, ultrasound guidance is also recommended for correct catheterization of jugular vein. Basilic vein and common femoral vein also are options, but in case of excess from basilic vein, the distance are longer. As for common femoral vein, cannulation of ovarian vein are more difficult because the angles with vena cava are significantly narrow. Different materials are used depending on which approach will be chosen. I most often use an MPA catheter. Also, other types of catheters and microcatheter can be used in the femoral approach. Sandwich technique, coils plus scleroform for embolization of gonadal veins is most usable. Using of detachable coils are preferable. In case of pushable coils, oversizing up to 30% according to target vein diameter is necessary, and coil must be as long as possible with maximal number of loops for preparing by Tessari method. Treatment technique varies depending on operator preference, but in general, the entire length of the ovarian vein is treated to prevent collateralization with retroperitoneal veins and recanalization. Other embolization materials like glue, onyx, gel foam, vascular plugs can be used in selective cases. Extremely important to avoid complications because they are affected on effectiveness and safety rates, hospital stay, number of lost working days, and costs. Particular attention should be paid to the prevention of some intraprocedural complications, such as access site complications like hematoma, arteriovenous fistula, bleeding, pneumothorax, thrombosis, embolization of non-target vessel, incorrect deployment, protrusion, vein perforation, and possible allergic reaction. Just you see incorrect deployment in right gonadal vein, and therefore part of coil deployed in inferior vena cava. Possible reason is vasospasm, whose elimination is possible by the waiting 15-20 minutes or using nitroglycerin. This coil was successfully retrieved by the using of snare. Prevention of coil migration also is very important. For this reason, I recommend carefully choosing the size of coil, oversizing up to 30%, and also using one tweak. After coil deployment, move catheter distally and the next coil's first loop deploy inside the previous coil. And finally, I want to present 4 cases where performing of embolization was impossible. First and second cases presented left gonadal vein with huge tortuosity. On third case, presented thrombotic right gonadal vein with partial resolution of thrombus, and the last case with aneurysmatic changes of left gonadal vein, and there are no adequate size embolic material on the market. Thank you for attention.
Thank you, Dr. Jaza. Please, if we have any questions, we've got one question. Which embolizing agent you think will give us the best results?
About the embolization materials and the technique is sandwich technique is most usable, and I use in absolutely all standard cases. But also I have 2 cases when I use the vascular clot, and also once I used the product from Artventive company. It's also like a plug, and in normal cases, absolutely the combination of coils with the scleroform is absolutely effective.
And what percentage of STS you use?
3%. 3% is preparing the foam and use in per session not more than 10 milliliters of the.
Because you want to have a very good sclerosing, it's a very big vein, so you better to use an STD and than polytoconol, and use the best percentage, 3%. That would be the best. And another question is, which is the safest method of embolization?
What? Sorry, it's bad streaming.
Which is the safest method? Which method is the safest?
Safest method of embolization?
Yes,
what? Safest method?
Yeah.
Safest method of embolization?
Yeah.
Yeah, I think this sandwich technique we are using last 10 years, and we have not any complications of this in our experience.
Okay. Thank you, Dr. Jaza. We'll move to the next topic, please.
Okay. Thank you very much again for invitation.
Thank you. The next talk is by Dr. Rahul Jindal. Tarun, please. Dear friends, today I'm going to talk about Klippert-Trenaunay syndrome and what are the endovascular options. So we all know Klippert-Trenaunay was discovered in 1900, this entity, and it is basically associated with port wine stains with sharp borders, lymphatic anomalies, venous anomalies, hypertrophy of soft tissues and bones. The incidence is equivalent in male and females. The exact cause is unknown, though there is a gene defect which has been found in this group of patients. All races are affected. The incidence is between 2 and 5 to 100,000. You can see the sharp demarcation of the malformation, and you can also see that in some patients this is bilateral, but mostly it's limited to the midline. Venous malformation is present in 70 to 100% of the patients. It's a persistent embryonic vein, and there is aplasia and hypoplasia with valvular incompetence and varicose veins. And these venous malformation can also be present in the GIT, causing bleeding. It can also be present in bladder and vagina. The venous component, which is there, the marginal venous vein, this is located in the subcutaneous layer. So that's very important when we want to think about an endovascular repair, and it's connected with multiple perforators to the deep veins. Hematological evaluation pre-procedure is important to allow consideration of anticoagulation. These patients, they can present to you with a bleeding, or they can present to you with a venous ulceration. And in terms of investigation, clinical findings really clinch the diagnosis. You can also have an X-ray, duplex scan, and MRI to evaluate the deep veins, and the genetic test in some patients. In terms of treatment options, it's a complex disease, so there are no single treatment. Every treatment is individualized to the patient. So if the patient is asymptomatic and the varicose veins are very small, then we normally manage it conservatively. Otherwise, we try to treat it with surgical interventions. In terms of compression, you can use various compression garments and stockings to keep the veins compressed so that the patient does not have any symptoms. In terms of surgery, phlebectomies and stripping has also been described in the literature. The lateral embryonic vein is treated in some patients if they're causing the symptoms after evaluating the deep veins, and it also can be treated with an endovenous ablation. So I'm going to show you some cases. This case came to us with a bleeding on the right leg. We treated with a foam as there was no major component which has to be treated with a laser, and it gave us a very, very good results. Another case who has got a left leg KTS and present to us with a venous ulceration. So we do the clinical examination of the vein and see the facial defect. You will always be able to feel the facial defects where there is a big perforator which is causing the veins to get filled up. So what we do, we make the patient stand, we feel the defect, then we make the patient lie down, then we do the leg elevation of this patient, and I can feel these defects over there. And once I feel the defect, then I will press those defects with a hand and then do the leg elevation of the patient. I'll empty all the veins. The leg will start looking normal. And once the leg starts looking normal, I will press that walls very tightly with my hand and make the patient stand again. The reason for that is because as soon as I will make the patient stand, if I'm compressing the wall which is causing the symptoms, and then I will know that this is the culprit wall, because sometimes there are so many walls and facial defects in the leg that it's impossible to differentiate which one you want to block. So you see, I have pressed this wall near the knee, and I can see there are no veins which are filling up in the leg. So if I just treat this small wall near the knee, this patient will have an 80% relief of the reflux. So as soon as I release the wall, you can see the whole foot and the leg gets filled with the varicose vein. So this is a very, very nice examination, and you don't require anything. And actually, if the patient has got an incompetent deep veins, patient will start also getting symptoms. So this patient, you can see the photographs here, came to us with a venous ulceration, and which we treated with a laser treatment. There's another patient who had a right leg Krippel-Trenaunay syndrome with very severe leg symptoms. He's a young female, and the lateral embryonic vein was draining into the saphenofemoral junction, as you can see. So this is how we put in a 6 French sheet under ultrasound guidance, and we're using a 1470 laser fiber, and we give a lot of tumescence anesthesia because the vein is very, very close to the skin, so you can get a burns. And at the same time, what we have observed from our practice is that if we use the normal energies, which we use for the varicose vein, the veins tend to reopen. So what we use is we use 1.5 times of the normal energies what we use, and with a lot of tumescence, and we found that this has given us a very good closure. So here the laser fiber is near the saphenofemoral junction, as you can see, and we have burned the vein, and then we are given a lot of tumescence anesthesia. And you can see that all the laser ablation of the vein is done under ultrasound. Wherever the vein is aneurysmally dilated in some patients. So we give it much more higher energy and try to do a transmural burn on an ultrasound visibility. We can easily see so that we can get the maximum damage to the vein and get a very good closure. So if you look into this post closure, it's a very, very good closure, and you can hardly see any vein in the immediate post-operative period, and this gives us a very good result in the long-term follow-up. So this is a lady whom we did the ablation, and you can see the findings at 3 to 4 weeks. It gives us a very good cosmetic result, and the patient's symptoms, they normally disappear, but patient continues to wear stockings. Another case with a very huge vein, lateral embryonic, draining again into the SFJ. As you can see here, we have placed the 6-inch sheath. We are using a 1470, I think 1940 laser here in this patient. And we took the fiber up, and as the vein is very superficial, you can actually see the light of the fiber, laser fiber, and we give a lot of tumescence anesthesia. You can see the vein is very big in this patient. So it was around 22 millimeters, so we have to give it a lot of tumescence anesthesia, and because we want to use a very high energy, and the vein is very, very close to the skin, so you have to be very careful that you don't burn the skin. So we put in the firing of the laser. You can see we are using the energy what we are using here, and we are just totally trying to destroy the whole vein. Whenever you use the higher energy, sometimes the fiber tend to stick up much more than the normal energies what are described for varicose veins. So this is 1 day post-operative period. A patient is walking, we put these patients on stocking, discharge them, and we put these patients on 1 week of anticoagulation. And this really gives us a very, very good results. And you can look into this post-operative period, immediately how this patient looks like once she comes for the first follow-up. Another patient with a huge amount of dermatitis, bleeding from the knee areas, a huge amount of veins. She has multiple treatments, multiple forms sclerotherapy, but now she has come back to us 10 years later with an incompetent SFJs and a bad veins. So we have done the long saphenous vein puncture. It was not a lateral embryonic vein in this patient, so it was straightforward. And so once we have burned that, and as you can see, it gives us a very good clearance of the dermatitis and the veins and symptoms of the patient. So this is again a post-operative period, what this young girl has. So this is our experience. So around 280 patients with arterial malformations and other venous malformations, 42 patients with KTS, and similar age group. Ages are different. First 2 patients we treated with a normal energy, had a recurrence at 6 months, so we modified the protocol, and as I've already mentioned in my talk before. So we have treated around 13 patients with laser, some with foam and some with open surgery, and we got a very, very good results. So I feel KTS is a complex disease, and long-term follow-up is required of this patient. And I feel that if you choose your patient wisely, and as I shown in my protocol, if you follow it properly, endovascular route, endovascular laser is the best treatment for this group of patients, along with foam sclerotherapy. Thank you. So we can take one question because of the lack of time. Dr. Lohit Razi, please.
It's a nice talk and a nice experience, huge experience. You have talked about successfully about the superficial veins. So, but what do you think about the sciatic vein that we are finding always in these cases, and it is incontinent completely? How to deal with?
Yeah, but you see, in our clinical experience, we had, because that patient we operated last week, so we had only one patient with a huge vein in the posterior part of the thigh. But if you look into the persistent embryonic vein, most of the patients, what we have observed in our practice, the patients who are symptomatic, they don't have a problem when we block these veins. This is very in contrast to all the previous things what we have been discussing. So what we do is, I feel that clinical examination is very important, and of course a duplex scan. So there are a lot of patients where the deep veins are competent or deep veins are present, and the lateral embryonic vein is also present. So then in that cases, once you block the lateral embryonic vein, there is no issues because there is a presence of the deep vein. But we have treated one patient where the deep veins were hypoplastic, and patient had come with hugely incompetent these veins. Because the time was limited, I couldn't show you all the patients. We treated that patient. What we did was we pressed the main valve, because there are multiple incompetent valves. If you see these patients on ultrasound, it's not only one valve which is incompetent, there are multiple incompetent valves. So we find the main valve which is causing the symptoms of the patient, by which we can reduce, we can make the patient better. We find that valve on the clinical examination. There is no other way you can find it up. And I keep on pressing that for 3 to 5 minutes and see if the patient does get any worsening of the pain or symptoms on standing. And sometimes we are tired to tourniquet there and make the patient walk for a minute or so. And if the patient does not get any symptoms, then we do that laser of that area, a particular area. We don't try to get a closure of all the perforators which are there in this patient. So we just try to do the limited procedure which will make the life of the patient better.
Thank you.
Okay, we move on to the next lecture, please. I'm really sorry, we are short of time. Dr. George Rios from Argentina, he's president of the Society of Vascular Diseases from Rio Cuarto, is going to speak on a very important topic, popliteal fossa. All the vascular surgeons, venous surgeons, you need to know the anatomy of the popliteal fossa. So we thought, this will be a very, very interesting topic to discuss. Thank you, Professor George.
Del doctor Bedi y Hindal, autoridades de la Asociación Venosa de la India, por este importante evento de difundir la educación flebológica. El tema a tratar es anatomía ecográfica de la fosa poplitea, una zona un poco olvidada. La zona poplitea es una zona que se encuentra localizada en la parte posterior de la rodilla, tiene la forma romboidal y está limitada hacia arriba por un triángulo en el cual su límite interno está formado por el músculo semitendinoso, semimembranoso, hacia afuera por el músculo bíceps y hacia abajo, hacia el lado medial, por la cabeza medial del músculo gemelo interno y hacia afuera por la cabeza lateral del músculo gemelo externo. El piso de la fosa poplitea está cubierto por el músculo popliteo y tiene un techo que está formado por la aponeurosis muscular del miembro inferior. Esta es una estrecha fosa donde tiene un contenido vascular y nervioso, el cual comprende desde la superficie a la profundidad el nervio ciático, en el cual en este espacio vamos a tener la raíz de la división del nervio ciático, que es el nervio tibial, más hacia la profundidad la vena poplitea y en la profundidad la arteria poplitea. Esta región presenta varias variaciones anatómicas debido a su origen embriológico. Por esta razón es una zona de muchas patologías, tanto patologías locales como patologías derivadas de otra región que impactan en este sector. Esta fosa es muy poco investigada y está en íntima conexión con la gran vena safena. Esta es una imagen de la zona donde se encuentra ubicada la fosa poplitea. Acá en esta lámina tenemos cómo se representa en la parte superior del rombo popliteo la división del nervio ciático, en su rama tibial y su rama peronea, la vena poplitea y la arteria poplitea. Este es un preparado anatómico de un cadáver fresco donde vemos el nervio ciático, que acá podemos observar el nervio tibial y hacia afuera el nervio peroneo. Habiendo ya limpiado la parte nerviosa, podemos ver la vena poplitea, la cabeza externa del gemelo y la cabeza interna del gemelo, donde desembocan en la vena poplitea la vena del gemelo externo y la vena del gemelo interno, la cual va un poco por encima del anterior y es de mayor calibre, ya que este músculo presenta un mayor desarrollo que el gemelo externo. En la anatomía ecográfica, ¿qué vamos a observar? Desde la superficie a la profundidad hacia afuera, en un plano transverso, vamos a observar el nervio peroneo común y más en la parte central, por encima de la vena poplitea y por debajo de la vena safena menor, el nervio ciático popliteo interno, o también llamado nervio tibial. Acá en esta imagen, en un corte transversal en colores, podemos observar desde la superficie a la profundidad la vena safena menor, la vena poplitea y la arteria poplitea. Y en este corte longitudinal observamos cómo corre en la profundidad la arteria poplitea, y hacia arriba podemos ver la vena poplitea y corriendo por encima de dicha vena en forma longitudinal el nervio tibial. ¿Qué vamos a observar también en la fosa poplitea, yendo un poco más hacia el lado del pie, o sea, hacia la región distal? Vamos a observar las venas gemelares, que se observan como dos espacios negros, ubicado en la parte central, la arteria del gemelo. Acá la podemos observar en colores, y en un corte longitudinal podemos observar la desembocadura de la vena safena menor en el rombo popliteo con su prolongación cefálica de la vena safena menor, o extensión del muslo de la vena safena, que acá se une a una vena gemelar en un tronco común para ir a desembocar en la vena poplitea. Fíjense en esta imagen, esta paciente, como estamos haciendo un corte transversal, y la vena poplitea se ve aplanada como si estuviera enferma. Acá en estos casos es importante hacer al paciente que haga una ligera flexión, y fíjense en cómo la vena poplitea se ve de mayor diámetro sin patología alguna. Esto es importante para no confundir o hacer un mal diagnóstico como que la vena poplitea no se encuentra o que se encuentra trombosada. Por eso es muy importante, siempre que no la veamos, hacerle flexionar ligeramente la rodilla al paciente. ¿Cuáles son las patologías que podemos encontrar? Y la insuficiencia de la vena safena menor, este paciente presenta una úlcera con un gran trastorno trófico, donde la vena safena mayor es normal, pero observen unas tributarias que se dirigen hacia la vena safena mayor y que proceden de la vena safena menor. Acá observamos una gran vena safena menor insuficiente con tributarias que salen de la misma para dirigirse al aspecto antero-interno de la pierna. También en la zona poplitea vamos a encontrar masas, que el paciente va a consultar por presencia de masas en la región poplitea o bien en la región superior de la pierna. En este caso, esta gran masa poplitea es debido a una perforante de la fosa poplitea insuficiente que es transformada en forma neurismática, en lo cual su flujo se dirige hacia la vena safena menor, haciendo la misma insuficiente. Otra de las consultas también es la presencia de masas, como dijimos anteriormente. En este caso no es debido a origen venoso, sino es un aneurisma de la arteria poplitea, como lo podemos observar, que mide 3,46 de diámetro transverso por 3,88 por diámetro anteroposterior. Para corroborar se hizo una angiotomografía donde observamos la gran masa que corresponde a la parte arterial. También otras estructuras importantes que vamos a encontrar en la zona del rombo popliteo son los quistes de Baker, que es bastante frecuente, siempre lo vamos a encontrar en la parte interna y generalmente tiene un cuello, un cuerpo y una extremidad posterior redondeada. El cuello sale entre la cabeza del gemelo interno y el músculo semitendinoso. Suele ser bien ecogénico, o a veces suele presentar material denso en su interior, como en este caso. Esta imagen corresponde a una paciente que consulta por gran dolor en la pantorrilla con tensión del músculo gemelo interno. Se le hizo un eco Doppler donde en la zona transversa se observa un quiste de Baker de pequeño tamaño, pero sí se observa un gran hematoma en el gemelo interno. Eso es importante para hacer diagnóstico diferencial con trombosis venosa profunda que esté comprometida la vena poplitea y no hacer una terapéutica equivocada, ya que si lo anticoaguláramos a este paciente estaríamos incurriendo en un grave error terapéutico. Conclusión: explorar la fosa poplitea siempre será incluida en todos los estudios de los miembros inferiores, por más que el paciente nos presente patología en la cara anterior o en el territorio de la vena safena mayor. La vena safena menor es un sistema que generalmente está conectado con la gran vena safena y con las perforantes pélvicas. Muchas veces la insuficiencia en la región de la safena menor no procede de la unión safenopoplitea, sino que viene desde perforantes pélvicas como son la pudenda interna o la glútea inferior, o bien a través de las circunflejas posteriores o de la vena de Giacomini. Esto es debido al desarrollo embriológico, con lo cual existe una gran variabilidad de la vía venosa, y es también ver patología no venosa, como dijimos, de los quistes de Baker o los aneurismas en la región poplitea. Muchas gracias por su atención y los dejo con algunos paisajes de nuestra Argentina.
Thank you, Professor George. Professor, you are online with us. If there is any questions, if you can take up that question, please. We can allow one.
Ahí está, Víctor. Yes.
Any questions, please? Okay. Thank you, Professor George, for a wonderful lecture.
Okay,
and now we'll move to the next lecture, please, by Dr. Sanjeev Lakhanpal. As you know, Dr. Sanjeev is President and CEO for Center for Brain Restoration from USA, and he's going to talk about iliac vein evaluation and IVUS and venograms and stenting. Welcome, Dr. Sanjeev Lakhanpal, and thank you for joining.
Hi guys, thank you very much for this honor of presenting at the Biocon 2021. My name is Sanjeev Lakhanpal, and my topic for the day is how I do it pertaining to iliac vein stenting. I'm a bleeding Indian American and represent the organization called Center for Vein Restoration and Center for Vascular Medicine. Center for Vein Restoration recently hit a landmark 100 centers in the United States because of an amazing group of physicians who you see here. And today I present the work of these physicians. So what I intend to cover today is quickly talk about patient selection and how do we confirm that these patients have the disease that we're trying to treat. And then most of my talk today will be about the procedure, how we do a venogram, intravascular ultrasound, how we place our stents, how we size our stents, and then a quick consideration about postoperative issues. So talking quickly about symptoms. So either you can have symptoms just limited to the pelvis, and those would be symptoms of pelvic congestion syndrome, or you could have symptoms when the pelvic hypertension is leaking into the legs. That's when you would have symptoms of CVI in the lower extremities, and I'm sure you all know plenty about that, but without symptoms, the patient has no reason to be on your operating table. Just the presence of a lesion does not justify treatment of that lesion. Our group looked into a cohort as to who are the patients who have leg symptoms versus pelvic symptoms. As people mature in age, we see more and more symptoms on the leg side, and early on you see symptoms more in the pelvis only. How do we diagnose these patients? Again, number one, symptomatology. Once the symptomatology is there, we do a surface ultrasound. We do not typically do CTs or MRIs for these patients. It's the surface ultrasound that tells us whether the lesion is there or not. At times, those lesions are hard to see. Other important reasons to do the surface ultrasound is to look at the directionality of flow in the ovarian veins. However, it is critical that you also rule out any other coexisting pathologies in the pelvis before you take the patient to surgery. So now we have a patient with symptoms who has come to the operating room. One of the key things first we do is a pelvic venogram, and we access both groins with 10 French sheets, very slowly inject the contrast. We try to limit the amount of contrast. Our patients are awake during this procedure. We may give them a little bit of sedation, but we can We can talk to these patients well during this. And as you see in this venogram, you don't see any cross-pelvic collaterals. Venogram could just be taken as something that is normal, but the intravascular ultrasound is critical here. You see the inferior vena cava, and as we are pulling the IVUS catheter down, here you start seeing the compression. This is the right common iliac artery crossing over the left common iliac vein here. And here, this is where you see the compression. The point I'd like to make here is at times you may feel this outer edge leads you to believe that it's a long, compressed common iliac vein, but that is not the case. As this diagram by Dr. Raju clearly demonstrates, that you're not seeing a cut straight through here. One edge of your IVUS catheter is getting the inferior vena cava here, hence giving you the false impression that the narrowing is not as bad as it seems. So you got to be very careful about that as you're assessing the common iliac vein. Then here you got the common iliac artery now on the left side, and it is looking at the common iliac vein. And then here the common iliac artery divides into the internal iliac and the external iliac. The common iliac vein is still the entire common iliac vein. And very soon you will see the common iliac vein also. You got the external iliac and the internal iliac getting together. And finally, you got the common iliac vein. So what you see here is a left common iliac vein compression. Now, if the patient has the right symptoms, which we don't have the time to go into today, but if the patient has the right symptoms and a significant lesion, that's when you go ahead and treat. What size are you going to treat these patients to? Again, going back to Dr. Raju, he's given us these size criteria where you've got to, again, stick to, you get to 125 millimeters in the common femoral, 150 and 200 millimeters in the common iliac vein. You get to those size criteria. This is what the compression looks like if you want to look at it from a diagram. Here again, we are talking about, so this patient has a left common iliac vein compression. At times we choose just to do a venoplasty. You would do a venoplasty if you're using this as a therapeutic test, or some patients who have bad nickel allergies. We use de novo stents, and the purpose to use a de novo stent, it's a barge stent, is the precision of where you can deploy the stent. You look at this, if you look at the stent placement here, it goes right at the takeoff of the common iliac vein, and that's really what we want to do. The various choices of stents right now are given in this slide. Again, we have experience with wall stents that we used to use in the past, and de novo stents now. The Vichy stent is also getting a fair amount of traction here in the United States. Why not continue to use the wall stent? This is a prime example. You get the fish mouthing here, and again, we must have deployed over 1,500 wall stents. This was rare, but when it would happen, it would be a tough thing for the patient. The other thing with the wall stent is that you would always have to deploy the wall stent partly in the inferior vena cava, as is visible here, and that would lead to a lot of issues by itself. And now with the presence of stents that can be deployed with more precision, it is kind of redundant to deploy something else. Perioperative concerns you need to be careful about is anticoagulation. For the thrombotics, it's easy. You put them on lifelong anticoagulation. But for non-thrombotics, it's still a controversy. We've put out a couple of papers for that. One comparing different kinds of anticoagulants, that it really doesn't make a difference. And the second one was whether the anticoagulant makes a difference at all. And we found in the post-operative in-stent restenosis rates, it really does not make a difference. We still use them, so it's your call. Other perioperative concern is back pain. We typically use 14 to 16 millimeter stents. In 14 in a smaller person, 16 in an average sized person. We go to 18 to 20 if you've got a basketball player or a football player to do so. But patients will have post-operative pain. You should warn them about that ahead of time so that when they have pain, they are not surprised by that. Treatment is just supportive, and the pain goes away in about 48 hours or so. Some patients 24 hours, rarely it may last longer than that. So in conclusion, I'd like to state that this therapy is real. Please use it only for patients who are really symptomatic. And it's, again, I would like to always, whenever talking about deep venous disease, express our gratitude to Dr. Raju, who's taught us so much about this. Thank you very much again for the opportunity, guys. Dr. Bedi, Dr. Jindal, everybody else at Biocon. Miss you guys. Would love to have been there in person, but hopefully next year. Thank you very much.
Rahul, we've just got a message that Sanjeev is probably tied down with some emergency case, but his colleagues, Professor Nick and Dr. Khan, are there.
Dr. Khan is there. Yeah.
Nick
So
is
we can
also
take
there.
one question, please. If there is any burning question. Or Dr. Jadhav, please. Hello. Dr. Lohit Razi. Dr. Lohit Razi, please.
Yes, we are talking of symptoms, and we are treating only symptomatic patients, sure. But our idea about symptoms has changed just 2 years as we are treating male pelvic congestion syndrome. It is not only leg pain and pelvic pain and dyspareunia. Now we know that the pelvic congestion syndrome can cause a lot of symptoms, as back pain, sciatic pain, reopening, hemorrhoids, impotence, infertility, urinary tract compression. So our idea about symptoms now is more large, and our indication are more important. So we are treating patients that we haven't things to treat before.
Nick, did you want to take that, Nick, or did you want me to take that?
You can go ahead, Ken.
Yeah, no, it's you're absolutely right on that, and that's why it's so important that we use all of the specialists to rule out all of the other causes of the symptoms you're describing. The worst thing that we can do is to do a procedure on somebody and have them come back and say that, you know what, my sciatic pain is still there, my urinary symptoms are still there. So important. You're absolutely right. The symptoms have to match up, and we have to rule out all of the other causes of these symptoms before we move forward to this to this procedure.
And another question, Dr. Khan, while you're there, another question from Dr. Jaza is, which stent will you prefer for non-thrombotic obstruction?
You know, that's not something that I typically do. So Dr. Lockenpaul probably is going to be the right person to ask on that. I don't do the procedure personally.
Okay. No issues at all. And we will move, and thank you, Dr. Khan and Dr. Sanjeev Lakhanpal. We'll move to the next topic from Professor Nick Morrison. He's here on the panel. Thank you, Nick, for joining. And
thank you for having me.
Thank you.
Well, good morning, or afternoon, or evening, or midnight as it is for me. I'm Nick Morrison. I'd like to speak to you about foam sclerotherapy for varicose veins and venous malformations in the U.S. That's a nice shot of the Grand Canyon in my home state of Arizona. There is a nice hike that you can go down and out. It's about 1,500 meters down and the same coming back out over a 29-kilometer distance. So I absolutely have not recommended to do it in one day, although there are members of the audience who have already done that, exactly that. These are saguaro cacti, and lest anybody thinks that Arizona is nothing but cactus and desert, that's a nice ski area up in the northern part of the state at about 3,500 meters. Okay, so in the States we do have the choice of using either physician compounded foam, homemade foam, or commercial foam. Decisions we make are, do we want to use the foam at all? And most of us do. If I'm using foam, am I satisfied with the safety and efficacy? Or do I want to switch to a commercial foam? If so, what are the advantages and disadvantages? And does it have regulatory approval? Now, the commercial foam, called Varithena, is indicated for the treatment of incompetent truncal saphenous veins above and below the knee tributaries. Now, they have proven efficacy compared to a placebo over 8 weeks, clearly superior to the placebo. And this VANISH-2 trial concluded that the treatment with this foam, polydocanol endovenous microfoam, or PEM, led to durable, clinically meaningful, and ongoing improvements at 1 year from varicose vein symptoms and appearance. This is another study where they looked at the stability of foam, and what they were determined was that the commercial foam was significantly more stable than a physician compounded foam. And then just by way of, this is Yamaki study that he did about a decade ago, where he looked at the difference between small volume, highly frequent injections versus large volume, less frequent injections. And he came to the conclusion that small volume, more frequent injections were clearly superior in terms of success rate and side effects. Now, this is a slide prepared by the BTG company. Up in the upper right, that's 100% CO2 foam. You can see in a minute that it degrades really pretty quickly. And then the room air will start in that upper right. There's the installation, and it degrades, but fairly quickly, but not nearly as quickly as the 100% CO2. And then, of course, at the bottom is the Varithena foam, and that's very slow to degrade. So the commercial foam had a lower degradation rate than the homemade foam, so a longer dwell time and more contact with the vein wall, so this resulted in better overall performance. Now, the safety trials with the commercial foam, they did 12 trials involving over 1,300 patients looking for adverse events. Here you can see a list of them. There were no clinically evident PEs or cerebrovascular events. DVT rate was 4.2%, although over half of those were thrombus extensions and not the same as a routine DVT. As far as neurologic or visual adverse events, 2.7% of the patients who got Varithena experienced one of these, while 4% of the placebo group also got them. So these are very non-specific, and then they took a group of 80 patients, 60 of whom had a documented right to left shunt, and studied them very carefully. They hospitalized the patients, did MRIs before and after of the brain, neurologic studies, and cardiac enzymes, and their conclusion was that there was no evidence of cerebral or cardiac microinfarctions in any of those patients, including all of the ones with the right to left shunt. So to date, there have been no reports in the world literature of serious neurologic events such as TIA or CVA using this commercial foam. Now, in the States, we do have our own guidelines submitted by the various societies. They are very similar to the European guidelines, and so I won't go to those in great detail. But I would like to point out that in the U.S. there are package inserts in both the polydocanol and the sotradecol, which clearly state that the foam created with room air, the safety and efficacy has not been established, and its use should be avoided. That puts us in a very bad spot with this in the package insert if there's an adverse event and a medical legal action. As far as cost, there's a distinct difference. The cost of the canister, 45 ml canister of the commercial foam costs about $3,200 or $71 per cc, plus an administration pack. The cost in the treatment for a full leg treatment of 8 to 15 cc's will cost between $600 and $1,000, and distal truncal treatment will be anywhere from $250 to $355. Now, the wrinkle is now insurance and Medicare does reimburse for the microfoam. So the commercial rate, the Medicare rate, as you can see, for multiple veins injected is $1,500 for the commercial foam, and for homemade foam, it's $172. A dramatic difference, which is really shifting use. Now I want to talk a little bit about foam sclerotherapy for venous malformations, and that's another shot of the Grand Canyon. That is, I believe, the South Kaibab Trail, and that looks like that's Eberhard looking for Felicitas. Stepwise look at patients with venous malformation starts obviously with a physical examination. You're looking for pulsatility or audible bruise, bluish discoloration, the characteristic of a venous malformation, or lymphatic, has a rubber consistency, and has localized lymphedema. Next step is a duplex ultrasound to identify the flow characteristics, to be sure that there isn't an arterial component. Look for the extent of the malformation, proximity to adjacent structures, and particularly the drainage pattern, because that's what's changing things a bit. Then an MRI or MRA to fully identify the full extent, and then direct puncture phlebography. If you look for the drainage patterns, if it's essentially normal drainage patterns, your cure rate will be fairly high and the complications will be quite low. On the other hand, if there's dysplastic or ectatic drainage, the cure rate goes down and the complications go up. And finally, treatment, surgical excision confined to truncular lesions. Sclerotherapy can be used, ethanol to a certain extent, but more and more people are using the detergent sclerosants foamed because of fewer complications. Combined approach, sometimes people will look for those drainage patterns and use something like glue to eliminate the drainage pattern, which allows for longer dwell times. Now, that's a case study of a 32-year-old patient with a congenital venous malformation. On ultrasound, it looks like that, and then on direct stick phlebography, there is the extent of the lesion, again there, and before and after 3 rounds of sclerotherapy, so it is certainly diminishing in size. Now, I mentioned some of the other ways. This is a laser approach, so they're using laser to eliminate these venous malformations, perhaps along with some foam sclerotherapy. And this is something called a STACE technique, which involves using adhesives, coils, heat, something to close the outflow tract, and then foam sclerotherapy. So there's a much longer dwell time. That's it. Thank you very much for your attention, and have a great rest of the conference.
Thank you, Nick, for a wonderful talk. And please, any questions? We got one question from Dr. Lovell. When do you use physician compounded foam versus commercial made foam? How do you decide which one to use?
It's a very simple answer. It's an economic answer. Both are very effective. However, as you saw, the difference in reimbursement is dramatic. And so if the commercial payer will pay for the commercial foam, I'll use that. If they don't, I use my own foam.
Thank you. For the time, can we just move on? I'm really sorry because we are running late. Thank you, Nick. And I'd like to invite Dr. Khan. He's from Vein Restoration Clinics from USA. Tarun, can you change the slide, please? Dr. Khan, he works along with Dr. Sanjeev Lakhanpal and Dr. Nick Morrison, and we would like to invite him to talk about how I do it Medtronic glue in varicose veins.
Hello, my name is Khan Nguyen. I'd like to thank everybody for giving me the opportunity to speak today. Just a little bit about my background, experience, and my disclosures. I am board certified in emergency medicine, and I have been in practice since 2003. Completed my residency in Detroit, Michigan. I'm currently an associate clinical professor at Georgetown University School of Medicine, and I joined the Center for Vein Restoration in 2009, currently the chief medical officer. We have 100 locations across the US with over 60 physicians. I have personally performed over 25,000 patient encounters as well as procedures, and since being a part of CVR. I'm a diplomat of the American Board of Venous and Lymphatic Medicine and currently serve on the advocacy committee of the AVLS. I have no disclosures or conflicts. My topic this morning is how do I perform my VenaSeal procedures? As you all know, VenaSeal is a non-thermal, non-tumescent, non-sclerosant medical adhesive that is used to treat venous insufficiency, particularly the truncal veins of the saphenous system. Some of the clinical considerations that I think about for this procedure are the fact that there's no need for post-procedure compression. It is a non-thermal technique, so there's no risk for nerve and tissue damage, and there's no need for tumescent. This amounts to much less bruising and pain, and there's a rapid return to normal activity. One of the negatives to this procedure is that it's considered an implant, but I also think that one of the positives to this procedure is that it's an implant. We will get into that in just a little bit. In addition, according to the literature, there's approximately a 10% hypersensitivity reaction that occurs for some patients. But I have found that initially this may be true, but after making some minor adjustments, the reaction is much less than 10% if you don't close the last segment of the vein and don't withdraw the catheter outside the lumen. I believe this prevents sensitizing the surrounding tissues to the adhesive. That being said, I still think that for patients that have a propensity for allergies to medications, I usually offer them another modality. I also think about whether I can pass a catheter through the vessel. If it is extremely tortuous, it may not be the right procedure. And then from a business consideration, the vast majority of my patients are insured, and 40% of them have Medicare, which is, in my area, the only current payer that allows VenaSeal. This, however, is rapidly changing. I believe that the benefits of the procedure are easy to discuss with my patients. The hardest things to discuss are the potential negatives. I usually tell them that cyanoacrylate has been used in medicine for over 70 years. There's never been a correlation with it being carcinogenic. There are antimicrobial properties to the medical adhesive which prevents it from getting infected. And although it is considered an implant, I do tell my patients that it does break down over time and eventually does dissolve over the course of several years. Because it does stay in the body for so long, I think it is extremely durable and has a very long-term success rate when it comes to closures. I also let them know that the amount of adhesive is extremely small, probably less than 2 to 3 milliliters for a typical procedure. And the glue that's in your leg is going to be extremely soft and elastic, so they won't feel it or know that it's even there in most instances. Here's a picture of the device. We start by accessing the GSV and inserting an introducer catheter using the Seldinger technique. I place the adhesive catheter 5 centimeters from the saphenofemoral junction and place the patient in Trendelenburg to empty out the vein. I usually do this for all my ablations, whether it's VenaSeal or any other technique. We then compress the proximal segment to the catheter and inject the glue. The first segment is done with a 1 centimeter pullback and with an additional aliquot glue and then held for 3 minutes. After this initial segment, the remaining segments are closed and compressed with a 30-second hold with a 3 centimeter pullback. And then for larger diameter aneurysmal segments, I usually will administer an additional aliquot of adhesive, and you do that as needed. Here's an animation of the closure. We'll kind of just show you the basic steps. Again, a picture of the device itself and the glue. Here it's showing the actual access. Thread the guide wire all the way to the junction and place the introducer catheter over the guide wire, making sure to pull the introducer catheter back 5 centimeters. Next, the glue catheter is being inserted through the introducer. And again, we're making sure that we are 5 centimeters from the tip of the glue catheter now to the junction. Here we're looking to find the tip of the catheter. We're going to go just proximal to that and compress. And there's the installation of the glue, pulled back for 1 centimeter, and then pulled back for the remaining 3 centimeters. This is repeated over the next 3 centimeter segments using a 30-second hold. And again, the key here is to place the patient in Trendelenburg. And then the other key is to make sure that you don't close the final segment of the vein itself. So that way you make sure not to extravasate any of the glue outside of the vein, which causes the sensitization. The picture on the left is a longitudinal view of the field in a sealed catheter with a administration of the adhesive. You can see a slight swelling of the proximal segment of the vein indicating injection of the glue. The picture on the right is a transverse view of the catheter tip, which shows an echogenic stellate appearance to help you identify the tip. So to review, we want to follow the IFUs. We want to empty the vein and tilt the patient back in Trendelenburg. For larger segments of the vein, you want to administer additional adhesive. You want to refrain from closing the last segment of the vein before withdrawing the catheter to prevent hypersensitivity reactions. And finally, you want to choose your patients very carefully and explain the risk and procedures, as well as the benefits very accurately. Thank you very much for your time today.
Thank you, Dr. Khan. Please, any questions? We can take one question, please.
Dr. Khan, we have used the glue in a few cases, and we have had some of them get a reaction and sometimes needed to remove the glue with a small surgical nick. So is that common with the VenaSeal?
I've never had to remove the glue, but usually when you do get these hypersensitivity reactions, they usually respond very well to NSAIDs, so a few days worth of NSAIDs. And to be honest with you, sometimes what I do is I will actually tell my patients just to proactively take 400 milligrams of ibuprofen on the day of the procedure and then do it every 8 hours for 2 or 3 days. And that seems to reduce the reaction even from occurring from the very beginning. And then for severe reactions, if I'm going to go ahead and make an IND or remove the glue itself, I probably will at least try some steroids, some oral steroids first. And then if that doesn't work, then consideration for an IND.
Okay.
And how do you choose between laser and glue? Which patients to take for glue and which patients to take for laser?
The benefits of a non-thermal technique are really to prevent significant nerve and tissue damage. And if I'm going to, if I have the ability to use a non-thermal technique, I'm always going to choose a non-thermal technique over a thermal technique. And again, just like Nick said, it really comes down to commercial payers. The non-thermal technique just provides just much better patient satisfaction. We have good long-term 5-year closure rates for these techniques now. And if there's significant tissue damage, skin changes, ulcers, especially near the ankle, a non-thermal technique is going to be the best opportunity. In our practice, we use laser really for short segment, large diameter vessels. And then for any long vessels, we typically use RF or non-thermal techniques just because the amount of pain and ecchymosis after the procedure is so much less.
Thank you, Dr. Khan, for joining us, and it's been a wonderful session. And thank you to all the ladies and the speakers. We'll move to the next very important session of lymphedema. I'd like to invite Dr. Gogia. He's the president of Indian Society of Hepatology. Dr. Rajesh Hyderabadi from India. Dr. Vivek Kumar Singh, VK Singh from India. Dr. Ankur Agarwal is also a vascular surgeon from India. Dr. Arvind Kohli from Jammu from India. Dr. Tapesh Sahu from India. And Dr. Murli Krishna from India. And Dr. Sarvanan Robinson from India. Thank you for joining here. And we got very important 4 lectures. And the first lecture is by Dr. Alessandro. And you will listen to this lecture. It's very important. And he is the director of the Colombian School of Lymphology.
Good afternoon to everyone. I will share my presentation. Thanks to Dr. Harinder Singh Bedi and Rahul Jindal. And cordial greeting to Dr. Malay Patel for the invitation for the 14th annual conference of the Venous Association of India to present our experience in the management of lymphedema treatment under the context how I do it. I live in Bucaramanga, Colombia, in the northwest of South America. We work at Foscal International Medical Complex, made up of Foscal Clinic, Foscal International Clinic, and Medical Campus of the Anatomos University of Bucaramanga. I work as Vascular Surgery Service and Lymphedema Clinic Chief Coordinator, and as a professor of vascular surgery in the medicine program at the Bucaramanga's Autonomous University. We provide the lymphology service in the lymphedema clinic through the Colombian School of Lymphology, ECL. We provide in healthcare and academic file as well. In academics, we give a postgraduate program on the physical therapy techniques for the lymphedema treatment. Our work is certified by the Bucaramanga's Autonomous University and other universities and medical societies in different Latin American countries. To establish the management of protocols for patients with lymphedema in ECL, we take into account the concepts of existing national and international consensus and guidelines to establish our own protocol. We began to establish an accurate diagnosis of lymphatic pathology. First, excluding differential diagnosis, and second, the diagnostic is based on the etiology and the state of evolution and the level in involvement of the limb. When we need to supplement the studies in patients with lymphedema in special cases to determine a specific cause and to get the best diagnosis, we have lymphogammography, lymphoangiography, and lymphoscintigraphy MAT-CT in the near future with lymphofluorescence with indocyanine green. Once of the diagnosis is established, is presented to the medical ward in the lymphedema clinic to establish the management protocol according to the clinical chart under the concept the transdisciplinary lymphedema treatment, which include physical therapy, pharmacology, electrocompression, multidisciplinary treatment, surgery, and follow-up. In the physical therapy, we consider the complex descongestive therapy, CET, with 4 basic elements: relaxation and breathing exercise, manual lymphatic drainage. We use inelastic or very short stretch bandage under the concept of multi-layer bandage, therapeutic bandage class 3 and 3C and 3D, biokinetic exercise. As complementary techniques are currently being use different devices, which are not yet consensual, such as deep oscillation, ultrasound, shock waves, radiofocal, and taping, which can be used in 3 ways: derivative, contentive, as we use it in the service, or therapeutic, which is under discussion. Once the lymphedema is compensated, or in the remission period, or maintenance phase, or when the use of multi-layer bandage is suspended, we go to containment phase with the compression elements, slips for the upper limb of different brands, stock, pressure gradient stocking, class 3 or class 4, or the use of double stocking in the same limb. Other system that can be used is contentive, not yet consensual, and Velcro system, which are about 10 different brands in the market, but the problem is the high cost for Latin American countries. The taping is the same, and the difficult to use the derivative and contentive in the maintenance phase associated with support stocking. The fundamental of the lymphedema transdisciplinary treatment is the multidisciplinary management, where specialists from other associated pathologies, all with knowledge of lymphatic disease, participate in the lymphedema's comorbidities and active participation in the therapeutic process. Basically, these specialties are internal medicine or vascular medicine, a specialty approved in Colombia, psychology for direct support to the patient as a human being and his family, foot and ankle surgery, subspecialist orthopedist, dermatology, and nutrition, metabolic control, and the relationship with exercise. Surgery of the lymphatic system with a great boom in recent years must be performed by a surgeon, vascularoplastic with great experience, expertise, in order not to obtain results as I showed you. This is a resective surgery and lymph node transplantation performed 3 years ago in Colombia. Monitoring and scheduled medical control is another pillar of the evolution of the lymphedema patient, taking into the account that is a present pathology with easy reactivation and or no complete resolution. The periodic medical evolution protocolized is essential since each patient is different. This is an example for lymphedema secondary to C6. Clinical cases and the response, therapeutic response. 1, secondary lymphedema post-treatment to cervix cancer, stage 3, fibrosis, level 5. Number 2 is another post-treatment secondary lymphedema of the cervix cancer, stage 4, fibrosclerosis, level 4. And number 3, trauma secondary lymphedema from femur surgery in paraplegic patient, stage 2, level 3. In conclusion, we have a lot to do for patients for lymphedema, and we must be prepared to help them have an excellent quality of life over time. Thank you very much for your attention. You are welcome to the lands of Santander, a fraternal greeting from Colombia.
Thank you, Alejandro. What I'm thinking is we can take 2 talks together because they are sort of overlapping by Dr. Maria and Dr. Alejandro. Dr. Alejandro, if you're okay, if we have the talk of Dr. Maria also and Dr. Luis also, because they're all related to bandaging and taping, so that we can have a combined discussion at the end. Is it okay? Thank you. And can we have Dr. Maria's slide, please, on the board? And this is, I'm doing it because we're running late because of the delay in the first session, because of the technical issues. Sorry about that. Dr. Maria Isabel, she's from Colombia, and she is going to, let us know how she does the lymphedema bandage to get the best results.
Muy buenos días, yo soy la doctora María Isabel Lozano, directora de la Fundación Reina Isabel.
Good morning, I am Dr. María Isabel Lozano, director of the clinic Reina Isabel.
Hoy quiero mostrarles la preparación del vendaje multicapas en pacientes con linfedema.
Today, I would like to present to you a multi-layer bandage in patients with lymphedema.
Cuando vamos a colocar un vendaje multicapas, debemos estar muy seguros que el paciente no tenga una enfermedad arterial oclusiva crónica asociada.
When we are going to perform a bandage procedure in patients with lymphedema, we have to make sure that the patient doesn't have a chronic arterial occlusive disease or any other complication.
Y por eso tenemos que estar muy seguros de los pulsos a nivel distal, que tengamos un índice tobillo-brazo que nos permita hacer un buen vendaje.
And this is the reason why we have to make sure that we check the ankle brachial index, and also we have to make sure of how their peripheral pulses are.
Es por esto que nos ofrecen hacer un vendaje multicapas elaborado por nosotros mismos, o la industria farmacéutica también ofrece vendajes para que el paciente mismo los pueda colocar, y estos vendajes vienen ya con el gradiente de presión establecida.
And this is the reason why we have two options of bandaging. One that it's provided by the industry, and one option that it's to perform the bandage by ourselves. And also we have to keep in mind that these bandages have already the accurate gradient.
Y es así, cuando elaboramos nuestro vendaje multicapas, simplemente tenemos que tener un sitio adecuado, el cual, como lo pueden observar a ustedes aquí, no es un sitio que requiera demasiada extensión, es un sitio pequeño, pero que cumpla con todos los protocolos para poder colocar o elaborar un buen vendaje multicapas.
It is very important to keep in mind that to perform an accurate bandage, we need a proper site. As you can see, you don't need a lot of space, but you need a site that is provided with what we need.
Es por eso que quiero mostrarles también aquí los diferentes insumos que necesitamos para elaborar un buen vendaje multicapas. Pueden observar, aquí tenemos solución salina, compresas, cremas hidratantes, corticosteroides tópicos, apósitos primarios, algodón laminado, vendas de corto estiramiento, cobán, espuma, microporo, bota de una y un zapato adecuado.
And here, I would like to show to you some of the medical supplies that are needed to do our bandaging. We need saline solution, compresses, moisturizing creams, topical corticosteroid, primary and secondary bandage, cotton bandage, short stretch elastic bandage, Coban self-adhering wrap, foam bandage, micropore, surgical tape, Eunice boot, and suitable shoe.
Es importante también, cuando vamos a colocar un vendaje multicapas, estemos con un colega o con un personal de la salud adecuadamente, que hagamos prácticamente un equipo para poder hacer un buen vendaje multicapas.
It is important that when we perform our bandaging, to have the help of a person that can assist us, of someone who is able to perform the bandaging with us.
Es tan importante colocar un vendaje como quitar un vendaje.
It is very important to place an accurate bandaging, but also it is important to perform an accurate removal of the bandage.
Aquí debemos lavar la extremidad bien adecuada, la limpieza, cosa que es muy importante.
It is very important to do correct washing of the extremity.
Igualmente hacemos un buen secado, sobre todo en los interdígitos de los dedos, para evitar alguna humedad.
It's also very important to pay attention to the drying process, and we need to make sure that we dry between the toes because they can keep humidity.
Importante también es hidratar la piel. Aquel paciente que tiene linfedema, hay que hacer una buena hidratación.
Also, it is very important the moisturizing procedure. we need to apply a moisturizing lotion in the extremity.
Luego colocamos un apósito primario.
Then we continue by applying an adhesive bandage.
El algodón laminado que debe ser colocado de distal a proximal.
Then we continue with the placement of the cotton bandage that should be placed from distal to proximal.
Una vez ya colocado el algodón de distal a proximal, procedemos a colocar el cobán en los dedos.
Once we finish with the placing of the cotton bandage, we continue with the cotton self-adhering rough placement, being very careful with the toes.
Pueden observar ustedes aquí cómo queda el cobán colocado.
And you can observe here how the cobán is placed.
Luego colocamos la goma espuma para dar simetría a la extremidad.
Then we continue with the foam placement, and this is very important to provide symmetry to the extremity.
Aquí colocamos luego ya las vendas de corto estiramiento de distal a proximal.
Then we proceed with the placement of the short stretch elastic bandages from distal to proximal.
Una vez ya colocado el número de vendas, dependiendo del gradiente de presión, debemos utilizar un calzado adecuado.
Once we finish with the bandage and it has the accurate gradient pressure, we proceed by placement the suitable shoe.
Quiero mostrarles aquí los casos a continuación.
I would like to present here some of our cases.
Pacientes con enfermedad venosa y con linfedema, podemos colocar vendajes en su capa.
With lymphedema and with venous disease can actually be receiving a treatment with a multi-layer bandage.
Igualmente, estos son nuestros casos. Aquí quiero compartir con ustedes cómo damos calidad de vida a estos pacientes.
Here I would like to share with you some of the cases and to show you how we can offer a better quality of life to our patients.
Es así como las conclusiones son muy importantes en que esta patología tan difícil de manejar, pero podemos dar calidad de vida con vendajes multicapas.
This is a very difficult pathology to treat, but we can offer, and we are offering quality of life to our patients. And this is very important to us.
Nuevamente nuevos casos y calidad de vida que es lo que nuestro paciente necesita.
Again, new cases and providing quality of life, that's what patients need.
Muchas gracias.
Thank you very much.
Thank you, Dr. Maria, for joining us all the way from Colombia. And we will now take up another lecture from Dr. Luis, and then we will take up all the questions together. Is it okay? Dr. Luis, he's the president of the Bolivian Scientific Community of Phlebology and Lymphology, and he's going to speak on lymphatic drainage and kinesiotaping.
Hello everyone, this is Dr. Luis Arias from Bolivia and Mexico. The topic I'd like to talk today is about lymphedema. Great. Lymphedema is defined as an abnormal increased protein-rich fluid in the interstitial space due to an alteration in the transport capacity of the lymphatic system. The lymphatics of the lower and lumbo-aortic extremities converge in the cistern of the xylem packet, from which the thoracic ducts emerge, leading on the left jugosubclavian confluence, where the lymph in the left half in the head of neck, left hemithorax, and left upper limb also converge. We have here a picture that shows us how the capillary is in between capillary venous and arterial capillary, and both has confluences to the lymphatic capillary, and where they start the lymphatic precollector. Under normal conditions, the transport capacity of the lymphatic system is more than 10 liters, which can be increased 20 to 21 liters if the situation requires it. When necessary compensation mechanisms are set in motion, collateral lymphatic pathways, lymphopatic and lymphovenous anastomosis. However, the increase in the diameter of the vessel leads to valve insufficiency, which worsens the transport capacity. The lymphatic system has two functions: an immunological one of transporting antigens from the tissues to the lymph organs to produce the immune reactions, and another one, extravascular homeostasis, by reabsorbing and returning to the bloodstream protein bodies and plasma protein that are continuously leaving the blood capillaries to the interstitium. The treatment of lymphedema is almost exclusively based on rehabilitation measures. Control sites to evaluate the evolution: lymphatic drainage pumps, sequential pressure chambers. Lymphedema pharmacology: limit the work overload, preventing fluid from leaking out of the blood capillary, to help evacuate the retained water by reducing the oncotic pressure linked to the accumulated proteins. Prevention: creams, antiseptic agents, fungicides, benzopyrones for topical and oral use, etc. Treatment: diuretics, immunotherapy, benzopyrones. Immunological therapy: injection of lymphocytes, BCG immune vaccine by scarification. And we use also, it's a very interesting tool, is kinesiotape. Kinesiotape is a bandage that does not require prompt removal, since it depends the care. It can remain useful from 3 to 7 days. The color influences its function, promotes blood flow, sedative effect, anti-inflammatory, tonic or relaxing effect. Longitudinal elasticity 30 till 50%, similar to skin. Thickness and weight similar to the skin. At the head, to paper with 10 till 15% stretch and water resistant. Kinesiotape increase the temperature, warm colors, yellow, pink, and black. Disminui the temperature, make lower, cold colors, green, blue. Simulating colors, yellow, pink, and sedative colors is blue and green. Kinesiotape's function: keep cold or heat, provides muscle support, eliminates pain, increases inflammatory process, decreases edema and lymphedema. Physiological effects: trauma, inflammatory process, generates pain, increase the pressure of the tissue, they make circulatory changes, evacuation lymphatic, and the pressure, increase the pressure by the nociceptors. Other functions: 1, improve muscle function. 2, maintain the function of the injured ligament. 3, joint alignment. 4, increase spaces. 5, improve lymphatic drainage. 6. Improve fibrosis, scars, and hematomas. 7. Improve organic or segmental function. 8. Cross-taping. Forms of application. They are different techniques and forms. It depends on the part of the body that we have to use. A lymphatic taping simulates the elimination of liquids, fannet of octopus technique based of about 3 centimeters without stretching. The tape is applied without stretching from proximal to distal stretching to skin. Is applied against the direction of flow. And once again, it's very good for me. I'm feeling family, stay back with Bicon 21. Regards to Dr. Shoaib Padaria, Rahul Jindal, the shark, regards to also Dr. Harinder Singh. See you.
Thank you, Luis. And we will go to the last lecture by Dr. Oscar Bottini from South America, Argentina. And he's going to speak on massive localized lymphedema and morbid obesity. And then we can take up all the lectures together for the questions, please. Dr. Oscar cannot join us because he's slightly off the internet at present.
I thank the authorities of the Congress for allowing me to participate in such an important event. Described by Farship and Weiss in 1998, the massive localized lymphedema in the morbidly obese patient is a rare pathology with an increase in cases in recent years due to the advance of the surgical treatment of obesity, which tries to solve a problem in patients before evicted. Observe that in the first years, only 23 cases published in the bibliography were found. However, it increased in the last years, where only one center showed 46 cases in 13 years. In spite of this, it remains a rare frequent entity. They are lymphomatous tumor lesion, benign, voluminous, and located in a specific area, hyperobesity being a common factor to all patients. The objective of the presentation is to show the importance of the massive lymphedema and the committed lymphatic flow in the therapeutic sequence. Observe the increase of the body mass index and the weight of the tumor mass, generally associated with comorbidities. Lymphomatous tumor shows maceration and ulceration of the skin and induration and edema of the subcutaneous cellular tissue. Although the diagnosis is clinical, lymphography and MRI can be requested. The medical treatment consists of treatment of edema with compression, manual and postural lymphatic drainage. And skin care. Surgical treatment consists of resection of the tumor mass. The microscopic characteristics are hyperparakeratosis, hypertrophic epidermis, dermis edema, hypodermis fibrosis, lymphangiectasias, which inflammatory infiltrate without signs of malignancy, although it has been described associated with Kaposi sarcoma. The result is definitive, because the derivative lymphatic flows are not affected, the lymph always finding an escape route. It is complemented then with the treatment of obesity. In the sequence, first the treatment of the massive localized lymphedema and then the obesity. Massive localized lymphedema in the lower limbs, after studying the venous system and lymphatic, always requires medical treatment with a skin care and the drainage of the lymphomatome mass to allow better walking. Together with the medical treatment of hyperobesity and psychological support, after which we proceed to the surgical treatment of obesity, and a significant weight decrease is expected for the surgical resolution of the inflammatory tumor. The sequence will then be reversed to the previous. First, surgical treatment of obesity, followed by the treatment of the lymphomatous mass. In this case, the failure of the psychological support results in the recurrence of the hyperobesity. There is the importance of the multidisciplinary support. Summarizing, when the affection occupies the upper body, the tumor mass should always be resolved first and then obesity. But if the affection is in the lower limbs, involving the normal drainage of the lymphatic flows, the obesity must be treated first because the weight loss will allow a better compressive management of the lower limb in the post-operative term. Thank you for your attention.
Thank you, Professor Oscar, for a very nice lecture. And now the things are open for discussion. We have Dr. Gogia here. Dr. Gogia, and if you want to ask any questions, please, you can ask. Please ask slowly because Dr. Maria and Dr. Alessandro, they are from Spanish speaking.
So thank you for thank you for inviting me for this August session, and I'm glad to hear all the talks. The first two were excellent, and they provided an overview. Of course, Dr. Luis then talked about kinesiotaping, and these two cases which were shown for massive lymphedema, they were good, excellent cases, and he pointed out some of the things which I wanted to ask for the first speakers. The role of infection. How often do you see infection in your patients, in your these things? And also, like Dr. Maria talked about, cleaning and drying the limb, which is very, very important for managing the limb. But we find in India, at least, many cases having fungus also. That mention has not been done. And how often do you find infection in your patients? Thirdly, just related to that is, you said that you put tape first after putting a moisturizer. Does the moisturizer help stop the taping in some way, or does it interfere a little or not?
I'd like to answer this question. Dr. Shashi Goya. In my experience, we have the procedures for kinesiotaping we do in the office. We make extremely careful antiseptic. We make clean for a surgery, clean, and after we have everything ready, we put a lot of alcohol. When it's a lot of humidity, it is more easier to use the kinesiotape. And we have the view every week, and we ask the patient take a shower every day. And it's not a big deal. I do kinesiotaping after over 10 years already. I never have an infection or fungus problem. Maybe in India, it is more common because the people
walk without shoes or has contact with animals. We are strictly talking with the people, be away from the animals because it is more possibility to have a fungus.
No, I was asking because like Dr. Maria said that we put a moisturizer. Doesn't the moisturizer, you put alcohol, that will be a reason. So do you do that also, Dr. Maria? Do you put some alcohol to allow the taping to take place when you're putting directly on the skin? Outside the band is understood.
Luis, can you convert the question in Spanish if it's possible?
Yes, María, quiere saber si tú también utilizas alcohol para ayudarte a pegar el kinesiotape y si es que has tenido problemas con infecciones u hongos.
Okay. I'm going to have an interpreter. I don't speak English very well, okay? Entonces, no uso alcohol. I don't use alcohol. Prefiero lavar muy bien. I prefer to wash very well. Con solución salina, with saline solution, más ácido acético, plus acetic acid. Porque si pongo alcohol, because if I use alcohol, los pacientes con linfedema tienen la piel muy deshidratada.
Patients with lymphedema present a very dehydrated skin.
Entonces prefiero lavar con este tipo de solución.
So in this case, this is the reason why I prefer to wash with this type of solution.
Y secar muy bien
and dry very well,
ya que la humedad,
since humidity,
es un factor de riesgo para la aparición de hongos.
For fungus appearing.
Logro después humectar muy bien.
Then I moisturize very well.
Con cremas que tengan urea al 10%.
With 10% urea lotions.
Ya que estos vendajes, la extremidad se ocluye y cada semana se retira.
Since it's very important to pay attention to the extremity and to do the follow-up because each week we remove those bandages.
Porque nuestro sistema de salud no permite el cambio de vendaje 2 veces por semana.
Because our health system doesn't allow us to remove the bandages twice a week. So we have to do it every week.
Thank you.
Thank you. Excellently answered, first of all. Also, now the next question is for Maria. How often do you see fungal infection in the webs and how often do you get erysipelas, infective episodes?
María, ¿quieren saber la frecuencia que has tenido infecciones de hongo y con qué frecuencia has tenido una secuela de erisipela?
Generalmente es muy frecuente la aparición de erisipelas en pacientes linfedematosos.
It's very often to find erysipelas in patients with lymphedema.
Porque la hipertensión linfática es un factor de riesgo.
Because the hypertension is a risk factor.
Para la aparición de procesos infecciosos. Y esto empeora
for the appearance of infection, and this makes it worse.
La patología linfática.
The lymphatic pathology.
Dr. Gogia, any questions to Dr. Alessandro, please?
No, exactly, it was similar because they were from the same unit. And Dr. Alessandro presented very nicely the patients that he has done some good results. And we look forward to interact more on these because we also have some similar results. But somehow I feel that their patients are slightly different. Exactly the same thing I wanted to ask him also. How much do you treat for infection, which is a major problem that we find? And what antibiotics do you use?
Dr. Alessandro, if you can unmute, please.
Okay, thank you, Jubal. The lymphangitis in Colombia or Latin America is a lot of because the immunity of the skin is low, yeah, and all the leg is supposed to do infection in lymphangitis. Talking about the taping, I see the skin needs to dry to put the taping. no with alcohol, no with the cremas, only is skin white. The color is important because it doesn't have anything significant in the technical treatment. The color is not important in the very concept.
Okay, thank you. Any questions from the audience? Anybody else?
Thank you, Dr. Gogia, for interacting. And thank you, Dr. Maria, Dr. Alessandro, Dr. Oscar, and all the panelists for joining the program. And now we will end this session, please. We are a bit late. And I will give the mic to Dr. H.S. Bedi and Dr. Roy Varghese to pass the closing remarks. And I think Dr. Padaria is not here with us. So Dr. Roy Varghese and Dr. H.S. Bedi, please.
Roy, are you there?
Sir, I can't see him, so I don't think he's.
So thank you, Rahul. That was a fantastic start. And we really enjoyed right from the first session. New sort of procedures like the HIFU from Mark Whitley, steam ablation. These are some things which are pushing the envelope. And beside that, we had people like Shoaib and Dhanesh and Deepak who told us what is the best way of doing the conventional therapies. And Dr. Rashad, Dr. Bozort, Dr. Victor. So we've really had a who's who of phlebology. Then we had Dr. Imad Hussain, Dr. Sergio, and our own Wasila Taha, Aman Fakri, and something new we learned from Jill Shapira. So these are really articles of topics, and we've really enjoyed. I think we've all learned a lot, and we go home wiser, definitely. And so we get together tomorrow at 4 p.m. Is that correct?
Yeah. So, the nursing session is starting at 3 p.m. In virtual hall 2, presenting the public papers. And then the main session starts at 4 o'clock, and we will start with deep venous interventions. So we got all the best in the world to speak on this, and we're going to discuss that different sort of deep venous intervention covering the whole practical aspects, ethically, how to do it. And another thing is, I really like to thank all the judges, panelists, speakers, to be here home. It's a without you guys, this meeting would not have been successful. And I really like to thank Tarun, who is the IT guy, and he's trying to coordinate. Thank you, Tarun, for coordinating all the talks and all. I really appreciate you getting the talks at the last minute, and you are and setting it up. It's very difficult. We have been requesting people to send the talks as soon as possible. And thank you all the companies, especially Surya, for supporting the cause of education and the Venous Association of India. They have been really helpful. Without them, we would not have been able to do this this meeting. And I think we can close the session, sir. And just for the people, we got a GBM tomorrow, and we also got one lecture, especially for you guys, on air guns. Besides vascular surgery, so we are going to have a small lecture on air guns, which you can buy. Maybe not in America, but outside America, it's very difficult to buy guns. So at least you will have some knowledge about air guns, which you can buy and enjoy them. Thank you.
Thank you, sir.